India's Next Sushruta.
Physicians and surgeons in India are among the best in the world, but we do need larger numbers of qualified physicians and surgeons in India for achieving healthcare outcomes and to take healthcare further together. India's Next Sushruta is an initiative by Medtronic to nurture and develop young surgeons.
As Medtronic, the largest medical device company in the world, I guess there is a serious commitment that we have towards improving quality of education.
India's Next Sushruta is a unique program wherein best of medical minds have been competing over last 1 year.
Congratulations to all of you, the top 10 winners of India's Next Sushruta. What an amazing journey this has been.
This is fantastic.
Most eminent and celebrated jury.
India is having immense disease burden, and India looks forward to have you in its force to relieve this burden. Thank you for all the hard work you have done till now, and congratulations for making it till this stage. Thank you and all the best.
All the best.
Learn from all the experts and actually be juried by the top surgeons of India.
I am sure it would have been a tough, intense competition between best of the minds.
Top 3 winners will have the chance to win 2-week international clinical immersion.
Congratulations to all the finalists.
You're on the lookout
For India's Next Sushruta.
Are you the one? All the very best to the finalists.
India's Next Sushruta.
Physicians and surgeons in India are among the best in the world, but we do need larger numbers of qualified physicians and surgeons in India for achieving healthcare outcomes and to take healthcare further together. India's Next Sushruta is an initiative by Medtronic to nurture and develop young surgeons.
As Medtronic, the largest medical device company in the world, I guess there is a serious commitment that we have towards improving quality of education.
India's Next Sushruta is a unique program wherein best of medical minds have been competing over last 1 year.
Congratulations to all of you, the top 10 winners of India's Next Sushruta. What an amazing journey this has been.
This is fantastic.
Most eminent and celebrated jury.
India is having immense disease burden, and India looks forward to have you in its force to relieve this burden. Thank you for all the hard work you have done till now, and congratulations for making it till this stage. Thank you and all the best.
All the best.
Learn from all the experts and actually be juried by the top surgeons of India.
I am sure it would have been a tough, intense competition between best of the minds.
Top 3 winners will have the chance to win 2-week international clinical immersion.
Congratulations to all the finalists. You're on the lookout
For India's Next Sushruta.
Are you the one? All the very best to the finalists.
India's Next Sushruta.
Physicians and surgeons in India are among the best in the world. We do need larger numbers of qualified physicians and surgeons in India for achieving healthcare outcomes and to take healthcare further together. India's Next Sushruta is an initiative by Medtronic to nurture and develop young surgeons.
As Medtronic, the largest medical device company in the world, I guess there is a serious commitment that we have towards improving quality of education.
India's Next Sushruta is a unique program wherein best of medical minds have been competing over last 1 year.
Congratulations to all of you, the top 10 winners of India's Next Sushruta. What an amazing journey this has been.
This is fantastic.
Most eminent and celebrated jury.
India is having immense disease burden, and India looks forward to have you in its force to relieve this burden. Thank you for all the hard work you have done till now, and congratulations for making it till this stage. Thank you and all the best.
All the best.
Learn from all the experts and actually be juried by the top surgeons of India.
I am sure it would have been a tough, intense competition between best of the minds.
Top 3 winners will have the chance to win 2-week international clinical immersion.
Congratulations to all the finalists. You're on the lookout
For India's Next Sushruta.
Are you the one? All the very best to the finalists.
India's Next Sushruta.
Physicians and surgeons in India are among the best in the world, but we do need larger numbers of qualified physicians and surgeons in India for achieving healthier outcomes and to take healthcare further together. India's Next Sushruta is an initiative by Medtronic to nurture and develop young surgeons.
As Medtronic, the largest medical device company in the world, I guess there is a serious commitment that we have towards improving quality of education.
India's Next Sushruta is a unique program wherein best of medical minds have been competing over last 1 year.
Congratulations to all of you, the top 10 winners of India's Next Sushruta. What an amazing journey this has been.
This is fantastic.
Most eminent and celebrated jury.
India is having immense disease burden, and India looks forward to have you in its force to relieve this burden. Thank you for all the hard work you have done till now, and congratulations for making it till this stage. Thank you and all the best.
All the best.
Learn from all the experts and actually be juried by the top surgeons of India.
I am sure it would have been a tough, intense competition between best of the minds.
Top 3 winners will have the chance to win 2-week international clinical immersion.
Congratulations to all the finalists. You're on the lookout
For India's Next Sushruta.
Are you the one? All the very best to the finalists.
India's Next Sushruta.
Physicians and surgeons in India are among the best in the world, but we do need larger numbers of qualified physicians and surgeons in India for achieving healthcare outcomes and to take healthcare further together. India's Next Sushruta is an initiative by Medtronic to nurture and develop young surgeons.
As Medtronic, the largest medical device company in the world, I guess there is a serious commitment that we have towards improving quality of education.
India's Next Sushruta is a unique program wherein best of medical minds have been competing over last 1 year.
Congratulations to all of you, the top 10 winners of India's Next Sushruta. What an amazing journey this has been.
This is fantastic.
Most eminent and celebrated jury.
India is having immense disease burden, and India looks forward to have you in its force to relieve this burden. Thank you for all the hard work you have done till now, and congratulations for making it till this stage. Thank you and all the best.
All the best.
Learn from all the experts and actually be juried by the top surgeons of India.
I am sure it would have been a tough, intense competition between best of the minds.
Top 3 winners will have the chance to win 2-week international clinical immersion.
Congratulations to all the finalists. You're on the lookout
For India's Next Sushruta.
Are you the one? All the very best to the finalists.
Two, one, live.
A very good morning to one and all. A very, very, very warm welcome to you all for the grand finale of India's Next Sushruta. Medtronic, in association with Docplexus, presents India's Next Sushruta, an academic contest with an international clinical immersion opportunity for the postgraduates and super specialty students in the field of surgery. A total of 4 rounds, with 3 rounds of academic quizzes and abstract submission already over, we are now in the grand finale round of case presentations. With over 1,300 plus participants, our experienced jury panel has picked a brainy lot of 10 finalists for the grand finale. Witness the best of brains from India's premier medical institutes competing for the title of India's Next Sushruta. Now, I would like to invite Mr. Madan Krishnan, Vice President and Managing Director, Medtronic India, to open the event. Please, sir, if you can go on with the opening address.
Thank you. Good morning to everyone. Really happy to be here to inaugurate the grand finale of India's Next Sushruta. I'm really honored to be a part of this venture, to support the initiative, to support balance in surgery and super specialty students to become the future of surgery, to take India surgical outcomes to greater heights. I'm also thankful to our esteemed panel of jury members, starting with Dr. Abhay Dalvi, Dr. Anil Agarwal, Dr. S.V.S. Deo, Dr. Avanish Saklani, Dr. Madhavananda Kar, and Dr. S. Sudhindran for taking the valuable time to come here, participate as esteemed jury members for the India's Next Sushruta finale, and also supporting us and guiding us throughout the process of this initiative. I really am indebted to you, and your support and mentoring is crucial for the budding surgeons in India to attain world fame and to attain the best in capability and expertise. Medtronic has always stood to develop capabilities and to bring cutting-edge, latest, innovative technologies to the market. Right from introduction of lead battery powered pacemakers 70 years ago, which was introduced by our founder Earl Barkin, to multiple advances in surgical and implanted product technology. Medtronic has always stood for innovation and better outcomes. But none of our innovations are valuable if valued surgeons and physicians like you, do not take it to the right patient, to the right outcome. So we are indebted to you, to the surgeon community, physician community, for all that we are able to achieve. India has among the best physicians and surgeons in the world, and I think the world acclaim that each and every one of the jury members have achieved, and the other surgeon fraternity have achieved, is a great example of that. But we need significantly larger numbers of healthcare professionals, and the shortage of qualified surgeons, physicians is significantly high. That's why Medtronic has structured an initiative of identifying India's Next Sushruta along with Docplexus to ensure that budding surgeons find a platform to showcase, to hone their skills of presentation, hone their skills of communicating their ideas effectively, getting the mentoring and support from the esteemed heads of department and the seniors in their own hospitals, and also at a national level from the esteemed jury. We'll ensure that all the participants and the winners are supported and nurtured. The winners of the grand round will get international ability to get into international observerships and training, which is going to be a great boost their career, distinguished career that they're going to have. I'm sure, and I'll ensure that Medtronic supports each and every one of the participants through their growth into esteemed surgeons, which they are capable of, and they've shown their interest in developing themselves, which is essential, the first step to develop. And I'm indebted to the surgeon community all around India, to the teams who have participated in this, to the Docplexus, esteemed colleagues from the Docplexus team, and to the members once again. And let's move to find India's next Sushruta. I wish each and every one of you success and all the very best. And thank you for all that you do to the health and positive outcomes in health for India. A healthy India, a successful India, and taking healthcare further together is Medtronic's motto. Thank you and Jai Hind.
Thank you so much, sir, for that opening address. I'm sure with your vision and the talent and skill of our young surgeons and our experienced jury surgeons, will take India ahead and in the road of a healthy healthcare system. Moving on, with over 1,000 plus entries, the program involved intense evaluation, and all this would not have been possible without our experienced jury panel. I deem it a privilege to introduce our esteemed jury panel to you. Beginning with, we have Professor Dr. Abhay Dalvi, Professor and Unit Head, Department of Surgery, King Edward Memorial KEM Hospital, Mumbai. I welcome you, sir. Next, we have Professor Dr. Anil Agrawal, Director, Professor and Head, Department of Gastrointestinal Surgery, Govind Balla Pant Hospital, Delhi. Heartiest welcome, sir. Moving on, we have Professor Dr. S.V.S. Dio, Professor and Head, Surgical Oncology, All India Institute of Medical Science, AIIMS, Delhi. Warm welcome, sir. Our next jury member is Dr. Avinash Saklani, Associate Professor, Robotic Lead, Colorectal, Tata Memorial Center, Mumbai. I welcome you, sir. Moving on to our next jury member for the day, Professor Dr. Madhavanand Kar, Professor and Head, Department of Surgical Oncology, All India Institute of Medical Science, AIIMS, Bhubaneswar. Happy to have you here, sir. Last but not the least, we have with us Professor Dr. S. Sudhindran, Professor and Chief Transplant Surgeon, Department of Gastrointestinal Surgery, Amrita Institute of Medical Sciences, Kochi. I welcome you here, sir. On behalf of Medtronic and Docplexus, I would like to thank our honorable jury members for taking time off their busy schedules to join us here today. Finally, I welcome you all with a hearty welcome to you all. Moving on, so we move to the most important part of today's event, the case presentations. I would like to brief the finalists and our viewers about the event structure now. The 10 presentations for the day have been divided into 2 segments, with 5 presentations per segment, followed by a Q&A session with the jury members. Each presenter will be given a time span of 20 minutes for the presentation. After all the presentations are over, there will be a break, followed by jury feedback segment. The final awarding ceremony will happen at 4 o'clock in the evening, that's 4 p.m., followed by closing remarks by Mr. Prashant Krishnan, Senior Director Surgical, PMA and ENT Therapy Business, Medtronic, India. So after being the rules and the event structure laid out, let's move to the main event of the day, the case presentations. We are on the lookout for India's next Sushruta. All the best, dear finalists. So, starting with, I would like to invite Dr. Naveen Kumar from AIIMS, New Delhi. Please, Dr. Naveen Kumar, take the stage away.
Hello, everyone. So, at the outset, I would like to thank Medtronic and Docplexus for providing me the opportunity. And my topic is a prospective interventional study evaluating awareness and knowledge about genetic aspects of breast cancer in low, middle-income countries. So, before going to the topic, I would talk about something. It's my thesis topic, and I have done thesis on this topic. So, my chief guide is Dr. Professor S.B.S. Dev, who is a professor and a head of Department of AIIMS, New Delhi, and NCI Jhajjar. So, coming to introduction, familial breast cancer and hereditary breast cancer constitute 20 to 30% and 5 to 10% of all newly diagnosed breast cancer patients. Management of hereditary breast cancer and familial breast cancer require genetic counseling, mutation testing, and risk reduction strategy, which mandates awareness and participation in decision making by the patient. So, after all, the decision making is for the patient and by the patient. So, literacy rates, as we all know, literacy rates are very low in India as compared to the Western countries. On an average, literacy rate is 76% in India, and compared to US, it is 99%. So, the literacy rate is low in contrast to the Western societies. Hence, separate studies to gauge awareness and acceptance of genetic counseling and testing is mandatory. So, what is the purpose of this study? So, this study is to ascertain how much of our study population, breast cancer patients, knows about the breast cancer, its genetics, and their attitude towards genetic testing, proposed intervention, and its acceptance in order to develop targeted educational and healthcare strategies. So, basically, it's a completely a new thing regarding the breast cancer patients for the genetic aspects. Like if the awareness level is adequate, they can make decision properly. So this study is focused on the awareness level, basically. So coming to material and methods, so it's questionnaire-based prospective interventional study, and this study was approved by Institutional Ethics Committee of AIIMS New Delhi with reference number 182/10th May 2018. So total patients, 175 patients were enrolled, and the sample size calculation was done with the help of biostatistician Dr. S.N. Dwivedi. So total number of patients has been 175, and its study period was from May 2018 to December 2019. So the consecutive breast cancer patients were registered in the BCC breast cancer clinic in our OPD on bi-weekly basis, and these patients were taken in the study after proper informed consent. So this study was done in 3 phases. First is pre-interventional study assessment. So what is this? It's a basic knowledge, basic level of the patients regarding the awareness level and knowledge of the about the breast cancer. So it's questionnaire-based assessment of the patient regarding awareness and knowledge. Second study phase is genetic testing, educational intervention, and it's basically a small conversation between me, like the thesis doing thesis candidate, and the enrolled patients. So 1 to 5 patients were addressed in a single session of 10 to 20 minutes in OPD, and every patient provided with educational material. So I will discuss the what educational material I have provided to these patients. So it's like a pamphlet forms, 2 pages printed form. So first I explained about the all information verbally, and then also give the this pamphlet form, printed form, educational material to the patient or attendant. If the patient is illiterate, then attendant who are like reading in Hindi or English language as convenient to the patient, I provided them. So explain it's basically explained about the breast cancer etiology, risk factors, screening, treatment, genetic aspects, BRCA testing, and prophylactic intervention. So last phase is post-intervention assessment. So patients are reassessed using the same questionnaire. Were reassessed using the same questionnaire 5 to 7 days after the genetic testing education. So after that, we know how much patients have gathered the knowledge about that topic. So questionnaires are basically based on demographics, basic knowledge about the breast cancer, knowledge of hereditary, familial, and sporadic breast cancer, interest in genetic testing, breast cancer risk perception, like willingness of for genetic testing for self and family both, and willingness for prophylactic intervention like surveillance, chemo prevention, or surgical prevention for self or family, other family members. So awareness was measured in dichotomous manner, yes or no, or ordinal manner. So it's completely subjective, and it's graded like low, moderate, or high, based on the subjective assessment of the investigator. So in this picture, we can see the snapshot of the one patient who which were enrolled in this study, and in which all the demographics on the first page we can see the demographics of that patient. Pre-intervention questionnaire. This questionnaire is on 4 divided topics, like knowledge of the breast cancer, knowledge of hereditary breast cancer risk, willingness for genetic test, and finally intervention. The same questionnaire were repeated after giving the educational material. So post-intervention questionnaire are the same, except the demographics level, because demographics are not going to change. So after that, we can I compare these two with the statistical method. So this is the educational intervention. It is written in Hindi or English, depending on the patient choice or understanding of language. So like 2 pages, first I explained in verbal manner and then in printed form as well. So how I analyzed? So a statistical test used was Stewart-Maxwell test of marginal homogeneity. So this test determines the homogeneity of qualitative varieties. So to identically distributed questions are evaluated by this method. So it's modification of McNamara test. And chi-square test was used for comparison between the 2 groups, like familiar and sporadic groups. And level of significance was taken at 5%. Means if the value is less than 0.05, it is considered as significant. So coming to results, so total 175 patients were recruited in the study, of whom 150 patients were sporadic and 25 were familiar or hereditary. So the demographic variables are described like, so mean age of diagnosis was 46 years, mean age of menarche was 13.4 years, age of first live birth is approximately 22 years. So it's on an average same in a sporadic and familiar group. So educational point of view, it's very contrasting in compared to the other countries, other Western countries. So we can see 60% of patients, 60% of patients were only educated till 10th. Like here, we can see uneducated, out of which 15% patients were uneducated. They don't know writing or reading anything. So only 40% were above 10th level. So it's the patient profile in AIMS, like other government hospitals, it's like 2/3 patients are 10th standard or below 10th standards. So coming to marital status, 96% patients were married, and patients, 91% patients were multiparous or uniparous. 9% patients were having no kids, out of which these are unmarried, and some patients are were having no kids. So coming to breastfeeding, 85% patients in this cohort had history of breastfeeding. They fed their kids, and work status wise, 84% patients were homemaker. So like the patient profile, it's low, middle socioeconomic status patients were more common in our cohort. So coming to history of breast cancer screening, it's only 5% patients out of the whole, only 9 patients had undergone breast cancer screening, out of which 8 patients were from the whole cohort who have undergone for breast cancer screening. 12% patient of the familial breast cancer patients have undergone breast cancer screening before coming to our hospital. Like 3 patients from the 20 out of 25 patients have history of breast cancer screening by mammography. So the response of the patient to the questionnaire and the effects of educational intervention has been analyzed, and it is like, so first question was, how much have you heard or read about the breast cancer? So here we can see the pre-intervention group, 87% patients have low level of awareness, but after intervention it shifted from 87 to 77%, and the moderate level of awareness has been increased from 11% to 20%. So it shows positive change, and it's significant positive change. So second question, what you know about breast cancer screening? So here again, the breast cancer screening very only, I think only 2 to 10% have very they say like, yes, we know screening, and it can be done with mammography like this. So 90% patients have very low level of awareness level, but after intervention it changes from 2% in moderate level to 37%. So it again shows positive change of approximately 0.0 p-value less than 0.001. So third question, what you know about the treatment of breast cancer? It's again its general aspects, like treatment of breast cancer. Nil means they don't know anything. Something low means they don't, yes, some surgery or some chemotherapy is known, but high level, like they know what is MRM, what is VCS, like this. So high level of awareness has been increased from 28% to 62% after intervention. So it's again showing a significant value, and its approximately change is 82%, and it's quite significant. So coming to the next question, what are the sources of information? So again, most of the patients says breast cancer expert have given the knowledge about the breast cancer etiology or pathogenesis or treatment modalities or diagnostic modalities. So most of them are say that yes, they have got knowledge from breast cancer expert. So, do you know about familial or hereditary breast cancer patient? So again, they don't know because they have a very low interaction, and most of the answer that this is the first time in our family that we have such type of disease. So only 14% say they do know about the familial or hereditary breast cancer. But yes, after intervention, it increases from 14 to 74%. So positive change is 60%, and it's quite significant. So next question to the is, do you know about other family members? So members could be affected. So again, it's significant percentage has been changed from 14% to 70%, and it's again is quite significant value. So again, the question about the BRCA testing, like have you heard or read about genetic breast cancer or BRCA? So pre-intervention, only 2% patient know about the BRCA testing. But after that intervention, 14% patients know, yes, some BRCA gene are there which are responsible for the breast cancer or other syndromic disease. So it's again showing that education material, by giving education material, the improvement in knowledge is significant. So a few more questions, like do you know in hereditary breast cancer, BRCA, the risk of developing breast cancer to the siblings or daughter is higher? Then again, it's significant from 10% to 60% try, 62% try. And the question is, do you know about the genetic testing and the sample required for genetic testing? Again, awareness level is quite low before educational intervention, 6%, and after intervention is 65%. So these values are significantly high. So now the interest, like willingness for genetic testing. So question is, are you interested in genetic testing for yourself? Willingness is just 32%. So first of all, they are concerned about the treatment part. But after intervention, some of the patients changed their mind and said, yes, we want testing also if they are provided free of cost. So it's 38%. So its rise is 6%. It's again significant. Are you interested in genetic testing of your family? Willingness level is 26% before intervention, and rise is 12% after intervention. So awareness level regarding prophylactic intervention, it's 10% before intervention, and after educational intervention, it's 55%. So it's again prophylactic treatment modality wise, it's again significant value. Willingness for self-prophylactic intervention, it's pre-intervention, it's 22%. Pre-educational intervention, 22%. After educational intervention, it's 60%. So it's change of 38%. So for prophylactic intervention regarding siblings or family members, it's quite significant. As the knowledge has increased, this shows more interest for the willingness for prophylactic intervention. So interest shows for different prophylactic intervention like surveillance, chemoprophylaxis, or surgical intervention. Here the important thing is, surveillance wise, most of the patients initially don't know anything, so they say only 24% are ready for surveillance. After educational intervention, 72% patients ready for surveillance. Like this, chemoprophylaxis, they are also like only 2%, 3 patients they were ready for chemoprophylaxis. After that, it's 18 patients were ready for chemoprophylaxis. But here the important thing, despite of proper counseling, no patients in pre-intervention group or post-intervention group, like at the baseline when we are seeing in OPD, they are at that time no patients were ready for surgical intervention, prophylactic surgery, and after counseling also no patients were ready for surgical intervention like prophylactic bilateral risk reduction mastectomy or risk reduction self-angiopectomy. So it's very important that in our Indian scenario, surgical intervention, patient don't accept surgical intervention for prophylactic purpose. So coming to the fact about the sporadic and familial breast cancer, awareness levels were similar in both groups at presentation. A significant improvement in awareness level about all aspects of breast cancer genetics were noted after 5 to 10 minutes of educational intervention. There are some important facts like maximum awareness regarding BRCA gene have been seen in familial group with positive percentage change of 27 versus 9 of sporadic group. In both groups, even after educational intervention, none of the patients showed their interest for prophylactic surgical intervention. Like Western country, Angelina Jolie effect, here the Angelina Jolie effect is not seen in our patients because the patient profile is not so advanced in AIMS or other government hospitals, or they don't know about the, they are much less convinced about the risk reduction mastectomy or risk reduction self-angiopectomy. In familial group, almost 100% patients showed their willingness for genetic testing and prophylactic intervention mainly by the surveillance. So coming to conclusion, Indian breast cancer patients have low level of awareness and knowledge about breast cancer and its genetic aspects. This is likely the first educational intervention study involving Indian breast cancer population for assessment of knowledge regarding genetic aspects of breast cancer. Like there are various ample of case series or literature available for general awareness of cancer, breast cancer, regarding breast cancer in cancer patients, but not regarding the genetic aspects. It's important thing to do such a study so that we can know what the normal patients, what the breast cancer patients think in our society. Single short educational intervention had a significant impact in increasing awareness and knowledge of breast cancer patients, particularly in terms of risk factors, screening, management, familial breast cancer, genetic testing, like that. So a small thing like 5 to 10 minutes counseling is very much important to increase the awareness and knowledge so that patient can make decision easily. So in future, there is a need of goal-oriented, dedicated and collective effort to educate Indian breast cancer patients and their family members for the betterment of breast cancer outcomes. So in the last, the acknowledgements, I would like to acknowledge my chief guide, Dr. Professor S.P.S. Dev sir, who is professor and head Department of Surgical Oncology, AIMS New Delhi and NCI Jhajjar, Dr. Raja Pramanik, Assistant Professor, Medical Oncology Department, Dr. S.N. Dwivedi, Professor, Department of Biostatistics, regarding statistical analysis. So thank you very much.
Thank you, Dr. Naveen Kumar. Now, I would like to invite Dr. Nitesh Kumar from Osmania Medical College, Hyderabad.
Good morning, everyone. Welcome to India's Next Sushruta. I am Dr. Nitesh Kumar, MCH Urology from Osmania Medical College. Let's begin. I will be presenting on effect on short-term preoperative dutasteride and finasteride on bleeding after transurethral resection of prostate, a prospective randomized study. It was done in Osmania Medical College. TURP is a standard of care for the surgical treatment of BPH, but still it has its own set of complications. The combined morbidity rates of around 18% have been reported in the studies, and of them, perioperative bleeding is the most concerning one. Other complications are urinary incontinence, retrograde ejaculation, transurethral resection, TOR syndrome, erectile dysfunction. But due to perioperative bleeding, it leads to clot retention and blood transfusions, which ultimately prolongs the hospital stay and the reintervention. So it leads to a perioperative blood loss of more than 1 liter is reported in around 13% of the patients in the past. 5-ARIs act by inhibiting the conversion of testosterone to the active form dihydrotestosterone. And the available 5-ARIs are the finasteride and dutasteride. They suppress the level of DTH and prostate vascularity and growth. And ultimately, this helps in decreasing the blood loss during TUR. There are several studies on finasteride and dutasteride, but they have a conflicting result. When we see the difference between two drugs, dutasteride is a double inhibitor, but finasteride inhibits only type 2 5-ARIs. In serum DTH, dutasteride suppresses more than finasteride, but they suppress intraprostatic DTH almost similarly, and they have a similar pharmacokinetics except for the long half-life of dutasteride. So the question is, if finasteride can stop the bleeding, why not dutasteride? Because it's a better drug. So with this, we aim to compare the effect of the short term, around 2 to 4 weeks pre-treatment of DTH with dutasteride and finasteride on bleeding after TUR. But to date, no study has been done which has compared 2 weeks of preoperative finasteride and placebo with 2 and 4 weeks of preoperative dutasteride. With this, a prospective randomized double-blind study was done in Osmania General Hospital from January 2018 to December 2019 after taking ethical committee approval, and the study was conducted in accordance with the Declaration of Helsinki. The patients presenting with LUD suggestive of enlarged prostate were evaluated by IPSS, DERE, uroflowmetry, PSA, and USG was done for the prostate volume. Urodynamic study was done when required. The following patients were included in our study. All patients diagnosed with BPH and those cases planned for surgery were included in the study. All those cases were treated with alpha blockers before inclusion in the study, and a detailed history, physical examination, basic preoperative blood and urine investigations were done for all the patients. The following patients were excluded from our study: those with history of treatment with 5-ARIs within a year, prostate volume less than 30 grams, those with previous invasive procedures of the prostate, those with pelvic or any other urological malignancy, those with any other anticoagulant use, with hematological disorders, the patients with deranged renal function, and those with severe hepatic dysfunction, and ultimately patients with unstable cardiac disease. UTIs were treated before intervention. If malignancy was found, it was excluded by trust biopsy in patients with PSA more than 4 nanograms per ml. NSAIDs and aspirin were discontinued 2 weeks before and resumed a week after the surgery. All patients' written and informed consent was taken. We divided the patient into 4 groups using computer-generated randomization chart, and the person dividing the patient into groups was blinded. The patients were also blinded to their study group. The groups were group 1, is J2, they were given dutasteride 0.5 milligram for 14 days. The group 2, F2, were given finasteride 5 milligram for 14 days. The third group, P2, were given placebo empty capsules for 14 days. And the fourth group, D4, was given dutasteride 0.5 milligram for 28 days. All tablets were given once daily before doing the procedure. QRP was done under spinal anesthesia with 26 French Iglesias continuous irrigation resectoscope sheet of Karl Storz and bipolar loop working element with NS irrigation. The operating surgeons were of similar skill set, and the surgeons were also blinded to the study group. All the irrigation fluid during the surgery was collected in a bucket, and 1,000 units of heparin was added to the bucket to prevent the blood from clotting. After completion, the bucket was stirred manually, and 2 samples of 5 ml was taken for estimation of hemoglobin. A low hemoglobin measuring system, HemoQ-AB, was used to measure the intraoperative blood loss. and was measured by hemoglobin of the irrigation fluid multiplied by total volume of irrigation, and the product was divided by hemoglobin before surgery. Serum hemoglobin levels were also measured just before and 24 hours after the procedure. All the resected prostatic chips were also weighted. 20 French 3-way Foley's catheter was introduced into the bladder with pulp inflated to 30 cc, and continuous normal saline irrigation was started. Catheter traction was placed and was released after 6 hours. On the day 2, catheter was removed and voiding trial was given. The blood transfusions were given only when hemoglobin was less than 9 grams per deciliter. Dutasteride or finasteride and placebo drugs were stopped in the postoperative period. The outcome parameters were recorded by another surgeon who was also blinded to the study group. The primary outcomes were duration of surgery, amount of irrigation fluid used, duration of post-operative irrigation, weight of the resected prostatic tissue, total volume of blood loss per minute of operating time, and blood loss per gram of the resected prostatic tissue. The secondary outcomes were fall in serum hemoglobin, fall in hematocrit after 24 hours, blood transfusion requirement, duration of hospital stay, and histopathological analysis of all cases were done, and a diagnosis other than BPH was excluded. A sample size was calculated based on the power calculation done by K-Metal. He found more than 90% power in a sample size of 40 to interpret the intergroup differences. So we took a minimum sample of 40. Ultimately, we found that we had 60 patients in each group. Excel Stat 2019 software was used for statistical analysis. ANOVA was used for continuous data, and Fisker exact test were used for categorical data. The post hoc comparison was used for intergroup comparisons with adjustments using Bonferroni method. A p-value of less than 0.05 was considered statistically significant. In enrollment, 324 patients were assessed for eligibility, out of whom around 84 were excluded, and ultimately 240 patients were randomized into 4 groups and allocated into 60 patients in each group. In follow-up, few patients were lost, and ultimately for analysis, 58, 57, 59, and 57 patients were available in D2, F2, P2, and D4 groups. When we found that the general parameters were comparable between all the 4 groups, like mean age, BMI, total prostatic volume, PSA, number of patients requiring urodynamic studies, number of patients undergoing TRUS biopsy, duration of symptoms, IPSS score, Qmax, post-void residual urine, and number of patients on catheter. These data were almost similar between all the 4 groups, and differences were non-significant. The duration of surgery, amount of irrigation fluid used, weight of resected tissue, and duration of post-operative irrigation was also similar between all the 4 groups. The total volume of blood loss per minute of operating time, and blood loss per gram of resected prostatic tissue was significantly higher in the placebo group compared to the dutasteride and finasteride group, and the differences were significant. The fall in hemoglobin at 24 hours, fall in hematocrit at 24 hours were also, and requirement of blood transfusion was also significantly higher in the placebo group compared to the other finasteride and dutasteride group, and the data was significant. Duration of post-operative hospital stay was almost similar between all the 4 groups. When intergroup comparison were done between the significant parameters, it was found that with dutasteride and placebo group, the differences were statistically significant. Similar results were found with 2 weeks of finasteride and 4 weeks of dutasteride. But when dutasteride 2 weeks and dutasteride 4 weeks were compared to finasteride 2 weeks, the differences were not there. Even dutasteride 2 weeks and 4 weeks, there was no much differences. In postoperative, in our study, both the drugs were well tolerated. There were no severe adverse effects were observed. The 4 groups were comparable in terms of other postoperative clinical outcomes, and few minor complications like Clavin 1 and 2 occurred with no differences among the 4 groups. There were no major TURP-related complications, Clavin 3 and 4 in our study. Coming to the discussion, a mini review was published in British Urological Journal, and they found that they stated that TURP is a standard of care for surgical treatment of BPH, but it is associated with several complications and associated morbidity, which reaches around 18%. And of them, perioperative bleeding is the most frequent and serious complications, and clot retention and need for blood transfusion reaches around 4.4% in a meta-analysis. Another article published in BJUI stated that perioperative blood loss of more than 1 liter was found in 13% of the patients in the past. However, recent papers like of Han, they reported the blood loss of around 250 to 500 ml in QRP in those patients who did not receive 5-dash ARI. TUR syndrome has decreased at present times due to use of bipolar TURP in normal saline. In our study, all cases were done with bipolar TURP normal saline. The rationale for use of 5-dash ARIs before TURP comes from the ability to reduce the intraprostatic DPH concentration. But the routine use of 5-dash ARIs is not accepted worldwide due to the conflicting results in the study. A UK-based survey done in 2004 found that 98% of the urologists used 5-dash ARIs for the treatment of hematuria of prostatic origin. But contrary to that, only 4% used it before TURP to reduce the bleeding. In a meta-analysis by Zhu et al., he found that the optimal duration of preoperative 5-dash ARIs to reduce bleeding ranged from 2 weeks to 3 months. But Dunhen et al. Reported that 2 weeks of preoperative finasteride resulted in significantly lower MBD and VEGF expression in the prostate. Article published in the Prostate by Carlin et al. Reported that the gross hematuria due to BPH subsided after treatment with 2 weeks of finasteride. And Journal of Urology article by Kenry et al. Reported that in BPH patients who began finasteride while actively bleeding, the average time to clear urine was 12 days. So we decided to keep the duration of preoperative treatment to 2 weeks only, and we added an additional arm, 4 weeks of dutasteride, because of its low efficacy in the past studies. There are various methods to quantify the blood loss, and they have been reported, like falls in hemoglobin, fall in hematocrit, and hemoglobin in the irrigation fluid. Of these, the measurement of hemoglobin in the irrigation fluid is the most practical way to measure the hemoglobin. 2/3 of the variability was found in the perioperative blood loss. It was due to the speed of resection, which depends on the surgeon's experience and the amount of resected tissue. To negate that, we used the blood loss per gram of resected prostatic tissue and blood loss per minute of operating time, because the fall in hemoglobin and hematocrit might not give accurate estimates, and was also reported in these 2 studies. A study by Bansal et al., which included around 450 patients, did bipolar TURP, and he found that there was significant reduction in blood loss at 4 weeks after preoperative finasteride and dutasteride when compared to placebo. Kim et al. Published his article in Men's Health of around 83 patients. He reported that there was lower mean blood loss after 2 weeks of dutasteride compared to placebo. When we compared his findings to our study, we found almost similar results in our dutasteride and placebo arm. Liu et al., he studied around 100 patients, and he found that decreased levels of VEGF expression and angiogenesis in the prostate and reduced blood loss during TURP by using 2 weeks of finasteride. When we compared our finasteride arm to his study, we found significantly similar results, but blood loss was slightly less, maybe because we used the bipolar TURP contrary to Liu et al. Who used the monopolar TURP. Various other studies have reported no significant benefit of use of preoperative 5-dash ARIs, like Chanchal et al. Of 75 patients, 5 weeks of dutasteride, Lund et al. 35 patients, 3 months preoperative finasteride, Chanfeld et al. Around 60 patients, 3 months of finasteride. But as we can see, there was a low number of patients and all the studies were underpowered. Han et al., relatively larger study, he also did not find a reduction in MVD of prostatic tissue, even after 4 months of dutasteride therapy, despite achieving a 90% reduction in serum DPH concentration, which is very much contradictory to the large study of 450 patients done by Bansal et al. Bansal et al. Reported significant reduction in blood loss after 4 weeks of preoperative finasteride and dutasteride when compared to placebo. When we compared his findings with our studies, it was almost similar, and we found that total volume of blood loss per minute of operating time, and blood loss per gram of resected tissue almost similar to our study. A systemic review was published in Asian Journal of Andrology by Zhang et al. Included around 1156 patients in 2011. He found that he included 10 RCTs on finasteride and 5 for dutasteride. He found that finasteride treatment decreased MVD and blood loss, but dutasteride had no effect. Our next systemic review was published by Zhou et al. And included around 1500 patients in 2015. 17 RCTs were included, and he found that finasteride has a positive effect, but dutasteride didn't. Recent meta-analysis systemic review done in 2017 included around 1,000 patients, 5 RCTs and 5 cohort studies. Ren et al. Concluded that dutasteride could reduce cervical bleeding during TURP. As we can see, there was great variability in studies included in the meta-analysis. So, a well-designed, multicentric, randomized, placebo-controlled study with a different duration of treatment is needed to accurately answer the problem. But why our study counts? We tried to answer the role of short-term 5-dash ARIs in reducing the bleeding during TURP. A well-designed randomized placebo-controlled study was done by us. A clinical effect was the main outcome criteria, which is the ultimate goal. And we included a relatively larger number of patients. This is our study, the first one, which is comparing 2 weeks of preoperative dutasteride and finasteride with placebo and has an additional arm of 4 weeks of dutasteride. But there were some limitations in our study that we could not include the indirect methods to predict blood loss like MVD, VEGF, and CDS count. To conclude, short-term preoperative dutasteride and finasteride for 2 weeks are equally effective, and they significantly reduce the perioperative blood loss during TURP. But 4 weeks of dutasteride had no significant advantage when compared to 2 weeks of dutasteride. So, a short course, 2 weeks administration of 5-dash ARIs before TURP may reduce the blood loss, related complications, and need for transfusion in the perioperative period. These are the references. Thank you.
Thank you, Dr. Nitesh Kumar. Now, I would like to invite Dr. Rishi Datta from IPGMER and SSKM Hospital, Kolkata.
I am Dr. Rishi Datta from IPGMER, Kolkata. I am going to present my study, which is a comparative analysis of clinical and pathological outcome following laparoscopic versus open surgery in colorectal malignancy that we perform in institution. Though this topic seems a bit common, but such study in our setup hasn't been done before. So we thought of taking up this study in our center. As we all know that colorectal cancer is still the second leading cause of death from malignancy in the industrialized world, accounting for more than 10% of all cancer-related deaths. And operative excision with or without adjuvant treatment is still the only curative treatment. It was in 1991 when laparoscopic surgery first came into use for colorectal diseases, but there are still many school of thoughts who doubts the safety, the efficacy, the accuracy of tumor resection, the lymph node dissection, and port site metastasis for this study. Our aim and objectives were to study the demographic profile, certain preoperative status like the performance status, preoperative parameters like hemoglobin, albumin, and to critically assess certain clinical and pathological outcome in both the groups, and also to understand the advantages as well as disadvantages of one approach over the other. Ours was an institution-based prospective study which we conducted in the Department of General Surgery and Department of Pathology of our institution, that is IPGMER SSKM Hospital, Kolkata, and the duration was 24 months. Our sample size was 40, 20 open surgical patients and 20 clinical and pathological parameters based on some pre-designed pro forma that was used for data collection. And the statistical analysis was done with the help of the recent version of GraphPad Prism. The inclusion criteria for our study was patients who were more than 12 years, irrespective of male or females, and who had clinically and radiologically as well as histologically proven colorectal malignancies. And patients were excluded from a study where any patient aged less than 12 years, patients presenting with acute intestinal obstruction due to such malignancy, multiple synchronous growths, metastatic disease, any locally advanced disease, or patients who were unwilling to take part in the study, or patients who were not fit for general anesthesia. Now, coming briefly to the operative principles that we followed. Firstly, the open techniques. The anesthesia was always general anesthesia with endotracheal intubation, and the position of the patient varied depending on the surgery that we performed. Like for APR, we used the modified lithotomy position, and we started with the diagnostic laparoscopy to find out if there was any metastatic disease that we missed on preoperative radiological investigations. The incision was planned according to the operative procedure that we were going to perform. The bowel were mobilized following the principles of mobilization of the bowel, and the vessels were ligated according to the oncological principles. The resection of the bowel was done taking adequate margin depending on the location of the tumor and the oncological principle, and the anastomosis was performed. The decision to perform a proximal diversion in the form of stoma depended on many factors like the preoperative performance status of the patient, the preoperative hemoglobin, the preoperative albumin, or whether the patient received any preoperative chemoradiation, and also depending on the anastomotic integrity. So it depended on many factors. Now, coming to the laparoscopic technique, the anesthesia was similar. The position also here dependent on the surgery that we are going to perform, and mostly we use the closed access, that is with the various needle, but if there was any history of previous surgery, then we use the open technique. And the port position also varied depending on the procedure that we were going to perform. The mobilization of the bowel was similar like the open procedure, and the ligation of the vessels were also similar. The bowel are also resected taking adequate margin, keeping in mind the oncological principle, and the anastomosis were performed sometimes using stapler if there was an availability of stapler, but since ours is a government institution, so always we didn't have the availability of such laparoscopic stapler. So in those cases, we performed the extracorporeal anastomosis, and the proximal diversion was done depending on the factors similar to the open surgical procedure that which I already elaborated. Now, this picture on the left has been taken from the textbook of Maingo. This is to demonstrate the ports that were used in case of laparoscopic right hemicolectomy. We use similar port positions for right hemicolectomy. And to the right is an intraoperative picture taken from one of our patients to show that the diagnostic laparoscopy that we started the procedure suite to exclude any metastatic disease. The left picture shows the mobilization of the hepatic flexure in case of right hemicolectomy, and to the right is the figure demonstrating the vascular ligation using the vascular clips for the vessel ligation that we used. Now, coming to the results. First, if we look into the demographic profile, The mean age group of the patients who underwent open surgery was around 45 years, and that in the laparoscopic group was around 47 years, with a p-value which was not significant. And most patients in our study were in their third and fourth decade, so they're mostly young patients, contrary to the previous studies who showed that mostly patients in their sixth and seventh decades suffer from this disease. So there has been a change in this colorectal malignancy, which our studies also shows. And 52.5% of our patients were male compared to 47.5% female, and the male to female ratio was 1.1:1 compared to 1.18:1 as per the statistics from the Global Cancer Observatory. Coming to the family history, looking into this, there is only 10 patients who had a positive family history as compared to 30 patients who had a negative family history. But this is not sufficient enough to conclude that the family history status. We need more patients to comment on this. A study by Slattery, ML et al. Has shown that the association of family history are weak for patients with rectal malignancies and are very strong in case of malignancies affecting the proximal colon, like the right colon. Now coming to the preoperative parameters. Firstly, if we look into the preoperative performance status, which we measured with the help of ECOG score, both of our patients were comparable and there was no selection bias as far as this parameter was concerned. The preoperative hemoglobin level, the mean hemoglobin level was 10 for both the groups, and the p-value was also not significant. So in this parameter also, both our groups are comparable, though there are many controversy regarding the relationship between preoperative anemia and postoperative outcome. But study by Bruns et al. Has shown that anemia is associated with overall survival and not independently with postoperative complications. So coming to the preoperative albumin level, as we all know, albumin is one of the most important factors that determine the postoperative morbidity and mortality. And both our groups are comparable with a good albumin level around 4 for both the groups. And as we all know that hypoalbuminemia is associated with increased rate of postoperative mortality and morbidity. This is a schematic representations of the tumor. I had 11 patients suffering from carcinoma of the right colon, 5 patients with carcinoma of the left colon, and the remaining 24 patients had carcinoma of the rectum. This is the treatment that we offered. 26 patients had upfront surgery and 14 patients had surgery following chemoradiation. But all the patients, that is laparoscopic patients and open surgical patients, were comparable as far as the preoperative upfront surgery and the chemoradiation status was concerned. Now, these were the different types of surgeries that were performed both for the open group and the laparoscopic group, ranging from right hemicolectomy, anterior resection to APR. Coming to comparison of the intraoperative parameters, as we can see that the mean operating time was longer in case of the patients undergoing laparoscopic surgery as compared to the open surgery. But as has been shown by different studies like Badilli et al., we also believe that this difference can be overcome with increased experience of the surgeon and the operating team. If we look into this graph, which compares the intraoperative blood loss, the intraoperative blood loss was significantly less in patients undergoing laparoscopic surgery as compared to patients undergoing open surgery, but the energy sources and other devices used were same for both the group. The diversion was performed 33.3% patients for the laparoscopic group as compared to 26% of the patients in the open group. Well, since we are in the beginning phase of our laparoscopic surgery, so we are a bit skeptical. So maybe that has contributed to this little bit of increased diversion in the laparoscopic group. But as I have already told before, that the decision to perform a proximal diversion depended on many factors. Now coming to the postoperative parameters, if we first look into the return of the bowel function, the patients who had a laparoscopic surgery had a much earlier return of bowel function as compared to patients in the open group. And this has been supported by other studies like that by Kaputsu et al. And Peter Hewitt et al., who has also shown that there is a statistically significant difference with regards to the postoperative ileus in the famous ALC-SSS trial. Now coming to the postoperative ambulations, we could mobilize the patients in the laparoscopic group much earlier than patients in the open group, maybe because patients in the laparoscopic group had much less pain. And this has also been supported by the famous Korean trial, who also supports the fact that laparoscopic surgery had a much better physical functioning score than the open group. Now coming to the postoperative intravenous analgesic requirement, this was compared on the basis of a single intravenous analgesic that we used for all the 40 patients, and there was no difference as far as the agent was concerned. And we found that although this table shows the number of days, but the dose was also much less in the patients undergoing laparoscopic surgery as compared to patients in the open group. Well, though we followed all the same antibiotic prophylaxis, the intraoperative prophylaxis were same for all the patients, but still we found that none of the patients in the laparoscopic group had any wound infection in the postoperative period as compared to 6 patients who unfortunately had wound infections in the postoperative period. And studies like by Braga et al. And Antonio et al. Also supports this fact that morbidity like wound infections occurs at a much lower rate in the laparoscopic group. So taking into consideration all these factors, that is less pain, early mobilization, early return of bowel function, less wound infection, we could discharge the patients in the laparoscopic group much earlier in a mean of 4 days as compared to patients in the open group. And a study by Aziz et al. Has also found that total duration of the hospital stay was significantly lower in their study also who had a laparoscopic colorectal resection. So coming to one of the most important complications that we all surgeons performing colorectal procedures are scared of is anastomotic leakage. And we found that one patient in the laparoscopic group who had a stapler anastomosis had a anastomotic leakage, but the patient was a very well-built patient with a good preoperative performance status, good preoperative albumin and hemoglobin level. But we were unable to find out the exact cause which attributed to this leakage. And looking into the papers that has been performed worldwide, I found out 2 papers by Dams et al. And Scutio et al. But unfortunately, they were also unable to show the exact etiology of anastomotic leakage. But as we feel that intraoperative risk assessment and subsequent adaptation of the operative techniques can lead to the reduction of such anastomotic leakage in the future. Now coming to the comparison of the histopathological parameters, which is also one of the parameters of my study. This is the types of the tumor that we experienced. We found that well-differentiated and moderately differentiated adenocarcinoma were found to occur in equal frequency as compared to the poorly differentiated. But a study by Gonzalez et al. Has shown that moderately differentiated adenocarcinoma is the most common histological variety. But that may be because of the place of where the study has been conducted and the demographic profile. Now coming to the margin status, which is one of the most important oncological parameter as far as any malignant surgery is concerned, we found out that if performed meticulously, laparoscopic surgery can have a complete circumferential resection margin as compared to the open group. And all our patients, all the 40 patients, irrespective of the type of surgery performed, whether open or laparoscopy, had a complete margin of resection in the histopathological examination. Lymph nodes. This retrieval of the lymph nodes has been a matter of debate for many years. And I think it is still a matter of debate among many surgeons who still believes that laparoscopic surgery doesn't have a good lymph node retrieval. But we found out that if performed meticulously, taking into factors all the oncological principles, the laparoscopic surgery can also have a good amount of lymph node retrieval as compared to the open group. Now coming to the follow-up, we followed up all the 40 patients. First we followed up 3 monthly, then 6 monthly, and so on and so forth. And we used many factors, like we followed up the patients both clinically and radiologically. And one of the most important biochemical parameters that we used for a follow-up was the carcinoembryonic antigen level. If we look into this chart, first if we look into the preoperative carcinoembryonic antigen level, the preoperative CA level is comparable in both the open group and the laparoscopic group. So we can say that there was no selection bias. And if we see that there was a significant reduction in the CA level in the postoperative period in the open group, also there was a significant reduction in the CA level in the follow-up period in the laparoscopic group. So we can conclude from this table also that the laparoscopic surgery has a comparable oncological outcome as their open counterpart. So coming to the recurrence, as I have told that the study has been conducted for 24 months and till the last date of their follow-up, none of the patients had any recurrence either clinically or radiologically. So to summarize my study, firstly, demography. Most of my patients were in the 3rd and the 4th decade, followed by the 5th and the 6th decade. So we can see that there is a change in the trend of this disease affecting the younger population, contrary to the previous belief that this is a disease of the elderly population. And the male to female ratio was 1.1:1. Now coming to the preoperative parameters, firstly the performance status, which we measured by the ECOG scale. Both the groups were found comparable as far as the preoperative performance status was concerned, and there was no selection bias. There was no statistically significant difference between the preoperative hemoglobin and the preoperative albumin level between the two groups. And coming to the tumor location, 24, mostly majority of my patients, 24 patients had a carcinoma rectum, followed by carcinoma of the right colon, 11 patients, and the remaining 5 patients had a carcinoma of the left colon. Now, coming to the comparison of the intraoperative parameters, the first is the duration of the surgery. The laparoscopic surgery definitely took a longer mean operating time, but as I have already told, and as already been told by many other authors also, that this disadvantage with laparoscopic surgery can be overcome with the increased experience of the surgeon, the increased experience of the operating team, and the more number of surgeries that we perform. We believe that we will be able to reduce our mean operating time. But the blood loss was definitely significantly less in the laparoscopic group, although we used the same energy sources and the same principle for both the open group and the laparoscopic group. Now, coming to the postoperative parameters, firstly, the return of the bowel function of the postoperative ileus was much less, and the bowel function, including the stoma movement, was much earlier in the laparoscopic group, and we could mobilize our patients much early, maybe due to less pain in patients who had a laparoscopic surgery. The intravenous analgesic requirement, both in terms of the duration and the dose, was less for the patients who had a laparoscopic colorectal resection, and there was no wound infection in them as well, as compared to 6 patients who had a wound infection in the open group, although the antibiotic prophylaxis and other parameters that we followed to prevent wound infection were same for all the 40 patients in our study. So considering all these factors, the earlier return of bowel function, earlier ambulation, less intravenous analgesic requirement, less wound infection, we could discharge our patients in the laparoscopic surgical group much earlier than their open counterpart. So coming to the pathological parameters, we found well-differentiated and moderately differentiated adenocarcinoma to occur in equal frequency, and the remaining was poorly differentiated adenocarcinoma. And all the patients, all the 40 patients, had a complete circumferential resection margin, and the laparoscopic surgery was found to have a good lymph node retrieval and a comparable oncological outcome. So if performed meticulously, if performed taking time, and if performed keeping in mind all the oncological principles, laparoscopic surgery can have a definite good oncological outcome as compared to the open group. And as I have already shown, that patients in both the groups had a significant reduction in the carcinoembryonic antigen level in the follow-up period, and there has been no signs of recurrence either clinically or radiologically in any of the patient till their last date of follow-up. So to conclude, as we all know, that colorectal malignancy is a very morbid disease in itself. So if we can reduce the surgical morbidity, then definitely it is advantageous for the patient. So laparoscopic surgery, taking into mind all these factors, is definitely advantageous, as it has got much less surgical morbidity, like less pain, less wound infections, early ambulation, and shorter duration of hospital stay. But there is a comparable oncological outcome. So we didn't compromise on the oncological principle while performing the laparoscopic surgery. So adoption of laparoscopic surgeries in the treatment of such malignancy definitely seem advantageous for the benefit of the patient. The limitations of my study were, it was a single institution-based study, and the duration was comparatively less, and the number of patients were less. But definitely me and my other authors and my team definitely plan to take forward this study, collaborating with centers performing good number of surgeries annually, so that we can recruit more number of patients and can look into certain other parameters like the port side metastasis, so that we can make our study much more unique and present it in the world podium. So with that, I conclude my study. Thank you so much for your patient hearing.
Thank you, Dr. Rasheen Datta. Now, I would like to invite Dr. Syed Mustafa from Osmania Medical College, Hyderabad.
Good morning, everyone. I am Dr. Syed Mustafa, postgraduate in general surgery from Osmania Medical College, Hyderabad. The paper I am about to present is a randomized controlled trial comparing the efficacy of electrosurgical skin incision versus scalpel, the conventional skin incision, in inguinal hernia surgery. This is the outline of today's presentation. To start with introduction, the aims of the design, the results, discussion, and also a bit of the limitations of the study, and then the conclusion. To begin with a brief historical background, The idea of cauterization is actually pretty old. It's about 5,000 years old. We have evidence dating back to 3000 BC of the use of thermal cautery for treating battle wounds using heated stone and stone. Electrosurgery was repeated right back to Hippocrates' time, where he used electrocautery for treating abscesses and also for stopping bleeding in procedures. The word itself, cautery, comes from the Greek term cauter, which means brandishing iron or burning. The modern avatar that we are familiar with was made first commercially by Dr. William Bovey in 1920s at Harvard. And in fact, in operation theaters abroad especially, the machine is also called colloquially a Bovey for the patient. The first time it was used in a live surgery was by Dr. Harvey Cushing, the father of neurosurgery, to stop the trouble with neurosurgical bleeding. Of course, we tend to use all these terms, electrosurgery, diathermy, cautery, and electrocautery quite interchangeably, but there are actually precise definitions for each and there are differences. Like the term electrosurgery refers to the passage of high frequency electrical current through the body tissue to produce coagulation and cutting, while diathermy implies the heating of tissues due to the resistance to electromagnetic radiation, electrical current, or even ultrasound. The term cautery, as we saw, refers essentially to burning using either chemical means or using pure heat. In electrocautery, this heat is brought about by heating a wire loop, and it produces intense localized heat. In electrosurgery, the patient himself is a part of the electrical circuit, but technically in electrocautery, it is not the case. In fact, the current remains only in the instrument and does not actually go to the patient. So that is the brief difference. Despite being available in almost all operation theaters today and being indispensable to a surgeon's arsenal, the use of electrocautery for making skin incisions has been rather controversial. Now, the traditional reasons that people give to express their reservations about it include the fear of tissue damage, some questionable wound healing, and also the risk of post-operative infection. However, several international studies have evaluated incisions made by electrocautery and compared them to scalpel incisions in abdominal, thoracic, and inguinal regions. And the results have been actually varied. Some of them have shown equivocal results. Others have shown a marginal superiority of one over the other. Specifically, studies have also compared the early post-operative pain, and some have found that there is lesser early post-operative pain when you use an electrosurgical instrument for making the skin incision. Besides that, aspects of wound healing and scar characteristics are not really been adequately studied to form definitive conclusions. Now, open inguinal hernia repair is pretty much routine as a clean operation with generally uncomplicated wound healing and infection rates of about less than 2.5 to 3%. The wound healing is obviously routine and uncomplicated with acceptable scarring and low morbidity. So the aim of this study is to comprehensively evaluate the outcomes of using electrocautery or scalpel in making skin incisions in open inguinal hernia repair. Now, interestingly, the electrosurgical device has been called the most hazardous device used on a daily basis in an operation theatre. And that is because we must use it with precaution and with care. But actually, if it's seen, the most hazardous device used in an operation theatre are the sharps, due to the risk of sharp injuries, which far outweigh the number of hazardous events in the electrosurgical theatre. In fact, scalpel blades are a major source contributing to this. On the right, you see the different modes that are used. On the left, you see the electrosurgical unit, which was used in this particular study. The pure cut mode was used for making skin incisions. And as you can see, it has released lateral thermal damage as compared to coagulate with all significant tissue damage. In fact, in the pure cut mode, the tip of the electrocautery doesn't even touch the skin. There is no contact. There is an air gap, and an intense spark produced at the tip causes rapid vaporization of tissues and allows us to make a clean cut on the skin. The study design is essentially a randomized controlled trial, a double-blind trial with a sample size of 100. This was conducted in the Department of General Surgery at Uthman General Hospital, which is a tertiary care hospital. The patients were recruited from all the units of the hospital. of the surgery department. The criteria for inclusion was essentially age about 15 years of any sex and all elective surgeries of reducible, uncomplicated inguinal hernia of any size, either direct or indirect, any extent. The exclusion criteria, which is important, was inguinal hernia of any complication with recurrence, those having emergency surgeries, patients with diabetes, immunocompromised cases like HIV, significant anemia, cardiac renal disorders, and those on steroids, and also those with pacemakers, because they might be pacemakers and a monopolar causes. Also, patients having pre-existing infections and scars in the inguinal fluid region were also excluded. The committee approval was taken and patients were enrolled only after given informed consent, and those meeting the above criteria were randomly assigned either of two groups. Group A was the test arm or the intervention arm with 50 patients who underwent electrosurgical sterilisation, and Group B was the control arm which underwent scalpel sterilisation. There were 50 members in each of these. All the patients were adequately prepared for surgery and they underwent Lichtenstein tension-free hernioplasty and the spinal anesthesia. Prophylactic antibiotic was given for all right before the surgery, 1 gram ceftriaxone IV, and skin closure was done with 2-0-proline, and acute stitches with 2-0-chromic calcite were taken when necessary. Post-operatively, the prophylaxis for the treatment for post-operative pain was injection tramadol, IM 100 mg VD for the first 24 hours, followed by oral diclofenac for the next 2 days VD, and then SOS based on the patient's condition. Besides that, the two groups had only one difference, that is the mode of care incision. The mesh, the technique used in surgery were matched in both groups to the extent possible, so that all confounding factors are eliminated or minimized as much as could be done. For this entire procedure for both of these groups, a Johnson & Johnson electrosurgical unit was used at the power setting 45 for the cut mode. You can see the images of Group A and Group B here. Now the meat of the study. Essentially in the study, the outcome measures that were assessed were post-operative pain, superficial surgical site infection, and wound healing. All these measures were assessed on every day of the first week post-operatively and also on the 14th and the 30th day by a blinded assessor. Post-operative pain was assessed using the visual analog scale that you see on screen. Surgical site infection based on the CDC criteria to identify them and classify and grade them based on Southampton wound training system. And the Manchester scar scale that you see here was used for scar characteristics. It grades multiple scar parameters with point around coding as you see on screen. The results are analyzed for both the groups and the outcome variables, the second and third of them, that is surgical site infections and scar characteristics, are categorical in nature, so the chi-square test was used. As a post-operative pain in the visual analog scale, that is interval data that is non-parametric, so the man-Whitney U test was used to compare both the groups for statistical difference. Comes to the result. And this was that one patient present for eligibility, of which 20 did not meet the criteria and 30 did not consent to the study. Approximately 100 patients were recruited, divided into two arms, the test arm Group A and the control arm that is Group B. And we have follow-up for both groups. There was no also follow-up for either. All the patients in both the groups had happened to be male, and both groups were found to be to have comparable age and BMI. That is p-value of 0.29 and 0.39 on doing the t-test. So one could say that they were matched for both age and for BMI. Group A and Group B, both of them had a roughly equal mix of direct and indirect hernias. Coming to the first point of our assessment, the parameter of post-operative pain, it showed a median value of 3 in the electrocautery group and 4 in the scalpel group. This is the visual analog scale. And on doing the man-Whitney U test, the p-value was found to be 0.085. Now, in this study, I used the p-value 0.05 as the cutoff and traditionally used for significance. So, with the 0.05 value, one could say that post-operative pain was a approaching statistical significance, being marginally lesser in the electrocautery group than the scalpel group. Coming to the surgical site infection, 5 of the 50 patients in group A, that is the cautery group, had superficial infection, whereas the 50 in group B, the scalpel group, had superficial infection. On doing the calculations, the PMI of 0.53 is not showing any corresponding difference between these two in terms of their wound infection rate. Where all the infected patients, their swabs were sent for culture sensitivity. In group A, when the electrocautery incision being made, out of the 5 infected cases, did not show any microbial growth. The others had Staph aureus and Klebsiella. In group B, out of the 7 infected cases, from 2 of them did not show any microbial growth, whereas 3 had Staph aureus and 2 had Klebsiella. Coming to the last parameter, which is the scar characteristic, the manifestor scar essentially has scar color, the skin finish, the scar contour, the distortion of the scar, and the texture as the parameters. On assessing all these parameters in the tabulated data that you see, the difference was not found to be statistically significant for any of these features. So the p-value was more than 0.05 for all of them. Here are a few images. In the top row, you can see the wound erythema in group A, the healing scar in group A, the scar after 1 month in group A. In the bottom row, you can see the wound discharge in group B, a healing scar in group B, and also scar formation in an infected wound after healing in group A. Coming to the discussion part, electrosurgery has been a part of a surgeon's repertoire since 1920, and it is now indispensable to any surgical operation theatre. Yet, using it to make skin incision, surgeons have their own reservations, and this reluctance is explained partly by the common held belief that electrosurgical approach increases devitalization within the wound, and this is believed to contribute to greater wound infections, inappropriate scar formation, greater postoperative pain due to local nerve damage, and delayed wound healing. In fact, on the contrary, studies have shown and have suggested that local tissue beating increases the subcutaneous oxygen tension, and this via oxidative radical damage actually reduces the postoperative wound infection rate. So we have to create failure. The technical improvements in surgical units have enabled us to deliver pure sinusoidal current, and this rapidly revives cells, causing minimum lateral thermal damage. And thanks to these new oscillator units, we can save skin incision and attempt study like this. In this study design, most confounding factors were controlled for different possible age, BMI, preoperative, prophylactic antibiotics, the surgical procedure, the serious use, the post-operative anesthesia, aseptic dressing, there was blinding as well. All these factors were controlled as the possibility of post-operative skin disease of the first outcome measure was found to be lesser with the electrocautery group than in the scalpel group. But this effect was not statistically significant, but close enough to warrant us pay for attention. In fact, in other studies, that is by Kern et al., he had shown that the anatomy of skin was associated with lesser early post-operative pain and less analgesia requirement. Likewise, NMS et al. Also showed that in the first 24 hours, there was significantly lesser pain and lesser requirement of analgesia. Coming to South India, a study by Alex et al. Also had similar results. The second parameter that was outlined in the study aim was the rate of infection. The difference between group A, 5 group A, 7 and group B was statistically insignificant. And other various studies from Canada, from France, from Italy, and also from India that have concluded that using electrosurgical instruments for making incisions is associated with a high rate of wound infection. Interestingly, LMF et al. Conducted a systematic review using 6 randomized controlled trials with a sample size of total of 200 patients and concluded that using electrocautery making skin incision has less incision blood loss, 1, has reduced operation time, 2, and third, no risk of increased wound infection in this group. This is an important systematic review. Coming to the particular study, most patients in both the groups had number 1 bleeding, more than 90% had a grade 0 non-bleeding. Characteristics at the end of 1 month were found to be comparable in both groups. Using the Manchester case, there was no statistical difference between them. One could say that healing by primary retention was not influenced by the use of electrophoretic or by the use of scalpel. Dixon et al. Showed that the electrosurgical incisions are highly effective, consistently quicker, and also gave cosmetic results in his study with minimal complications. Rajesh et al. in South India concluded that diaphragm incisions are less harmful to the skin and have advantages like less post-operative pain with a comparable profile of wound infection and complications. So, one could safely say that wound complications were not higher in either of the groups, they were comparable. The most compelling reason to suggest use of electrophoretic is the risk of injuries is sharp. And with this study, we could say that electrosurgery is safe for both patients and the surgeon. In fact, it is faster, it keeps calculators away from the bleeding, and also provides the operative field from a blood less obscured view. So all in all, there are advantages and also no particular disadvantage of using electrophoretic for the instance as per the study. In fact, when we see the evidence, there is level 1 evidence in literature available that supports the idea, the notion that electrosurgical use of skin incision is comparable to use of scalpel. I mean, have all of the levels of evidence that supports this conclusion. But life is a different and life. In science, there are limitations to this, and science progresses only by identifying limitations and working on them. Comorbidities, complications, and emergency cases were not included in the study, and that leaves a significant chunk of patients out of the disease spectrum in this study. Likewise, there are confounding variables that were not accounted for. Like in my tertiary care hospital, it was not possible to have the same surgical team operating on all 100 patients. So there could be different variations in surgery techniques, tutoring, and other kinds of differences. Besides the genetic variability, there is more like hypertension, and also psychological stress has been shown to delay wound healing, which were not mapped for both groups. So they could be possible confounders. Although a larger number size would always have been better, of course, would have been for a longer period. And this study only included environmental instance. There are other instances as well which are not included. One aspect that is missing in this study is the duration of surgery. Other randomized controlled trials have shown that use of potting decreases the duration and the time of the surgery. So that is also an added advantage which was not included in the study. Besides that, fundamentally, the underlying pathological difference between use of electrosurgery and between use of scalpel communication is not there. But regardless of all of that, this study gives you the take-home message that the myth of the fear of using electrocardiac or skin incision is unfounded because cutting the diaphragm is as safe as, if not superior to, the use of scalpel for making skin incisions, particularly in one hernia surgery, to provide for pain, bone infection, pain, and appetite problems. So, I like to suggest based on the study that we safely use this technique in treating one hernia surgery. And to also corroborate with the current literature and the current standard currently. If the references on paper and the data approved. Thank you.
Thank you, Dr. Syed Mustafa. Now, I would like to invite Dr. Prateek Kumar Jha from Institute of Medical Sciences, BHU, Varanasi.
Warm greetings to all the respected jury members, my fellow colleagues, and the team of India's Next Sushruta and Docplexus along with Medtronic. I am Dr. Prateek Jha, a junior resident in the Department of General Surgery at Institute of Medical Sciences, Banaras Hindu University. I am privileged to have this opportunity to present a paper in the final round of India's Next Sushruta titled Dexamethasone in Prevention of Post-Operative Nausea and Vomiting After Laparoscopic Cholecystectomy, a prospective randomized double-blinded study. I have no disclosures to make. Cholelithiasis is one of the most commonly treated surgical diseases in the general surgery elective setting. And laparoscopic cholecystectomy over the last 2 decades has been established as a gold standard for the treatment of cholelithiasis. It has the advantage of having a small scar with reduced post-operative pain, shorter hospital stay, and prompt bowel activity with early return to work. And it has been seen to have diminished neuroendocrine metabolic responses. Post-operative nausea and vomiting is an unpleasant and distressing as well as exhausting experience for the patients in the post-operative period. It can defeat the very purpose of the minimal invasive day care approach in interventions like laparoscopic cholecystectomy by delaying the oral intake, increasing the nursing requirement, and increasing the post-operative hospital stay. However, the etiology of this post-operative nausea and vomiting is not well understood. It may result because of the stress response of the body to surgical trauma. However, the other authors postulate that it is because of the pneumoperitoneum that the carbon dioxide creates, which stimulates a series of hormonal, metabolic, central nervous system and inflammatory changes, leading to stimulation of the vomiting center in the central nervous system. Now, dexamethasone is a corticosteroid, an anti-inflammatory, and is an inexpensive as well as effective anti-emetic drug. It has minimal side effects after single dose administration. In 1981, it was first reported as an effective single dose antiemetic, especially in cancer patients after the chemotherapy. So this can be assessed as a cheap and safe drug that can prevent post-operative nausea vomiting following laparoscopic cholecystectomy. However, the doses used in various studies are variable. The aim of this study was to evaluate the efficacy of single-dose dexamethasone, that is 8 mg, for the prophylaxis of post-operative nausea and vomiting after laparoscopic cholecystectomy. This was a prospective study conducted in Department of General Surgery, Institute of Medical Sciences, Banaras Hindu University between July 2019 to December 2020. All symptomatic gallstones between the age of 18 to 80 years with ASA grade of 1 or 2 were included in the study. However, the ones who had pregnancy or any associated comorbidity, along with the patients who were on opioids or drugs like tranquilizers or steroids or had a history of alcohol or drug abuse, were excluded. After proper consent, the patients were enrolled, and a total of 132 patients were randomized into 2 groups using computer-generated random numbers. The study medication was prepared by a nursing staff in an identical 2 ml syringe to ensure blinding of surgeon, anesthetist, patient, and post-op evaluation. Group 1, that is the dexamethasone group, received injection dexamethasone 8 mg IV just before induction, and the placebo group, that is the second group, received 2 ml of normal saline as a placebo. The anesthesia technique, anesthetic drugs, and surgical techniques were standardized for both the groups. No intraoperative antiemetic was given, and the post-operative pain was assessed using visual analog scale at 12 and 24 hours, and post-operative nausea and vomiting was assessed by nurse blinded to the randomization of the patient at 12 and 24 hours. Where nausea was subjectively defined when the patient asked for antiemetic medications, and each episode of vomiting were recorded. Injection metoclopramide 10 mg IV was used as a rescue antiemetic. So, after enrollment of 139 patients, 7 were excluded. 1 because of the conversion to open cholecystectomy, 4 had comorbidities, 1 has had a associated GIST, and 1 had suspicion of malignancy. So, the 132 patients left were randomized into 2 groups, and 66 of them received injection dexamethasone, and the remaining 62 received injection placebo. And they were analyzed after in the post-operative period for 24 hours. The statistical analysis was conducted using the SPSS version 23 Chicago software, and the chi-square and man-hood meters were used for qualitative data as well as independent sample t-test, and one-way ANOVA was used for analysis of quantitative data. A p-value of less than 0.05 was considered statistically significant. Now, while comparing the variables between the Dexona and the placebo group, the mean age was 42.09 in Dexona group with 40.79 in the placebo group. Most of the patients were female, and the mean weight was 60.43 in the Dexina and 5.23 in the placebo group. The amount of carbon dioxide used to split, the operating time, number of stones, the complications as biliary leakage, pain score at 12 hours and 24 hours were statistically insignificant when compared between the two groups. However, post-operative nausea and vomiting in Dextrona group was significantly less, which was 12.1% compared to 13.3% in the placebo group. However, vomiting at 12 hours as well as nausea and vomiting at 24 hours were statistically insignificantly different in both these study groups. Similarly, while comparison of the various parameters among patients without or with nausea and Dextrona group, the disease time, the carbon dioxide used, the surgery time, the number of stones, the pain were statistically significant, implicating that these factors were identical or comparable in both the groups and did have a confounding effect. Now, comparison of various parameters among patients with and without nausea in the placebo group. Again, the disease time, the carbon dioxide used, the surgery time, the number of stones, the pain at 12 and 24 hours were comparable and was statistically insignificant. So, laparoscopic cholecystectomy has decreased the morbidity associated with the cholecystectomy. However, post-operative nausea and vomiting may range between 53 to 72%, and it has been reported in the literature, which can be distressing for the patients and may defeat the very purpose of daycare surgery of laparoscopic cholecystectomy. The cause of post-operative nausea and vomiting is not fully understood, and a multitude of factors like sex, cigarette smoking, menstruation, obesity, and drug intake, drug abuse have been reported. The exact mechanism by which dexamethasone as an antiemetic is not clear. However, it has been postulated that it actually may act as by central inhibition of prostaglandins and with changes in the permeability of the blood-brain barrier. In our study, single dose dexamethasone 8 mg reduced nausea after laparoscopic cholecystectomy, but the effect on vomiting was insignificant. Dexamethasone also lacks sedative, dysphoric, and extrapyramidal side effects as associated with traditional antiemetics. And it has been postulated that dexamethasone, being an anti-inflammatory drug, reduces the local site inflammation. Therefore, it reduces the afferent signals, the parasympathetic signals to the vomiting centers, thereby reducing the postoperative nausea and vomiting. So, in conclusion, prophylaxis intravenous single dose dexamethasone, that is 8 mg IV, given preoperatively at induction, significantly reduces the incidence of postoperative nausea and vomiting in patients undergoing laparoscopic cholecystectomy. And this may be very beneficial in the daycare surgery, with laparoscopic cholecystectomy for gallstone disease being the most common elective surgical procedure in general surgery setting. However, more such studies and meta-analysis are required to establish the efficacy as well as to bring the same in the standard of care in the long-term future. Thank you. I'm thankful again for giving this opportunity to present this paper in such an international platform. Thank you.
Thank you for that amazing display of medical brilliance. I would now request our esteemed jury members to please begin the question and answer for the presentations we witnessed. So, calling on the first finalist of the day, Dr. Naveen Kumar, handing it over to our respected jury members. So, if you can please start with the Q&A round for Dr. Naveen Kumar.
So where is Naveen? Where is Naveen? Can't see him on the video. No, can you hear me? Naveen's video. Hello, can you hear me? Hello. Hello. Can you hear me? Yes, yes.
Yes, we can hear you.
Where is Naveen? His video is not on.
I please kindly request Dr. Naveen Kumar to switch on the camera so that we can start Q&A round. Dr. Naveen Kumar, if you can hear me, please. So please, I will request you to...
Naveen, hi, are you on? Naveen, where are you?
Okay, I think we are facing some challenge with Dr. Naveen Kumar. No, but I think we can come back to him later on. We will move on to our second finalist of the day, Dr. Nitesh Kumar. Dr. Nitesh Kumar, please be ready for Q&A round. Particularly members, we can proceed on with Dr. Nitesh Kumar. Thank you.
Nitesh, is your video on?
Yes, sir.
Hi. Can you hear me?
Yes, sir. Good morning.
Hi, morning. Hi. I'm Dr. Sudhindran. Excellent study.
Thank you, sir.
You mentioned that your study confirmed the Helsinki Principle Declaration. Do you know what that is?
Yes, sir.
What is it?
Sir, it was a declaration done in Helsinki that study will be done according to the following protocol, considering all this ethical committee guidelines and no duplication of the materials or copying. This will be done.
Not about duplication, but what is the essential basis of the Helsinki Principle, Helsinki Declaration? What is it trying to achieve?
Helsinki Declaration. Actually, I have read that earlier during that submission of my paper. It's mainly based on that the study will be done on an ethical principle and this animal harm and patient privacy and these things will be taken care of.
Yes, essentially patients protect the patient's rights. Identity in Nazi times, they were actually, a lot of patients are actually under, they were in the trial against their wishes. So it basically maintain the patient's informed consent, patient's right to be in the trial, etc. Okay, so what was your randomization technique? How did you randomize?
It was a computer-based randomization. Yeah.
So what is allocation concealment?
Yes, allocation concealment is that we give a concealed envelope. It can be done on a two basis that the allocator is also concealed, but to the patient, it's given in a sealed envelope, and the allocator also doesn't know that what is inside, and the patient also will not know.
So how is it different from blinding?
Blinding is that allocation. Blinding is suppose sometimes we know that this code stands for this. If we say that A, B, C, and D, that A stands for this. If the person knows that A stands for this group, then we might be biased towards that. But if allocation is concealed, but it's given a sealed envelope, even the allocator doesn't know. And his allocator blinding is more efficient. And we know that.
Okay, it's slightly different. Blinding is actually happens after the allocation. See, once the allocation is done. Allocation is basically to avoid any selection. Selection bias, not the selection bias. It's actually you can read about it. Anybody else any questions? I'm done.
Yeah, and can you hear me?
Yes, we can.
Yeah, so Nitesh, what was the basis of your selecting? Because in one of the tracks you have talked about 2 weeks and 4 weeks, and I think there's some of the studies that you quoted in the discussion. There have been variable time periods that people have used these drugs for. So, what was your basis of zeroing in onto?
Study was done by Dunning itself, in which he showed that 2 weeks of finasteride, he studied the microvascular parameters and the histopathological parameters also, and he studied that both the clinical and histopathological results are obtained just within 2 weeks. And also when we give finasteride to stop bleeding, most of the studies they found that for this prostatic related bleeding, the bleeding almost stops in between 13 to 14 days. And several studies I have found that even when they give for 2 weeks or 4 weeks, almost the result is same. Mainly based on this pathological study and color Doppler study and the studies of the previous researchers to stop the prostate related bleeding, which was achieved in around 2 weeks. I targeted this time period. And also when the patients come, long wait time with police separation, or for him, if you want the surgery, waiting for the 1 month or 2 months is difficult for them. So I wanted to see the effect in 14 days.
Right. And what has been your practice in terms of the in terms of your, I mean, prior to the study, what was your practice? And prior to your practice after the study?
Yes, the patients were given alpha blocker. Those who are not responding, even if they come for surgery, even without any history of, without giving history, is ready for the surgery, we will take up the patient. But we found that blood loss was more. So we started giving Docplexus or finasteride in trial basis, because in our setup, sometimes few of the patients will have some long waiting time. So those patients who waited for around 14 days, either due to cancellation or something, we found that the bleeding was much less. So we thought that with selective.
Sorry, I'm not clear. That seems like that you were not so much worried about the bleeding at the time of surgery. Only thing is, patients who needed to wait for one or the other reason, you resorted to giving them dutasteride or finasteride. Is that right?
Before we started doing this study, before that we found that this difference was there. But those patients in whom we took them for surgery 1 or 2 days after receiving them without giving preoperative dutasteride, they bled more. And those patients who were cancelled due to some reasons or were unfit, they had some longer time or taking the drug. Those patients we found they were bleeding less.
So post study, what is your current practice now?
Yes, sir. So,
post study now, what is your current practice?
Current practice, I always give the patient dutasteride or finasteride. Both the drugs are equally efficacious, and currently I am giving all patients dutasteride for 2 weeks, and then I am taking for surgery.
Okay, and do you think that in that scenario, were the patients which were in the placebo group were denied the standard of care? Or what would you?
No, sir, because it's not established practice. Current EU guidelines doesn't have this mention that this finasteride or dutasteride should be given. So the patients are told that that you might be in one of the two groups. There won't be any issues. They were told about the complication that this might arise. Do not think that there is denied standard of care.
Right, and is there any study which talks about that? What is the current day practice in most institutions to use it or not use it? I understand that there is not a kind of standard this thing to say that you must use it or not use it, but what has been the current practice? Something like bowel preparation that people talk about.
It's still debatable, it's still not clear, and because most of the developed countries are switching towards the laser prostatectomy, and worried about these drugs and doing the study in a larger number or bigger trial.
Right. Okay. Over to the other jury members. Dr. Dev.
Thank you.
Yes. Thank you. Thank you. Thank you, Dr. Nitish, for a wonderful presentation. Could you just tell me what are the drawbacks or problems with surgical trials, vis-a-vis drug trials or hormone trials?
Drawbacks are sometimes this pharma trials can be.
How do you classify your trial? Is it a drug trial or a surgical trial?
It's a surgical trial, including drugs. But when pharmaceutical trials are there. They may pay me or pay the company to turn the results towards their favor. This is the most problematic. I have not done anything like that, but you are just.
The scientific drawback of organizing a good surgical trial. Okay? The drug is you prescribe a dose, you can blind it, you can give it.
Yes.
Can you do that with surgery?
No, sir. Surgery is no, sir, it's not possible because every surgery is a new thing, and we might face a different scenario at every thing, every case. So case-to-case variations will be there.
No, not case to case. Surgeon to surgeon.
Yes, sir. Varies from surgeon to surgeon only. So we include all the 4 surgeons, those who are included in the trial, were almost of the same duration of training. There will be some variations, but we try to keep it to a minimum difference or variation.
Okay.
They were trained at the same place.
Okay. How do you control quality in surgery?
The quality in surgery is sticking to the standards or predefined protocols that will start with this process, will do the resection in this manner, or will stick to the principle that will do a good hemostasis.
What are the 3 components of a quality outcome assessment? Can you tell me? What are the 3 components if you want to assess the quality of surgery?
I don't know.
Okay. The structure, what structure you are working, the process, in what process you do the thing, then you see the outcome. Okay.
Okay.
So these 3 are important for quality. These are very important to study quality control issues. And in your conclusion, you also said the operative medical management may reduce the bleeding. Why did you use the word may reduce?
May reduce because our study
has shown what is the outcome of your study?
Outcome is we found that preoperative reduced reduced the bleeding, but because we have done in 60 patients of each group, so we cannot give a conclusive statement because many randomized trial RCTs and these are not still have a definitive statement. So we cannot give a definitive conclusion based on this.
Okay, how do you determine the sample size?
A sample size we can determine by taking the prevalence of bleeding. We took it around 10%. We found it around 213 patients would be enough. We also took the reverse way, calculating the power of the study. We took a power of the study at around 90% with the prevalence of 10%. We found it around 230 patients.
I'm so sorry to interject the amazing discussion going on here, but the 10 minutes for the webinar is over, so I will have to join.
I think I have 2 questions reserved for him.
Okay. I will come to one question. I just
Nitesh, in your first slide, you have shown Sushruta and you. What are the common elements that you think you have to become the next Sushruta?
The quality of the surgeon is to know first and cooperate. It takes they take some time or a few years to know whom.
My question is very specific. Why you should be, besides Sushruta, especially the black line joining the 2 photographs?
I want to be a great surgeon like him, and I wish that I would make India's name again in top of the world like Sushruta.
My last question is, you are given a video limit of 20 minutes. Your video is more than 20 minutes. Your comments.
Sir, I recorded it around 19 minutes.
It is more than 20 minutes as given to me.
Sorry sir for that. Last time I recorded the video in 19 minutes 30 seconds.
I don't know.
If it is more, I'm extremely sorry, but I recorded it in 19 minutes 30 seconds.
No problem. Okay, thank you. 19 point something.
Yeah.
less than 9, less than 20. Yeah. Okay. Only one question I am asking. It is. Yeah. And also one question. This is a good study you have done. Only one question I am asking that your blood transfusion, you have mentioned that this is less than 9 grams. But everyone is having that you saw the hemoglobin level.
Yes, sir. So patients were continuously bleeding or there was bleeding during post-operative time and hemoglobin was repeated and those patients whose hemoglobin was less than 9.
Earlier, what I am telling, one is the prostate side, another is the hemoglobin. With respect to your transfusion and for liquid volume you are losing. These two things you have not mentioned anywhere in your study. This is all in mathematical studies.
I didn't get your question, sir.
This earlier value of these patients like hemoglobin and prostatic size and volume.
Yes.
They just mentioned in the evaluation.
It has been mentioned that hemoglobin before TURP and after 24 hours after TURP and the prostate volume also has been mentioned, sir.
Okay. Okay, that's it.
No. Thank you, sir. And thank you, India's Medtronic and India's Next Sushruta for giving this platform.
I think Priyanka,
Thank you.
yeah. Probably in one of the the pictures you can keep that countdown of the timer can
yeah.
So that you know that you're not starting from 10 minutes or something.
Okay, sir. So I'll keep that up.
So that the among us jury also we can kind of organize the timing.
Sure, sir. I'll do that.
Shall we go to?
But that was an amazing discussion. Thank you so much, Dr. Nitesh Kumar and our esteemed jury panelists. Amazing to have to be listening to this amazing discussion. So I will now call upon Dr. Rasheen Datta to take the next Q&A round with the jury panelists. Please, Dr. Rasheen Datta, if you can come on stage. Please switch on the video, please.
Good morning to all respected jury members.
Rishi, hi, morning.
Hi, good morning, sir.
Very nice presentation, and Dr. Sudhir.
Yes, sir.
So, in your study, you have mentioned the weaknesses as single institution study, less number of patients, and short duration.
Right, sir.
Do you think any other major weaknesses are there in your study?
And sir, the same surgeons have, the surgeries are performed mainly by the same surgeon. So we are also not being able to observe the inter-surgeon variability. So that was another weakness. It was the same team operating, sir. And also we looked upon one particular demographic. It was mostly an Eastern India based study, sir. So that was another point. We want to look into other parts of the country as well and other surgeons. So we can randomize them and we can validate the results further.
I think the biggest weakness is how do you select your patients for open or laparoscopy? How does that go?
Sir, actually,
who decides that?
Sir, it was actually randomization, mainly computer-based randomization, and mainly we wanted to prevent any selection bias. So we took all the patients so that the parameters like the performance status, these were same, and then it was randomized based on the computer-based software, sir.
So it was randomized, was it?
Yes, sir. The computer-based randomization, sir.
All right. Okay. What about how did you determine the sample size?
So we studied the prevalence and the incidence of the particular disease, and then we, with the help of the statisticians that we had, we calculated the sample size, and to have a good result, we calculated with 40. But after studying
in your presentation, it doesn't say it's randomized.
Sir?
In your presentation, it doesn't say it's randomized.
Yes.
It is not mentioned.
Sorry,
it just says sample design, 2 groups are compared on various clinical and pathological aspects. Where does it say it's randomized study? Do you think it's important to mention that?
Yes, sir. Sorry, if I have missed out.
Why is it not mentioned?
It's not mentioned.
So who randomized? When did you randomize? What was the technique of randomization?
Sir, we actually first studied the epidemiology and the incidence of the disease in the population, and then with the help of a statistician in our group, we randomized it.
How was the random? What did you explain to the patient? How did you get the consent of the patient?
Sir, we explained the advantage and disadvantage of both the open and the laparoscopic techniques to all the patients. And
so, what are the advantages of open compared to lap? How did you tell the patient?
So since most of our patients are a little unwilling to take, they have a little doubt about the laparoscopic techniques. So we told them about the benefits and also the open surgery, that mostly that since most of the surgeons where we have till date had done open surgery, so that was our advantage. So we explained to them. After that, after having been explained all the points to both the techniques, and after once they have agreed to it, then only we proceeded with the study, sir.
But Rishi, it is mentioned it's a prospective observational study in your material method.
Yes, sir.
Yeah, it says institution-based prospective observational study.
That's what it's meant.
It's a completely wrong thing to write if you're saying it's randomized.
Okay, Rishi, hi, I'm Dr. Saklani. How are you?
I'm fine, sir. Good morning, sir.
Good. I think it's a good audit from your side to look at what study you've done and what are your outcomes. So that looks okay. You see, there are many trials which have already been done comparing laparoscopic versus open colon resection and rectal resection. When you want to do a study, why would you do this study? It has already been done. It has been 20 years. So you have to, what is the reason for doing this study? So you have to do a study which is relevant. So give me one reason why you would want to do it.
So yeah, there have been similar studies, but studies of such kind is rare in our, in this Indian or the Eastern Indian setting and in our population. So we thought maybe if we can, and also since laparoscopic surgery are not much performed by surgeons in our institution, so we thought that maybe if we can compare this data in our setup, we can also validate the result with the studies that is already prevailing worldwide.
That's right. So when you do the study, so this is almost a surgical study. Now we know this is a prospective observation study. So if you wanted to do it, you had to calculate a sample size and things like that. So when you do that, then you would tell about the surgeons, how many surgeons were there, what was the experience that they have, because there is a learning curve for, what do you think is the learning curve for lap colorectal procedures, and had they already crossed the learning curve?
So all the surgeons that were involved had performed less than 50 surgeries, and there was a team of around four surgeons mainly that had performed all the surgeries for this particular study, sir.
I think the sample size is slightly on the smaller side.
Yes,
and then you club colon and rectum together. There are a lot of other parameters about chemoradiation and things and things. So I think you have to look at it. I think for all these ones, probably you can do a propensity case match analysis. That would be better. And there are a lot of things. When you put your results forward, you compared the demographics and then you look at outcomes. You compared some of them, the results, you put it in the conclusion side or in the discussion side. The other thing is you haven't put the stage of the tumor anywhere actually. You see, for the stage of the tumor, if at 2 years you had no recurrence at all in colorectal cancer, means I think most of them would be stage 3. Means then 100% disease-free survival at 2 years is a miracle, I would say. Okay,
so actually the follow-up was mostly for 1 year. I mean, all the patients had completed 1 year of follow-up.
Even in the best hand, it would be 70% DFS, so 30% would be there. Okay, so anyway, good effort, good audit, and good results. Thank you. I think I'll let it to my colleagues.
Thank you, sir.
Sir, I will have to again let you know that only 1 minute is left for the Q&A regime.
Can I put in a couple of questions? Hello?
Yes, sir.
Yeah, hi. I think there are 2-3 points that I wanted a clarification from you. I mean, aim of the study you mentioned. Now, it has to be very clearly defined. You can't really say that, to understand the advantages and as well as disadvantages of laparoscopy over conventional open surgery in colorectal malignancy. That may be the background to see and define the various factors that you're going to study. And so one is that. The second is that maybe you can answer together that you have a mixed group, because as I see that 24 patients with C rectum And then colonic malignancy, I think there were 11 and 5, which were right-sided and left-sided.
Yes.
And also, I think there is probably, if you compare the open and laparoscopic, probably there is a higher number of rectal tumor, I think, in one group. So I think, do you think that that may have skewed your data? So you answer these two, and then I'll just ask one more question.
So yeah, the number of rectal tumors were more. So and as you rightly pointed out, sir, that might have been a little limitation of that calculating part also, sir. But as I already told, sir, that it was the assessment that we have done and assigned the patients, and that might have been a little problematic on the statistical part.
Right, and I think, as you were asked earlier also, with the aim of your study now that laparoscopy being well established in this, especially for colonic and rectal tumors, is there a new message? And if what your conclusion ultimately is that probably there's a case for resorting to laparoscopic approach more often, then have we really denied that advantage to the other patients, or was that part of your informed consent that you did mention to them that what the status of laparoscopic surgery today is for colorectal tumors?
Yes, sir. In my institution, particularly, patients are not really very much enthusiastic about undergoing such laparoscopic surgery. So we had to really explain to them the advantages and then take their consent. And as I have already told that such study is rare in our setup in Eastern India or Indian setup. So, and also the surgeons performing them were who have performed less than 50 surgeries. So after looking into this study, what we came to the conclusion is that yes, if performed meticulously and with increased time, we can definitely provide them with the advantages. And after the surgery, some of the patients were really happy with their outcome.
Right. So in the light of your comment that probably a propensity score matching, as Dr. Dalvi said, might have been more prudent rather than randomizing, because which would mean that probably some people who were keen to get laparoscopic surgery were also put into that open surgery group.
Yes,
anyway, I'll pass on to the other jury members. Thank you very much.
I have only one question, Datta.
Yes, sir. Good morning, sir.
Are you doing your...
Hello?
Oncology.
Sir, I couldn't get your question.
Are you doing your MS general surgery, or
yes,
are you doing a subspecialty like surgical oncology or surgical gastroenterology?
Sir, I am doing MS general surgery.
Thank you.
Thank you, sir.
Okay, sis.
Thank you so much for that discussion. Thank you, Dr. Rasheen Datta, for answering all the questions.
Thank you to Medtronic and Docplexus. Thank you so much.
So I'm going to move on to now Dr. Syed Mustafa. Dr. Syed Mustafa, please, if you can switch on your video and answer the questions of our jury panel.
Hi, Syed. Hi. Good morning. Hi. Nice presentation. Nice trial. So you say double-blind randomized control trial. How is a double-blinding? What are you blinding?
This being a surgical study, sir, the blinding was at the subject level. The subject did not know which arm of the trial he or she was a part of. And at the interventionist level, the assessor of the wound infection, complication, and the wound's recovery was someone who was not a part of the surgical team. So of a different unit. So we have 8 different surgical units in our teaching hospital. And we coordinated with my colleagues to have the assessment from a blinded person who was not a part of the surgical team. So that way it was double blinded, sir.
Thank you. What about your samples as your randomization? Could you just explain on that?
Yes, sir. Computer generated randomization was done.
How did you do allocation concealment?
Yes, sir. So allocation concealment would be to during the recruitment of the subject itself. So if the subject meets the criteria and is to be included in the study, then using this technique or the sequentially numbered opaque sealed envelopes are used with the random number to give to the patient to decide which arm the patient will be involved in.
Okay. So how will you change your management now? What do you use now? Diathermy or
So,
skin?
sir,
So why?
the
Because
idea.
in your thing, in the conclusion says it debunks the mystery. That means that you're probably biased to diathermy already.
Yes, sir. So the idea behind my study was to explore whether there is a significant difference or if the fear of using electrocautery for skin incision is warranted. So the design was a non-superiority trial. So it was not an equivalence or a superiority trial. I've just attempted to show that this is not inferior to the use of scalpel. So the surgeon's discretion should not be guided by an inherent fear or a bias of the unknown. So the fear of the unknown factor is what I wanted to reduce with the conclusion that I had.
But what do you have against scalpel? What is wrong with the scalpel?
Yes, sir. With the scalpel, there are a couple of things that are problematic. Most important for them, for the surgeon, and for the patient is the risk of Sharp's injuries. And secondly, it has been shown in some studies, like the one by Chrysos et al., that the surgical time, the duration of surgery is reduced with the use of a scalpel for skin incisions. Of course, we studied longer incisions of the abdomen. But then the second advantage is after less Sharp's injuries, it is about faster duration of surgery and lesser bloody operative field. So it offers a clearer field.
Thank you very much.
Very good presentation. I believe again you are a PG doing MS in general surgery.
Yes, sir.
Good. Now I have some other questions for you. Since you have worked on monopolar cutting current and coagulating current and told us about it, tell me something about bipolar energy.
So a bipolar cautery does not involve the patient in the electrical circuit. The tissue to be cauterized is held between the two tips of the bipolar cautery, and the current is delivered between the two tips. So both the electrodes are within that. There's no. It's called a field cautery.
Wait, Mustafa, wait. What are the 4 stages in which bipolar coagulation works?
Sir, I would have to hazard a guess here because I'm not aware of the exact stages.
Your topic is electrocautery, Mustafa. You cannot tell us cutting current is better to cut a skin and not know about bipolar coagulation at all.
I know, sir, but I cannot structure it in, say, 4 stages. I can explain the procedure as I've understood it, sir.
If you have used bipolar, especially for mesoappendix, you will visualize that first there is blanching, then there is boiling. Now tell me the 2 others.
Blanching, boiling, desiccation, and coagulation, sir. I'm not very sure, sir.
It's okay. Does not matter.
It's charring at the end.
Yeah. So there is carbonization after boiling, and then there is charring. Tell me, when do you exactly stop when you are using bipolar?
Visual charring is what we have. What I have noticed is the endpoint.
That is the last thing that you do. My last question to you is, why have you preferred polypropylene as the suture material to suture the skin?
So polypropylene, being a monofilament, would reduce another degree of confounding in my study. Had I used a polyfilament or a silk suture, I would have to also account for that in my explanation. Using polypropylene reduces the chance of wound infections in the post-operative period.
Why not polyamide?
So that is what is available at my teaching hospital.
Say that as the first thing.
Yes.
Okay. Because commonly what is used is polyamide rather than polypropylene, because polypropylene is costlier than polyamide, at least in our country. Next jury, please.
I will have to quickly remind that we just have a minute.
Yeah, just quickly, I'll ask a couple of questions.
Yes, sir. Please go ahead. Please.
One of the things is that I find it a bit difficult to understand that the blood loss and the duration of surgery is going to be so drastically different whether you cut with a diathermy or a knife. And as I understand that in your methods, I think it's the superficial layer that you are cutting with either the diathermy or the knife, because I would understand that going through the subcutaneous tissue and other things, you must be using diathermy. Isn't that right?
Yes, sir. So I would concede that the other two factors are not drastically different, but I have included them because other studies have studied and found marginal differences. So I added them as supporting features that add to it, but I would agree definitely that they are not great advantages of one over the other.
I think for the inguinal hernia, you will have to, time it within microseconds or something to really get a difference. So I think,
Yes, sir. Yes, sir. That was
that. And would that really be clinically or practically beneficial? And the other thing was that it looked like, as what Sudhi talked about, that probably you have had a bias towards diathermy because you were trying to still that. Is it a well-established practice? We know that several centers use it. But did you quote any study which says that, yes, now it is as good? I mean, you went on to show the benefit of one over the other. But is it now a standard accepted practice to cut this with a diathermy?
Sir, because what I intended to show was non-inferiority, standard accepted practice is still what is conventional. The studies I've quoted are not making strong recommendations of one over the other. They're saying that it is as effective, if not superior, to the use of scalpel. So the recommendation grade, the strength of recommendation is not very heavy on any side of the scale. It leaves to the surgeon's discretion. All it says is that the myth of skin incision with electrocautery being harmful.
I think I'll pass it over to the other jury members in the interest.
I have one question.
Sir.
Yeah, Priyanka, I just need to ask one question for that.
Yes, sir.
Please. Mustafa, let me see, because you want to become the next Sushruta. Do you read history of surgery?
Yes, sir. I do like history of surgery. I have read.
Can you just tell me what are the methods to control bleeding before the advent of electrocautery?
Before the advent of electrocautery, sir, the French surgeon Ambroise Paré introduced ligatures for the first time. Before that, the oldest method, of course, is Hippocrates using thermal branding irons to coagulate and burn wounds. That's the oldest traditional method in battles. And then its use of ligatures, use of pressures. Pressure is the instinctive method even by non-medical people. These have been used traditionally, sir.
Any chemicals used?
Yes, sir. Chemical cauterization has been used by using caustic substances that burn the skin. And
okay, very good. Thank you.
Thank you, sir.
Can I ask one question?
Yes, sir.
Mustafa, this is a good study, but that what hypothesis you are showing that this is with the scalpel infection is more than your cauterization?
So the null hypothesis of my study is that it is
because already this is the aseptic conditions you are taking both.
I'm sorry, sir, I couldn't catch you, sir.
Yeah, your infection rate is more with the scalpel. This is the what hypothesis you're giving, that this is why it is more with the scalpel than the tubes.
Sir, not just infection rates. I'm studying wound recovery as a whole, which includes early postoperative pain and the incidence of infection and the quality of the scar that is eventually formed. So on all these three parameters, both these were compared, sir.
Yeah, that's what I'm telling. There's an infection rate is your high with the scalpel use.
No, sir. On doing the statistical analysis, the p-value was higher than 0.05. So I wouldn't say that there is a statistical difference between the two arms as per infection rates. Yes, the raw number shows that it is 5 in one group, 7 in one group, but 5 and 7 in a sample of 50 is not statistically significant, sir.
Okay. Okay, thank you.
Mustafa, your study would have been good if you had included BMI as one of the components. Let me tell you that.
Yes, sir.
Mustafa, one more thing. There are already 6 RCTs done for it. Why do you want to do it? India is such a poor country. You need to investigate things which have not been done. There are 100 things to be investigated. 6 RCTs already there and you're doing the same thing. Why make a washing machine when there are 100 companies?
Sir,
thinking is important.
Yes, sir. I could be more innovative, but I believe science progresses in small bits and pieces. This is my small contribution to it, sir.
Okay. Anyway, next time think better.
Then you should stop using chromic catgut, my dear.
Yes.
Priyanka, I think we are well ahead of time. So if we take 1 or 2 minutes more to judge a candidate, please allow us to do it.
Yes, sir.
Yeah,
Definitely. I completely
more
understand.
restricted, I think.
No. This is necessary, of course, to
Assessment
understand
paper,
their thought process. Yes.
Move to the next.
So, if I can, with your permission, proceed on to our next finalist.
Please.
Yeah. So, thank you, Dr. Syed Mustafa, for that discussion, and I will move on to now inviting Dr. Prateek Kumar Jha for the Q&A round. Dr. Prateek Kumar Jha, if you can switch on your video, please.
Yes, very good morning to all the respected jury members and my fellow colleagues.
So, Prateek, do you think your study will change your management? I mean, what you and in your conclusion you have said actually decreases post-operative nausea and vomiting, but the vomiting there was no difference at all. So it just changed your nausea a bit. Is that right?
Yes, sir. In our study, that is what we concluded, that it did not have any significant effect on vomiting. But there are other RCTs that they have shown that they in their study they have reported that they have significant statistical difference in vomiting as well.
Well, you have to conclude from your study, but that doesn't. Yes. So, do you think you will continue to give that? And if so, why? Because it doesn't change your admission rates.
In our setup, yes, sir. We have implemented this as a drug during the time of induction, and because we want to give less stress to the patients and we want to discharge early to the patients who undergo laparoscopic cholecystectomy. So we have instituted this as a medication to prevent post-operative nausea and vomiting just before induction.
So who prepared this placebo and who gave the injection?
Sir, the placebo, that is the placebo as well as the drug, was prepared by a nurse, separate nurse, and the injection was given by an anesthetist who was blinded regarding whether it was a placebo or a medication, sir.
Okay, thank you.
Okay, Prateek.
Yes, good morning.
Yeah, and is there any change of dose for any patients? So this is a fixed dose for all the patients.
No, sir. In all the patients, that were between 18 to 80 years without any comorbidities, this was the standard dose, single standard dose of 8 milligram IV that we gave, sir.
Okay, that is given by the anesthetist or you?
It was given by the anesthetist, sir. The anesthetist consultant in charge who was blinded regarding whether it was a placebo or the drug given.
Okay, because this is already established in the chemo patients, like
yes,
patients, yeah.
Yes.
Okay.
So
next.
Yes, Doctor.
Yes, Doctor. Yeah, Prateek, could you tell me what are the surgeries you are worried about if the patient is having severe nausea and vomiting regarding the surgical outcomes?
Sorry, sir. Can you please repeat your question?
What are the types of surgery you will be worried about surgical outcomes if the patient is having severe nausea and vomiting?
Sir, mainly in the upper GI surgeries, wherein like where we
you don't want to strain your patient to strain too much.
Yes, sir. And the common surgery in the general practice would be the hernia surgeries, wherein we would like avoid straining in the early postoperative period. Similarly, in the patients who have a laparostomy or a patients we have undergone tumor control surgery would ask to the patients and we would avoid straining.
Okay.
Dr. Dev is trying to ask you a very specific question. As if there is vomiting, your whole procedure will fail instantly. What is that operation? Usually done laparoscopically.
Upper procedure.
Upper GI procedure.
Sir, fund application, sir.
Thank you. Can you? Yeah, Agarwal, go ahead, Anil.
Please go ahead, Dr. Dan.
No, I just want to ask him definition of regression analysis. You have done regression analysis, so I want to know.
Sorry, sir.
Does not matter. Does not matter. Now your results boil down to only nausea, and there is no statistical difference between vomiting. Why have you clubbed them together, calling them PONV?
Sir, in our study, sir, the post-operative nausea was a subjective assessment and vomiting was an objective assessment with number of the vomitings. In all these studies that we have had before, sir, they have reported in both the segments. So that is what we wanted to analyze to see whether there was any effect on both nausea as well as vomiting. However, in our study, we only concluded that the effect was only on the nausea aspect.
So will you practice giving dexamethasone to every patient who is undergoing laparoscopic cholecystectomy?
Yes, sir. That is what we have instituted now, sir, in all the patients that undergo a laparoscopic cholecystectomy.
Nausea and vomiting.
In all the patients, sir, pre-operatively, we give it as a prophylaxis drug, sir.
Okay, Anil, take over.
Yeah, I think, again, the question that he was just asking, that 4 patients in each of the categories had vomiting. And the nausea had decreased, I think, in the group in which you gave dexamethasone. Now, did you want to compare it with other standard of practice or what you have been practicing for reducing the post-operative nausea, vomiting, before saying that dexamethasone scores over others and this is the way to go? And the second thing, again, it's a small percentage of patients which develop this post-operative nausea, vomiting. So if you want to reserve it to, because there's nothing to say that if you started pre-operatively, it will have an impact. Like the question that you were asked about upper GI procedure.
Yes.
Why not reserve it, even if you wanted to give dexamethasone, as and when if any of those patients develop symptoms? First you answer that, then I'll ask you just one more question.
Yes, sir. In all these studies, all the RCTs that have been performed earlier, sir, they have used a dexamethasone as well as serotonin receptor blocker, which have together reduced both nausea and vomiting. However, in our study, we use only dexamethasone and a single dose. In those studies, the doses were also variable, sir. So the effect that we found was on nausea and not on vomiting that was statistically significant, sir.
So that's what I'm saying. Why not compare it with something else also? I think what have been maybe MSET or anything else that you want to do. And the second thing is also that probably you could have titrated some of the other factors, because post-operative nausea, vomiting may be a reflection of various other things in terms of pain control, in terms of duration of surgery, in terms of BMI and other things. So I think probably you need to match that and probably compare it with some other drug before we could say that this is the way to go. And dexamethasone is and because from your study you can't really conclude, because the vomiting incidence was almost similar, only the nausea was a little lesser in the group in which dexamethasone. So I think I would be a bit skeptical of putting that into my practice to say that in all patients of cholecystectomy I should use dexamethasone. Would you counter that, what I just said?
Sir, regarding the second part of your question, sir, in both the groups, we try to assess whether there was any confounding effect of pain, intraoperative bile loss, the age, the duration of surgery, the amount of CO2 insufflated. So it was compared in both the groups, in whether the patient had nausea or didn't have nausea, and the placebo group where the patient had nausea or didn't have nausea. So in that comparison also, there was no statistical significant difference that indicating that the outcome that is there, that is decreased, statistically significant decreased nausea, that is most likely attributable to the dexamethasone dose that was instituted, sir.
See, Pratik, what Dr. slides, that the escape route was metoclopramide.
Yes.
that is what tells you that you could have compared it with other drugs as well. Anyway, does not matter.
Yes, yes.
You are also doing MS general surgery and not a super specialty, right?
Yes, sir. Yes, sir.
You are a resident doctor doing MS general surgery.
Yes, sir. Yes, sir.
Okay, thank you.
Thank you, sir.
Pratik?
Yes.
Can you tell me, Sushruta is a surgeon or a physician?
Sir, he was both a physician as well as a surgeon. He was both a physician as well as a surgeon, sir.
What is the name of the book he has written?
Sir, it is called the Sushruta Samhita, sir.
What is the surgery is most famous for? Rhinoplasty.
Rhinoplasty. Yes. Thank you. Thank you. Thank you.
Okay.
I think we can go on to the next candidate if at all.
Yeah, and we have finished 10 minutes, I think. Priyanka, we are right on time in this case.
Yes. Okay, thank you so much for that discussion, sir. And we have our last finalist now. I will go back to Dr. Naveen Kumar. Let's check if he is available, if he's not facing any more network issues. Dr. Naveen Kumar, if you can please switch on the video and let us know if you're available for us.
I can see him.
Yes. Good afternoon, everyone. Yes.
Yeah.
Yeah, all the jury members, I would like to excuse myself because he was my student, so I will not be participating in the Viva for Naveen.
Sorry for it.
So Naveen, your questionnaire study.
Good afternoon, everyone.
Who explained all the thing at the beginning about the information? Who gave the information in the beginning?
Yes. So it was my study. I personally give information to the patient in group of 5 to 10. After finishing my OPD, the OPD chamber itself.
Okay, everybody, you gave it. You told everybody that, just you, nobody else.
Yeah. Yes, sir.
So how do you think it will change your general management? You know, explaining all this, how do you think it will change your management?
Yes, sir. So country like training is not for the resource constraint
Naveen, your video is not clear.
Not going coming early.
Well,
Yes, sir.
I
think his video is a problem. I think his connection is a problem.
I personally feel let him go. Naveen, if you can hear me, please go to some place where you have good signal and you can come in at a later date in the afternoon session, if all the jury agree.
Yeah, sure.
Yeah, that will be better.
Yeah, Naveen, please move away from the place where you are. Go to a friend's place or some institute where there is a stable internet connection. Even I am facing this problem, but I am shifting between my laptop and mobile. But you also do the same thing because you are contestant. I can be substituted.
Contestant and jury is all right, but you can't be substituted, Dr. Adani.
Shall we move to the
stable, and then we'll give you a chance. Don't worry.
So I think we can maybe move on and have the next set of 5 presentation and then include him in the next.
Yeah, Priyanka, we can move to the next 5
Yes. Yes.
What time is the next one? When is the next time the jury is meeting? What time are we meeting again?
5, 10,
We have the next round of presentations Shoot for 12.
What time do the jury meet for next question answer session?
2 o'clock, I was told.
No, maybe now it will be sooner because I think 5 presentations. So what, 100 minutes? So maybe around
1.5 hours.
1.5 hours.
So the next round of presentations will start from 12:40 p.m. That's the agenda that we're going to follow. So for the next 5 presentations.
But why don't we start rather than 12:40? Why don't we start that now?
We can do that. We can do that. If you're all okay to
A2 at 1:45 or something. Yeah.
fine. So we can do that. So if you're all okay with that, we can start the next set of presentations then.
I think now we should start better. Yeah, we should finish it better.
Okay.
Yeah, you see, you can start the presentations now, and we can join back by 1:30 and finish the QA by 2:30.
Okay. So
1:30 won't finish, no?
If they start
20 minutes into 5, so 100 minutes.
No, but all of them are not 20-minute presentations, so I think that may be okay. So I think by 1:30 we can reconvene. Yeah.
I think the remaining presentations are hardly, it's like a paper presentation, 8 minutes, 10 minutes, 12 minutes.
9 minutes.
Okay, so 1:30.
And one of them is unedited.
Yes. So I think
So sir, I will start with the next round of presentations with all your permission, and I would like to now invite Dr. Shankar from Madras
so
Medical
meet
College.
again at 1:30. 1:30. Yeah.
So we'll proceed with the next round of presentations, sir. I would like to now invite Dr. Shankar from Madras Medical College, Chennai.
Hi everyone, good afternoon to all. This is Dr. Shankar, Institute of Surgery and Gastroenterology, Madras Medical College, Chennai. And today, my topic of presentation is management of traumatic pancreatic injuries by single center experience. Moving to the introduction. As you all know, the traumatic pancreatic injuries is a rare event. The isolated injury is a very rare event. And the rarity is due to its retroperitoneal location and the subtle early clinical presentation, which frequently leads to delay in diagnosis as well as the treatment. Developing countries like India, most of the time it is caused by blunt trauma to the abdomen following a road traffic accident. And the incidence of isolated pancreatic injury is more in concordance with the blunt trauma abdomen rather than the penetrating injuries. Due to the methodology of the study, it is a retrospective analysis of prospectively pulled data of the patient with a traumatic pancreatic injury managed in our center from January 2015 to December 2019. And it includes variables such as patient's demographics, mode of injury, and the grading of pancreatic injury according to the American Association for Surgery of Trauma organ injury scale, and associated injuries of other organs, and mode of treatment applied, and the duration of hospital stay, and morbidity, mortality also taken up. The results, totally 32 patients have been put in our study, and out of 32 patients, males are more population than females, around 87%, and the age group varies between 10 to 55 years, the mean age being 26 years. All of the patients in our study have blunt trauma to the abdomen, such as road traffic accident, assault. None of the patients are penetrating due to the abdomen. Out of the 32 patients, 12 patients are directly admitted in our institution, and 20 patients are referred to elsewhere for expert opinion and further management. And the patients are divided or convened into 3 groups: mild, moderate, and severe, according to the grade of the pancreatic injury sustained with the patient. In grade 1, grade 2 considered as mild, and grade 3 as moderate, and grade 4 as severe, out of which grade 3 injuries are more about 78% rest of the injuries. Out of the 32 patients, 50% of the population, 16 patients had associated organ injuries, cutting the spleen, most common organ, getting involved along with the pancreatic injuries, followed by liver, and then halavascular injuries, followed by the facial, maxillary, musculoskeletal, and other injuries. Coming to the management of the patient, 2 modes of management have been applied. One is the conservative or non-operative method of management. Another is operative mode of management. In the non-operative mode of management, the patient put in oral, given liquid IV fluids, opiate analgesics, IV antibiotics, ERCP, pancreatic stenting, and percutaneous catheter drainage, or any post-pancreatic related collection. Coming to the operating management, the patients, the distal pancreatectomy, the spleen preserving, distal pancreatic vaginestomy on the distal stem, and proximal stem closure of the serosal patch in patients with pancreatic neck resection, and cystogastrostomy for any post-traumatic pancreatitis induced pseudocyst, laparotomy and lavage external drainage in case of patients with abdominal hypertension, and go down on the picture showing distal pancreatic specimen. And another one is the picture showing reaction pancreatic vaginestomy in the distal stem and closure of the proximal stem serosal patch. This is a bar chart diagram showing the mode of management applied in different grades of injury, mild, moderate, and severe. But obviously, moderate to has been more of patients, and all the patients, most of the patients are received operating kind of management. And this is the split where the patient is split into two groups according to the timing of presentation to our institution, whether they presented within 48 hours since incident or more than 48 hours since incident. And out of the 32 patients, 17 patients are presented within 48 hours to our institution, and 15 patients are presented more than 48 hours to our institution. Coming to the patients who are presented early within 48 hours, pancreatic duct disruption represented in 16 of the patients. Of these patients, 15 patients underwent surgical mode of management, either of mentioned above, and one patient was managed conservatively, and that patient had readmission for recurrent acute episodes of pancreatitis. Will stay not because much between two age groups, two groups of mode of management. In 16 in surgery group, and 18 in conservative management group. And patients who presented more than 48 hours since incident. Out of the 15 patients, 7 patients were managed surgically, and 8 patients managed conservatively. And out of the patients, 11 patients had pancreatic duct disruption. And in this group, in conservatively managed group, 1 patient with mortality presented very late with intra-abdominal sepsis. The hospital stay was prolonged by a week compared to the patients who were presented early within 48 hours to our institution. After the discussion, pancreatic injury occurs predominantly in males and that in a young age group or productive age group. So this literature report also matches our study, and most of the patients are economically active. Management of pancreatic trauma take place in the center of expertise for better outcome. The pancreas most commonly is injured by a crushing force resulting in compression of the pancreas against a fixed lumbar vertebra, causing a transaction or a tearing of the pancreatic parenchyma, most common resulting in a rectal injury. That's why in our series, 78% of the patients have sustained a grade 3 injury where there is a pancreatic disruption around the neck of the pancreas. And around half of our patients had associated injuries involving spleen, liver, bladder injury, and other organs. In patients with pancreatic trauma, around 60 to 75% of the patients will have hyperamyonemia, whereas in our study, all the patients have hyperamyonemia, and it has been correlated with the imaging findings in CT abdomen and helps in identifying the pancreatic injuries. The key determinant in the management, it depends upon the integrity of the main pancreatic integrity is assessed by a contrast lens CT abdomen or MRCP or ERCP. Whereas in acute presentation, as well as following a trauma, contrast lens CT abdomen is the standard of assessing the patient, especially assessing main pancreatic injury in patients with pancreatic trauma. In our study, all the patients underwent the contrast lens CT abdomen, and we have identified around 60 to 70% of the patients with pancreatic injuries. And in 11 patients, we have done MRCP to identify a ductal disruption. So in all forms of the patients with either grade 3 and grade 4 injury, where there will be a ductal disruption, requires a surgical intervention for better outcome. So most commonly performed surgery in our group of patients is distal pancreatectomy and drainage, where the patient has less morbidity and mortality. And the preservation of spleen to be considered in all patients because these patients are of a younger age group and they are longer lifespan to prevent any further complications of post-splenectomy surgeries. In 3 of our patients, attempted a re-extended pancreatitis and the distal system and serosal patch closure for the proximal system. This is considered an alternative to distal pancreatectomy, especially in patients who have no associated injury and the patient will be hemodynamically stable for the purpose of preserving the pancreatic parenchyma to avoid an unnecessary exocrine and endocrine insufficiency in a hemodynamically stable patient. In our series, we have done this procedure for 3 patients, and out of the 3 patients, 1 patient developed a grade A pancreatic leak and is managed conservatively. Among the non-operative management, such as the early ARCP with ductal stenting, fruitful for the patients with pancreatic duct injury, and it avoids an unnecessary laparotomy and dissection. In our series, we have managed 1 patient with the ERCP pancreatic duct stenting. We have also 1 mortality in the conservative group, where the patient present on 29th day is performed abdominal sepsis. Hence, we recommend early recognition, the early diagnosis, and the early management of patients with pancreatic injuries, and especially a surgical mode of management in patients with pancreatic duct disruption. And the limitation of our study is that we didn't encounter any grade 5 pancreatic injury, and in such scenarios, literature suggests a damage control surgery is the main key to reduce the morbidity, mortality, and to increase the survival of the patient. The exocrine endocrine insufficiency following a pancreatic trauma is very uncommon. It also requires at least 80 to 90% of the pancreatic parenchyma to be removed for the patient to encounter exocrine or endocrine deficiency, and none of the patients have shown up exocrine and endocrine deficiency in the follow-up period. To conclude, pancreatic trauma is more common in young male patients and more commonly due to a blunt trauma abdomen, especially from a road traffic accident, and splitting into the low grade and high grade depending upon the pancreatic duct disruption. The low grade pancreatic injuries can be managed conservatively in a center of expertise. The high grade pancreatic injury requires a surgical mode of management by the people of expertise. And the early identification of pancreatic ductal injury along with early surgery for ductal injury remains a cornerstone for pancreatic trauma management for better outcome. And when operative intervention is required, effort should be made to preserve the pancreatic surface as well as the spleen, and the delayed presentation will result in high mortality. Following are the references for my study. Thank you.
Thank you, Dr. Shankar. Now, I would like to invite Dr. Niharika from Andhra Medical College, Visakhapatnam.
I am Dr. S. Niharika. I have recently completed my post-graduation from Andhra Medical College, and I am here to present my topic for India's Next Sushruta finals. My topic is Indicators of Proliferative Breast Disease with Atypia in Perimenopausal Women, the need for identification and a closer follow-up. Coming to the introduction of my study, many epidemiological studies of breast cancer have shown that a history of benign breast disease increases the risk of cancer. Mainly, this finding was mainly based on prospective cohort studies done on women who were having a biopsy-defined benign breast disease. In addition, most studies found that the magnitude of risk of breast cancer varies according to the histopathological type of benign breast disease that was present in these patients. Thus, it seems to be important to identify risk factors according to the histopathological type of benign breast disease. Most publications of benign breast disease were on symptomatic lesions, hence the true incidence is not known. However, the prevalence is estimated to be from 6% to 27% among the screening group. Studies by Distad et al. And Hartman et al. To quantify the risk estimate associated with benign breast diseases demonstrated that proliferative benign breast disease with atypia had a relative risk of 3.93 to 4.2. That is a significant increase compared to the normal population. These data support extra management strategies for women with benign breast diseases, such as additional screening methods and also chemo prevention. In the first 10 years after diagnosis of atypical hyperplasia, the breast tumors occur predominantly within the same breast, but subsequently they can occur with an equal frequency in the contralateral breast. These observations suggest that atypical hyperplasia is both a precursor lesion and also a marker of an underlying predisposing condition. This is termed as a field defect or mutative phenotype. We chose to conduct our study in the perimenopausal age group of women, as this is the age group in which there is the highest incidence of breast cancer in our region as well as across the world. The aim of our study is to determine significant risk factors for atypical hyperplasia in perimenopausal women with benign breast disease. The materials and methods of our study are that it is an analytical cross-sectional study which is outpatient-based, conducted over a period of 2 years from August 2017 to August 2019 over patients who visited the outpatient department of general surgery or the casualty in King George Hospital, Visakhapatnam, which is affiliated to our medical college. The expected sample size was supposed to be 150 according to the incidence rates in various studies, but we had an actual sample size of 300. The inclusion criteria for our study were that only female patients who were of age 35 to 55 years with clinically palpable abnormalities and a BRADS3 on mammogram were included. Our exclusion criteria was that patients who presented to the OPD for a single visit and were not willing for follow-up were excluded. We even excluded patients with malignant findings and mastalgia with no clinically palpable abnormality in the breast. We even excluded patients who were not willing to give a written consent. Coming to study methodology, we first explained the patients in the age group of 35 to 55 years who presented to our OPD with pain, lump or lumpiness within the breast or nipple discharge regarding our study and obtained a written consent. We have taken detailed history and performed thorough clinical examination for all patients with a palpable abnormality. Later, we sent them for mammogram or ultrasound according to their age and identified women who had a BRADS3 on imaging. For these patients and that particular lesion, we did a core needle biopsy and obtained the histopathological reports from the patient or the department. Then this data was entered on a pre-designed case pro forma and analyzed after filling the master sheet. Operational definitions within our study are that perimenopausal age group was taken as 35 to 55 years. The mean age at menopause was taken as 45 years. Benign breast diseases are those which have both imaging and cytological findings suggestive of a benign etiology in the breast. Benign proliferative breast diseases are taken when there is a cytopathological or histopathological evidence of proliferation with or without atypia. The statistical analysis was conducted after entering the data in an MS Excel version 15.4 and calculations were done in SPSS software 18 version. Pearson's chi-square test and odds ratio were calculated for inferential statistics for each and every parameter. The conclusions of our study are that age more than 45 years is considered a risk factor which was associated with a significantly increased odds ratio, almost twice as that of patients who were below 45 years. And this finding of our study was in agreement by Cheng et al. And as per our study, early age at menarche is associated with a raised odds ratio of 1.5 times for the development of atypical hyperplasia, but this was not found to be statistically significant on chi-square test. Even this finding was in agreement with Parazzini et al. A late age at first childbirth and late menopause were associated with a significant higher risk of atypia and malignancy according to various studies like Parazzini and Minami et al. However, such findings were not present in our study, probably because the mean age at first childbirth was very low in our study compared to that of Western studies. Our study does not support any significant association of BMI with either non-proliferative or proliferative breast disease. Family history of breast cancer in our study was associated with a higher risk of atypia, that is 7.5 times more, and this finding was supported by various studies like Webb et al. Our study also finds a significant association of breast density, which is more than 75%, as the risk factor for development of atypical hyperplasia. The p-value was 0.03 and significant at 95% confidence intervals. The dense category of breasts as per ACR guiding are found to increase the risk of atypical hyperplasia by 1.065 times. This finding was in agreement with Ghosh et al. And Friedenrich et al. Thus, our study finds that age, family history of breast cancer, and breast density are the most important risk factors for atypical hyperplasia, even when there was a seemingly benign report on mammogram, that is BIRADS-3. The importance of identifying atypical hyperplasia as a criteria for closer follow-up in perimenopausal women is stressed because they are at a higher risk of breast cancer. High-risk patients must be identified, evaluated further, even in a case of BIRADS-3 on mammogram, and biopsied. If necessary, an excision biopsy with appropriate planning has to be performed for optimal treatment, and a closer follow-up is indicated. These are my references. Thank you for your time.
Thank you, Dr. Niharika. Now, I would like to invite Dr. Souvik Paul from BLK Multispeciality Hospital, New Delhi.
My topic of presentation is the response of inflammatory cytokines to bariatric surgery in Indian obese patients with non-alcoholic fatty liver disease. We don't have any conflict of interest. In the first, I will discuss about the background of this topic, and then I will discuss about the study details and the conclusion. Coming to the background, that obesity is known to be a state of low-grade chronic and systemic inflammation. In 70 to 80% of these patients with morbid obesity, there is NFLD. NFLD is nothing but the hepatic manifestation of the obesity-related metabolic dysfunction. It is a spectrum of disease. It progresses from steatosis to NASH to fibrosis to cirrhosis and to hepatocellular carcinoma. Of this, the last three can be responsible for a 12% risk of liver-related mortality. So there is a need to halt this progression over time, that we can prevent this morbidity associated with it. In the recent years, obesity and NFLD has been linked with the altered adipose tissue inflammatory activity. We all know that bariatric surgery is used to treat the obesity. In the current era, bariatric surgery is also being considered as one of the treatment options to treat NFLD. But whether bariatric surgery treats obesity and NFLD by correcting this altered adipose tissue inflammatory activity is a matter of research. Because if we get a definite answer to this, in near future, we can have a newer treatment options to treat the obesity and NFLD. In this context, I must mention that obesity and NFLD is a multifactorial disease. Cytokine and adipokine is a very smaller part of this bigger picture. All the other factors like ethnic differences, lifestyle patterns, genetic changes, gut microbiome, metabolomics, bile acids can be varied from population to population. And so the net result, obesity and NFLD, will also vary. So there is a Asian Indian phenotype of obesity and NFLD, which is very much different from its Western counterpart. Hence, we must look into this topic from our Indian perspective. Before going to the details of the study, I just have a few things about the inflammatory cytokines. The cytokines can be pro-inflammatory or anti-inflammatory. And adipokines, which are actually released from the adipocytes, can also be pro-inflammatory and anti-inflammatory. In a healthy individual, there is a balance between the pro-inflammatory and anti-inflammatory, which looks into the resultant inflammatory burden. In pro-inflammatory state like obesity and NFLD, the pro-inflammatory molecules are higher level than the anti-inflammatory molecules, which has been well established or well described in the Western literature. But in Indian setting, there is a very limited data. Most commonly, TNF-alpha, IL-6 and adiponectin has been implicated in the pathophysiology of the obesity and NFLD. So these three molecules are our most concerned molecules, and we have analyzed only these three molecules. But bariatric surgery response to these cytokines, it is in Western literature, there is very conflicting results. And Indian settings, there is no data, no published data yet. With this background concept, we aimed our study with the primary objective of to study the response of the inflammatory mediators in NFLD to bariatric surgery in Indian obese patients. The secondary objectives were to study the correlation between changes in cytokine levels and NFLD, to study the response of the hepatic steatosis and fibrosis to bariatric surgery, and also to evaluate the cytokine profile in obese NFLD patients compared to the healthy population, that is a control group. Coming to the methodology, this is a prospective observational study conducted at our hospital and THST Haryana. The minimum sample size was calculated to be 23 for each of the study group and control group. The study patients were selected as Indian obese patients attending for bariatric surgery at our OPD, patients with other causes of liver damage, patients with postoperative complications requiring re-exploration, patients with less 5% steatosis on histopathological examination, and patients who have lost to follow up, that means they don't have any follow-up data, were finally excluded from the paired analysis. The control group patients were selected having BMI less than 23, and these patients attending for regular health checkup in our general OPD. These patients had a single visit, no follow-up visits. They underwent routine investigations, including ultrasound whole abdomen. At this time, a blood sample was collected from them. Patients with abnormal total leukocyte count and abnormal ultrasound findings has been excluded from the study for final analysis. The study patients, after that enrollment, they underwent the routine workup for the bariatric surgery and also a fibroscan. Fibroscan was done to quantify the hepatic steatosis and hepatic fibrosis. Patients within 3 weeks after this workup underwent surgery, that is in the form of Roux-en-Y gastric bypass or sleeve gastrectomy. The choice of surgery was mainly based on the comorbidities and patient preference and the BMI. However, patients with hiatus hernia or symptomatic reflux disease underwent Roux-en-Y gastric bypass, and patients with severe fibrosis underwent sleeve gastrectomy. In all of them, there was an intraoperative liver biopsy was performed. Patients were followed up at 3 months and 6 months with routine investigation and fibroscan like earlier. In all these 3 points, preoperatively, 3 months and 6 months after surgery, a blood sample was collected. After collection of all these blood samples in the control group and the study population, the samples were centrifuged and stored in aliquots at -80°C. All the samples were analyzed at the end period of the study, were measured in duplicates, and the average was taken. TNF-alpha, interleukin-6 and adiponectin was measured by the ELISA kits. This part of the study was conducted in THST Faridabad, which is a very renowned biotechnological institute for this purpose, because our next part of the study was going to be conducted there. Liver biopsy was graded as per the clinical research network criteria to evaluate the steatosis and fibrosis. Patients with less than 5% steatosis was considered to don't have NFLD, so they were finally excluded from the study. The fibroscan was done to evaluate the steatosis by CAP value, and fibrosis was measured by liver stiffness measurement, that is LSM value, as per the pre-validated standard criteria. Coming to our result and analysis. The study patients, in 54 patients were enrolled. And of this, finally, 50 patients were included in the paired analysis and cytokine assay. 2 patients did not have NFLD in histopathology, so they were excluded. And also, 2 patients were lost to the follow-up because they don't have any follow-up data for comparison, so they have been excluded from the paired analysis in this observational study. Control group, in the control group, 81 patients were found to be eligible. Of these, 50 patients were included in the analysis by lottery method. The results, the mean age of our study population was 43.89 years with male preponderance. 28 patients underwent RYGB and 22 patients underwent sleeve gastrectomy. We can see that there was mean BMI at the baseline was 47.02 with 29 patients having diabetic and 32 patients have metabolic syndrome. 3 months after and 6 months after the surgery, there was a significant decrease in the excess weight loss, BMI, and comorbid status and insulin resistance. So this denotes the bariatric surgery has a successful outcome in the obesity-related parameters. Now, what was the effect of surgery on the NFLD? We can see that at the 6 months, there was a significant improvement in the steatosis with 76% patients having improved stages and 24% patients retained in the same stage. Regarding fibrosis, the changes were significant both at 3 months and 6 months, with ultimately there was around 58% patients have improved stages, 38% patient remains in the same stage, and 4% has worsening of the fibrosis. All these changes in steatosis and fibrosis was not significant as per the type of surgery is concerned. Now coming to the serum analysis. In the control population compared to the NFLD part is denoted by the red color, we can see there is a significantly raised CRP level and the IL-6 level in the NFLD population, which establishes the pro-inflammatory theory. However, adiponectin level, which is anti-inflammatory, is lower in the NFLD population, but did not reach the statistical significance. How these markers were correlated at the baseline in the study population? We can see that CRP was quite well related with the BMI. And also the adiponectin was influenced and by inverse correlation with the grade of steatosis. There was no correlation between these markers with insulin resistance and the stage of fibrosis. Now, how these inflammatory markers behaves after the surgery at different points of time? The mean TNF alpha level was rise after 3 months after surgery and then gradually decreased at 6 months after the surgery, but not up to the baseline level. In the IL-6 shows a similar rise at the 3 months, but at 6 months, their level becomes lower than the earlier baseline level. Mean adiponectin level shows an early rise within 3 months after the surgery and also continue to rise at 6 months after the surgery. The CRP level, which is gradually decreasing over time and becomes within normal range after 6 months after surgery. So, how these changes being affected by the other factors? First of all, the type of surgery. Roux-en-Y gastric bypass patients had a significantly better rise in the adiponectin level as shown in this correlation diagram, which is also correlating with the changes in the BMI after surgery. Regarding change of steatosis, with the change in the markers, we can see in the early 3 months, there is a significant rise in the TNF alpha and IL-6, both correlating with the improved steatosis. So as steatosis improves, pro-inflammatory markers are also rising. However, this correlation becomes weaker when we consider the 6 months because the level of the markers is being falling down. Regarding fibrosis, we could not find any significant correlation between these markers with the change of the fibrosis at 3 months or 6 months, except that CRP was inversely correlated with the fibrosis stage at 3 months. Now, how this changes on the markers with respect to the degree of change, that means subgroup analysis, we can see that the changes in the steatosis, when it's maximum, that is by grade changes is grade by 3, there is a trend towards the rise in the inflammatory as well as anti-inflammatory markers. This measure made us to think a plausible hypothesis that a theory of catabolism or theory of the lysis of the dysfunctional adipose tissue leads to rise in the pro-inflammatory markers. While this trend was not so evident in changes in fibrosis. In fibrosis, otherwise, we can see that when there is a worsening of the fibrosis, the rise in the markers were maximum. So it establishes the theory of the pro-inflammatory markers in NFLD patients. Now, how this outcome is being affected by the type of surgery? Adiponectin is being highly influenced by the RYGB or sleeve gastrectomy, where RYGB shows a better improvement. This improvement was much more at earlier stages within the first 3 months, and then gradually sleeve gastrectomy takes over, where the influence is more than the RYGB. However, in case of TNF alpha and CRP, there was a trend of better fall in the TNF alpha and CRP level was seen in the RYGB patients. So that's why it gives an understanding that why RYGB is being recommended as the treatment option for the patients with NFLD, not the sleeve gastrectomy. Coming to the discussion part, a current knowledge about the effect of bariatric surgery on the serum markers shows some conflicting literature in the Western part of the world. Here we can see that TNF alpha and IL-6 effects will be evident at 6 to 12 months after the surgery, with RYGB having an early effect. And adiponectin showed a significant increase at the 3 months without any difference in the type of surgery. But what we get here, first of all, this is an Indian analysis, the first Indian data. TNF alpha and IL-6 showed a raised level at the 3 month, then gradual decrease, which can be better predicted in RYGB patients. Whereas adiponectin changes are significantly better, which is also earlier described, and the effects is better and earlier in RYGB patients compared to sleeve gastrectomy. The current knowledge about the inflammatory molecules versus NFLD and obesity, that it is a pro-inflammatory state, which is being also proven in our study. But the inflammatory molecules versus histology at the baseline in the Western literature shown a different results, which is very much different from our results. We have only adiponectin inversely correlated with the steatosis. This could be due to the fact that Indian population has, the NFLD in the Indian population has a histologically milder disease. That's why there was no correlation with the fibrosis. So again, the bigger question, the prospective question is how cytokines and adipokines behave with steatosis and fibrosis changes after bariatric surgery. Our data shows a plausible hypothesis of theory of lysis or catabolism. This gives a new way to look into the research with all these 3 components, that is changes in the cytokines, adipokines, changes in the steatosis and fibrosis, and the third after bariatric surgery. No previous studies in the literature has considered all these 3 components. Either they considered any of these 2 of these 3 components. No previous published data was available in literature. The strength of our study is that this is the first Indian study. We have a vigorous statistical analysis to measure the outcomes. A surgery was marginal effect analysis was done, which was not done in any earlier studies. And our data also showed the basis of the raised cytokines following the early month of surgery, which needed further research to determine and compare a head-to-head cause-effect relationship. The limitations of a study that we don't have any follow-up biopsies. Our follow-up duration was very short. The subgroup size is quite small. And the type of surgery, to comment about the type of surgery, that needs a randomization study. Despite our limitations, we can conclude that in patients with obesity-associated NFLD, the pro-inflammatory cytokines are elevated and anti-inflammatory cytokines are decreased. Although bariatric surgery initially results in rise in pro-inflammatory state, over time, it results reversal to the normalcy associated with significant weight loss, improved insulin sensitivity, and improved hepatic steatosis and fibrosis. The type of surgery can significantly influence post-op cytokine levels, with the changes being more pronounced after Roux-en-Y gastric bypass. Finally, I will say that the implication of this study could be to improve the understanding of the pathophysiological factors influencing NFLD in Indian obese patients and the results of the bariatric surgery on the same. With further research, it may open up the fresh avenues for the treatment, which can act as adjuvants to bariatric surgery or may offer completely new treatment for obesity and NFLD burden. Also, there are much larger scopes for further research, which is derived from this study, that changes of the markers versus changes in the steatosis and fibrosis need studies with longer follow-up duration data. Also, we have to consider the gut microbiome and metabolomics into these factors, which is being conducted as a planned as our future prospective study, and we have started this protocol. NFLD changes are multifactorial and need to study the other biomarkers that influence the disease and also inter-cytokine interaction. And finally, to establish the cause-effect relationship between the inflammatory response and the NFLD. These are some references, one very small part. Thank you.
Thank you, Dr. Shravik Paul. Now, I would like to invite Dr. Yash Sinha from SGPGI, Lucknow.
Hello, everyone. I am Yash Sinha. Today I'll be talking about my research journal. The topic of the journal is Management of Liver Trauma in Urban University Hospitals in India. This is an observational multi-center cohort study. This journal was recently published in the October session of World Journal of Emergency Surgery. So just to why to do the study in the first place? The low and middle income countries like India contribute to approximately 90% of the global injury burden, which in fact is a very critical public health issue. Liver and splenic injuries are the commonest injuries which are seen in blunt abdominal trauma. The management of liver trauma per se has gone a paradigm shift over the last few decades. There have been various guidelines that have been published from Western cohorts, and the results have been generalized to the entire population. But are the management protocols and the data from these cohorts also reflective of the Indian scenario? The most published literature from India is anecdotal or single center studies, and these have a very small database and actually do not give a complete outlook of the Indian scenario. The basic aim of my study was to observe the demography, the mechanism of injury, the management outcome of patients who presented with liver trauma at 4 large urban tertiary hospitals in India. And along with that, to provide an insight into liver trauma in urban India and compare the outcomes with those of Western cohorts and identify the limitations and bring into light whether there was any scope of improvement. The basic methodology of my study was the study type. It was an observational multi-center cohort study. The design, it was a retrospective registry-based study, and the data was extracted from a prospective cohort study called Towards Improved Trauma Care Outcomes in India. The TITCO, in fact, was a multi-center research consortium of university hospitals that was established to develop a trauma registry system in India. This study basically included patients admitted at the 4 hospitals during October 2013 to December 2015. The 4 study centers included in my study were the King Edward Memorial Hospital at Mumbai, the Lokmanya Tilak Municipal General Hospital that was also at Mumbai, the Jai Prakash Narayan Apex Trauma Center at New Delhi, and the Institute of Postgraduate Medical Education and Research at Kolkata. In the patient selection, in the study, we included all consecutive patients admitted that presented with a history of trauma on arrival and had liver trauma based on imaging or intraoperative findings to any of the study hospitals were included in the study. The data for the study was collected by trained project officers. These project officers were given a week's training in the methods of data collection for this study. The data collection was funded by the Swedish National Board of Health Welfare and the Lauder Foundation. And the project was granted waivers of informed consent from all these study centers and had received approval from institutional ethics committees of the 4 centers involved in the study. The primary variables that were analyzed in this study were the primary outcome was 30-day in-hospital mortality following liver injury. The patients who were discharged before 30 days were considered to be alive at 30 days. The data set that was analyzed for patients' demographic profile, mechanism of injury, the severity, the management done, and the final outcome. The severity of injury was graded based upon the World Society of Emergency Guidelines, that is the WSES guidelines. The study definitions that were used are as follows. The patient's management in the study was divided and labeled as operative management in the patients who underwent a laparotomy and non-operative management in those who were conservatively managed without a laparotomy. Those patients who survived a non-operative management were labeled as successfully managed or NOM success, while others as NOM failure. In the statistical analysis, all the continuous variables were represented as mean, with their standard deviation and categorical variables as counts and proportions. The ISS score or the injury severity score was represented as median with an interquartile range. For comparison, standard tests of significance as per the data being utilized were used, such as the chi-square test or the Wilkinson's rank sum test. Now, coming to the results of my study. This diagram basically gives a brief outlook of the entire study. So in my study, we had a total of around 16,047 patients. Among them, we had 1,144 patients, which were roughly 7% of the entire trauma patients. These were the patients who had abdominal trauma. Among the abdominal trauma, we had around 368 patients, which was roughly around 32%, which had liver trauma. On the liver trauma patients, around 106 patients underwent a laparotomy, while 262 patients underwent non-operative management. The mortality in the laparotomy group was around 33%, while the mortality in the NOM group was around 26%, which was roughly around 10% of the NOM group. Finally, the success rate in the NOM group in my study was around 90.1%. The various methods for surgery used in liver trauma included perihepatic packing in 19 patients, hepatectomies in 4, and primary suturing in 9. In 74 patients, however, the exact details of the operation were not available. Now, this table is actually my table 1, which shows the major demographics and the variables that were used in the study. So we have, I had age, which are the mean values around 26. In my study, majority of the patients were male, which were 328, which is roughly around 90% of the patients were male. The main mechanism of injury analyzed was road traffic accident followed by railways. The results of the study were comparable with other studies published from other centers in India. Apart from Kashmir, which showed a predominance of assault as a major cause of liver trauma. The blunt injury in liver trauma patients was roughly around 91% and constituted around 337 patients. And the other variables that were analyzed were the heart rate, the systolic BP, the mean hemoglobin, the ISIS score, the Glasgow Coma Scale score, the length of the stain, median, units of blood received. The liver trauma patients were basically categorized according to the WSES grades into grades 1, 2, 3, and 4. In grade 1, we had around 127 patients. In grade 2, we had around 96 patients. In grade 3, around 70 patients. And grade 4, we had around 66 patients. In 9 patients could not be grouped into the above categories because the systolic BP on admission was missing from the records. Now coming to this chart actually shows you the number concomitant injuries along with the liver injuries in the patients who had liver trauma. So basically, this diagram shows in 52 patients, which constitutes roughly 14%, and 61 patients, which roughly constitutes 17%, had concomitant injury along with the liver trauma. Along with liver trauma, kidney and the splenic injuries were the most common injuries. This was my table 2. Basically, this table gives you an outlook of the number of patients who underwent non-operative management and who underwent operative management and the reason for operative management. So in WSCS grade 1, we had around 102 patients, which was roughly 39% patients who underwent non-operative management. In grade 2, we had around 64, which was roughly 24%. Grade 3, we had 58 patients, which was roughly 22 patients. And grade 4, we had 33 patients, constituting approximately 12.6%. The second column denotes the number of patients that actually went exploratory laparotomy for liver trauma per se. These patients might have other injuries, but the major reason for exploration was liver trauma. The third column denotes that the major reason for exploration was injury to other organs other than the liver. And finally, the fourth column, we could not find the exact reason why these patients were explored because of missing data in our study. And finally, the last column shows the sum total of the patients who underwent operative management. This will be discussed in the later part, the details of this table. In this study, we also tried to compare the physiological variables of patients who underwent laparotomy versus those who underwent non-operative management. The major physiological variables that were compared were age, penetrating injury, the systolic BP at presentation, the mean heart rate, the GCS, the ISS score, and the mortality. All the physiological variables were comparable between both arms, apart from the GCS score and the age. Now, this chart basically demonstrates the entire study and the percentage of NOM success. Coming to the first column, we can see in grade 1 injury, we had around, in grade 1 WESS, we had around a total of 126 patients. Among them, 113 were managed by non-operative strategy. The success rate was seen in 105 patients, and the the percentage success was around 92%. Similarly, in grade 2 liver trauma, the percentage of success was around 90.48%, and in grade 3, the success rate was 90%. However, in grade 4, this success rate dropped to around 82%. In brief, we can say that 90 to 93% of the WSE grades 1 to 3 in liver injuries were successfully managed using non-operative management strategy. In WSE grade 4 injuries, this number of NOM success was reduced to around 84. Now coming to grade 4 injuries per se. In our study, approximately 50% of the WSE grade 4 liver trauma were managed non-operatively. Now, this was in stark contrast to other literature where such kind of other literature and guidelines where generally such kinds of injuries would have been operated. In our opinion, the reasons for the operative management of these grade 4, the non-operative management of these grade 4 liver injuries may be due to various reasons. The primary reason might be that these patients were responders or borderline unstable patients whose BP improved after resuscitation. And India, due to lack of resources, there might be logistic issues such as unavailability of blood and blood products or financial constraints. And there is a lack of protocol-directed treatment in all these 4 hospitals. One of the other reasons for this stark finding may also be that 4 of the grade 4 liver injury patients had associated severe traumatic brain injury, and this is considered a relative contraindication in some centers due to the poor outcome associated with these injuries. Now, we know studies comparing the operative management versus non-operative management in high-grade injuries is still evolving, and we try to give our view regarding this. Our comparison of the 2 cohorts showed poor outcomes in those undergoing operative management. On admission, the operative management cohort had poor physiological variables compared to the non-operative group, suggesting this cohort might have more serious injuries. The median ISS score in the operative cohort was 14, which was significantly less compared to the non-operative cohort, which was 17. This again highlights that injury severity score is a poor predictor of severity in low and middle income countries. And this finding has been repeatedly demonstrated in predictive studies on mortality in trauma from various Indian as well as Western literature. Finally, to our knowledge, this is the first analysis of an Indian multi-center cohort of liver injury patients. And this has one of the largest cohorts analyzed in India and probably across all the low middle income countries, at least in Asia. And the main findings that we can come across are that the blunt trauma constitutes the major mode of abdominal trauma, and 1/3 of the patients with blunt trauma also have a liver injury. The operative management is roughly undertaken in less than 1/3 of those with liver injury, and our success rate of non-operative management of liver injury is comparable to other countries. And finally, this being a multi-center study with a large cohort size, I can say that the results of this study are actually generalizable to the urban university hospitals in India and perhaps to other similar university hospitals across the low middle income countries. The major limitations of my study were we do not have data regarding patients who required adjunctive procedures for management of liver injury. And also we did not have data regarding the cause of mortality in patients who were initially managed non-operatively. And also the morbidity in the NOM group was not recorded. My take-home message from this entire study is in our low and middle economic countries, we are faced with multiple challenges and pressures of healthcare inequities and scarcity of resources. And there is an urgent need to provide both essential and cost-effective trauma. To provide this, a trauma registry is an integral component of modern comprehensive trauma care systems. We need to realize that a registry is not just a registration of the injured coming to trauma centers or injury surveillance, but it is in fact a database containing the full spectrum of care of every patient. And over a period of time, such data can actually reveal how trauma centers are responding to the injured and actually improve the quality of care. Trauma registries are in fact necessary for identifying affordable, sustainable methods to strengthen trauma care capabilities. However, the bad part is in India, this is still rudimentary and incomplete. Much effort is still required on our part to make it more reproducible, feasible, and sustainable. And finally, I can say from the results of my study are that the liver trauma standards in urban India are comparable to Western trauma standards. However, still more research and capability strengthening is required to reduce the operative mortality in liver trauma patients. Thank you.
Thank you, Dr. Yash Sinha. Now, I would like to invite Dr. Usha from Kidwai Memorial Institute of Oncology, Bengaluru.
Greetings to all the dignitaries, the jury members, my colleagues, and all my friends to the grand finale of India's Next Sushruta. Wishing all my fellow participants all the very best for the finale. My topic for today's presentation is a retrospective analysis in which we are going to look at the pre-treatment neutrophil to lymphocyte ratio, depth of invasion, and perineural invasion as predictors for occult cervical metastasis in early stage tongue squamous cell carcinomas. I'm Dr. Usha from the Department of Surgical Oncology, Kidwai Memorial Institute of Oncology, Bangalore. I would like to thank the entire team who contributed for this research paper. At our institute, early stage 1 tumors form more than 50% of patients with high propensity for occult nodal metastasis in spite of thorough clinical and radiological imaging techniques. And as we all know, when the patient is not positive on our final histopathology, the survival drops by 50%. So it is very crucial for better disease control and appropriate management of such patients because head and neck malignancies are known for regional recurrences than distant metastases. There have been various clinical or pathological parameters which have been predictive for occult cervical metastasis, like your tumor thickness, grade of differentiation, pattern of invasion, and E-cadherin expression, although all of them have been insufficient in predicting the outcomes, and it necessitates the requirement of newer biomarkers. So neutrophil and lymphocyte ratio has emerged as an important prognostic tool, not just in head and neck malignancies, but also in various GI and ovarian malignancies, and have found to have correlated well with the poor outcomes. So what is neutrophil to lymphocyte ratio? As we all know that inflammation plays a very important role in the pathophysiology of cancer. So we need a marker which assesses this systemic inflammation that goes on when the cancer is developing inside the body. So easily obtainable and a robust metric for such a systemic inflammation, one such marker is neutrophil to lymphocyte ratio. And this can be assessed by the immune cell components of the complete blood count, which assesses your which permits your risk stratification, offering specific therapeutic intervention. So like you can see in this picture that there are various cytokines, chemokines, and growth factors which have been secreted by the tumor and also the cells which infiltrate the tumors. So as a result of which there is increase in the number of neutrophils and also decrease in the number of lymphocytes. Now why there is a decrease in lymphocyte count is because these neutrophils not only helps the tumor to grow faster, but also suppresses the cell-mediated immunity, which is carried out by the lymphocyte, the result of which is a high NLR. Now this high NLR results basically in a detrimental effect of neutrophils and beneficial effect of the lymphocytes. So not only does it have a role in the local tumor area, but also has systemic effects on various organ systems. So what has been the barriers for adoption of this NLR as a tool for prognosis or clinical decision making is the uncertainty in the optimal cutoff value, limited understanding of association between the NLR and the clinical outcomes, and corresponding group-specific cutoffs have not been validated in prospective studies. So the present study facilitates the prospective clinical validation of this valuable biomarker as a tool for this stratification. Coming to the next parameter that will be analyzed in our study is depth of invasion. As we all know, depth of invasion has now been introduced as a fundamental criterion in AJCC 8th edition in 2017 for staging of head and neck malignancies to categorize the T1, T2, T3 staging, which significantly correlates with your disease-specific survival, risk of nodal metastasis, and loco-regional recurrences, especially in tongue malignancies. When coming to depth of invasion, there are two important entities that we need to differentiate. One is your tumor thickness, the other one is depth of invasion. Now, tumor thickness is the extent of tumor from the outermost part to the innermost part, whereas depth of invasion can only be assessed on your postoperative histopathology, which is extending from your basement membrane to the innermost extent, and this can only be assessed postoperatively. Now, what are the advantages of depth of invasion is that it allows for precise clinical staging and choose the extent of surgery, need for compartmental resection and possible reconstruction, and also the requirement for neck dissection. So DOI, depth of invasion, has become a very powerful instrument in predicting the nodal metastasis, and this has been established and validated in large retrospective data, but there are no prospective or randomized controlled trials for the cutoff that we need to take when opting the patient for wait and watch policy versus elective node dissection. So what are the differences between the 8th edition and the 7th edition AJCC in terms of staging system? So in 8th edition, there was an introduction of depth of invasion in the PT category, which led to stage migration, especially in the T2 category, and there was a better predictive accuracy in terms of outcomes. Whereas in 7th edition, as we all know, the T category was only a two-dimensional definition, which lacked the adequate prognostic performances, especially in tongue squamous cell carcinoma, and also failed to distinguish early lesions that potentially do develop nodal metastasis from true early tumors without such regional spread. So pertaining to this comparison between 7th and 8th edition AJCC in oral cavity squamous cell carcinoma, analysis was being conducted in Tata Memorial Hospital, published in International Journal of Cancer in 2019, where almost 25.8% of patients were upstaged as per the 8th edition, and patients with upstaged disease had poorer survival outcomes. So this 8th edition staging system had a higher accuracy in predicting outcomes among oral cancer patients. So next entity that we are going to analyze in our study is perineural invasion. As we all know, perineural invasion is the spread of tumor along the neural sheath. And this occurs because of low resistance channels in anatomy and tumor microenvironment, which interact with each other and leads to various signaling pathway causing tumor progression and metastasis. Perineural invasion is associated with nodal metastasis and also regional recurrences. It has been considered as one of the adverse features to be considered for postoperative radiotherapy. So before moving on to the study analysis proper, I would just like to run through the review of literature. As we all know, oral tongue is a special subsite in oral cavity because it is a highly vascular organ and has the highest propensity for nodal metastasis. The chances of subclinical nodal metastasis in T1, T2, N0 oral tongue squamous cell carcinoma ranges from 25 to 35%. And all the more, elective neck dissection is recommended for all patients with tongue malignancy, irrespective of the stage. But is neck dissection absolutely necessary even in early stages? Because such early stages patients do survive longer, and these neck dissection in N0 are associated with a lot of morbidity in the form of nerve injury, shoulder morbidity, and scarring. So the ideal management for N0 patients must strike a balance between the oncological outcomes and the morbidity. Although various studies and randomized controlled trials published in 2015 in New England Journal of Medicine has established that elective neck node dissection is associated with higher rates of overall survival and disease-free survival than therapeutic neck dissection. And it possibly is the most accurate method of possibly staging an N0 in high-risk patients. So there have been various other studies which have emphasized on detection of these nodal metastases using newer radiological tools. But again, the radiology has failed miserably in the T1 stages because of higher upstaging due to peritumoral edema and lack of accurate assessment. So the effectiveness of neutrophil to lymphocyte ratio as an independent prognostic factor in many other head and neck malignancies is not yet universally proven, and its role as a predictor for occult neck metastasis is also limited. So in our study, we have elicited that NLR can be a useful tool to identify individuals who are at the highest risk of developing neck nodal metastasis, and only such patients can be taken up for elective neck dissection. So the aim of our study was to determine the predictive significance of NLR, depth of invasion, and perineural invasion with regard to occult cervical metastasis in stage 1 and 2 squamous cell carcinoma of oral tongue as additional parameters to the existing biomarkers which guide further in the management of clinical N0 patients. So ours was a retrospective study of patients who were taken up for surgery at our institute with clinically N0 neck addressed with elective nodal dissection between 17 to 18. So patients who were included in our study belong to the age group of 18 to 70 years with histologically proven malignancy through incisional biopsy, all early stage oral tongue cancers with no regional or distant metastasis, which have been confirmed clinically and radiologically, and they're documented to be clinical T1 or T2 and N0 stage. The patients who have been excluded from our study were the ones who underwent previous NACTRT or who had a previous history of cancers and various other conditions that are likely to affect the neutrophil or the lymphocytic count, for example, infections, hematological disorders, autoimmune disorders, etc. So all patients were evaluated with physical examination, routine blood investigation, and MRI was performed for primary and for the neck, and chest X-ray or CT was done for lung for metastatic growth. All tumors were retrospectively staged according to TNM classification 8th edition. The optimal cutoff for NLR and depth of invasion was determined using receiver operative characteristic curve analysis. Excel sheet in Microsoft Word was used for data entry and generation of graphs and tables. All tests were two-sided and statistical significance was set at 0.05. A total of 350 patients registered in our institute who were oral tongue squamous cell carcinomas in the time period 2017 to 18. A total of 134 patients with early stage oral tongue squamous cell carcinoma were included in the study. 216 patients out of 350 were excluded due to advanced stages, recurrences, previous history of malignancy, no neck dissection being performed, and comorbidities. So all patients underwent surgical wide local excision in 3 dimension and elective nodal dissection, either ipsilateral or bilateral, depending upon the location of the primary tumor. Elective neck node dissection if tumor was approaching midline. So the median age at diagnosis for our study population was 39 years, and it was predominantly seen in males, and the ratio of males to females was 2:1. On pathological assessment, resection margin was more than 5 mm microscopically in 96.6% of the patients. And out of 134 patients, 44 patients turned out to be positive in the neck. That is, positive neck node metastasis was seen, amounting to 32.8% of the total study population. Among the 44 patients who were node positive, 75% belonged to clinical T2N0 group. Coming to the first parameter of our study, neutrophil to lymphocyte ratio. With the help of the ROC curve, we determined the cutoff value for NLR at 2.66 with 95.5% sensitivity. So the analysis revealed that 95.5% of the node positive group had an NLR more than 2.66. So this difference between the node positive and the node negative when NLR was taken at more than 2.66 was statistically significant, where p-value was less than 0.001. Coming to depth of invasion, the mean depth of invasion for node positive was 10.6 and node negative was 6.8. On ROC curve, cutoff value was determined at 4.75 with 97.7% sensitivity. And the analysis revealed that 97.7% of node positive patients, that is, out of 44, 43 patients had depth of invasion more than 4.75. And this association between the node positive and the depth of invasion more than 4.75 was again statistically significant with p-value less than 0.001. Coming to peridural invasion, one of the last parameters that we assessed in our study, almost 38.6% of individuals in the node positive group had perineural invasion, and this association was also found to be statistically significant. We also did a subgroup analysis where we performed a subgroup analysis with respect to depth of invasion and T stage, and we observed that there were more number of T2 patients with depth of invasion more than 4.75, and it was statistically significant, and it correlated well with our AGCC 8th edition of T2 staging 5 to 10 mm. So there exists an association of depth of invasion with T stage of the disease. So this is the entire summary of patient and tumor characteristics based on our nodal status. As we can see, the median age was 39 years, predominantly males, and most of our node positive patients belong to clinical T2 category. 97.7% of the individuals in the node positive group had depth of invasion more than 4.75, and 95.5% of the individuals in the node positive category had an NLR of more than 2.66, and 38.6% of node positive group had perineural invasion, which was much more than individuals in the node negative group, and all of these associations were statistically significant. To summarize, the total number of patients who were registered were 350, 134 patients were included in the study, 216 patients were excluded from the study, and the parameters that we analyzed were NLR, depth of invasion, and perineural invasion. Under neutrophil to lymphocyte ratio, the ROC cutoff was 2.66, and 95.5% of node positive group had NLR more than 2.66, and only 26.7% of the individuals in the node negative group had NLR more than 2.66, and this difference was statistically significant. Coming to depth of invasion, the ROC cutoff was taken at 4.75 mm, and 97.7% of the individuals had a depth of invasion more than 4.75, and only 70% of the node negative group had depth of invasion more than 4.75, and this difference was statistically significant. Under the perineural invasion, 38.6% of the individuals in the node positive group had perineural invasion, and this was also statistically significant. So coming to the discussion, the incidence of oral tongue squamous cell carcinoma under our study was more so in male population. The node positivity was more in clinical T2 group. There was a strong positive correlation between the neutrophil to lymphocyte ratio and nodal status, which was statistically significant, which means that patients with NLR more than 2.66 were 57 times more likely to be positive for nodal metastasis. There was a moderate positive correlation between depth of invasion and nodal status, which was again statistically significant. So, which means that patients with depth of invasion more than 4.75 mm are 18.5 times more likely to be positive for nodal metastasis, and all patients except one in the node positive group had depth of invasion more than 4.75 mm. And for the subjects who were positive for occult nodal metastasis, there was 2.9 times more likely to have perineural invasion. So based on our retrospective analysis results, NLR is an easily obtainable tool which aids in stratifying patients based on the extent of metastatic node and the need for elective node dissection in clinical N0 neck. The presence of perineural invasion was much more in node positive group, and almost all patients in node positive group had a depth of invasion more than 4.75 mm. The limitations of our study was that it was a retrospective study, a single institution study, and patients with history of chronic inflammatory pathologies cannot be have already been excluded in the exclusion criteria. But in Indian scenario, this cannot be strictly excluded because these can result in interference with the statistical analysis. And depth of invasion, perineural invasion are two parameters which we have used as a biomarkers, cannot be assessed preoperatively, and disease-specific survival and 5-year survival data is awaited. So to conclude, pre-treatment NLR ratio is a strong predictor of occult nodal metastasis in early-stage tongue oral cancers with strong prediction for T2 tumors. The incidence of occult nodal metastasis was found to be proportional to the increase in depth of invasion. The incidence of perineural invasion was more amongst individuals who had pathologically positive nodes. So to conclude, pre-treatment NLR along with other established biomarkers aid as an adjunct and alter the management of patients with early stage oral tongue squamous cell carcinoma. Although there are lack of RCTs on validation of NLR and depth of invasion as prognostic tool with no definitive criteria or cutoff value for specific tumors and population, and further prospective trials on large series, they are required to assess the results obtained and define the NLR cutoff value as recommendations for elective neck dissection of clinically node negative neck. So these are my references. Thank you.
Our esteemed jury members to begin the Q&A for the presentations we witnessed just now. So like the way we did it for the first 5 finalists, we are going to commence it the same way for the next 5 finalists. So I will kindly request Dr. Shankar to come on stage and switch on his camera so that we can start the question and answer round. Thank you so much. Dr. Shankar, if you can please turn on the camera. Yes.
Hello, good afternoon all. Am I audible?
Yes, you're very much audible. I will request the jury members to please begin the Q&A round to Dr. Shankar.
Can I come in?
Yes, please, sir. Go ahead.
Dr. Shankar,
sir,
I have only 2 questions for you. Why did you take other organ injuries and not isolate your pancreatic injuries?
Sir, as a retrospective analysis, I have included all the injuries as presented to our department, sir.
So, in your data, how many were isolated pancreatic injuries?
Sir, 50%, sir. 16 patients. 16 patients, sir.
Okay. And second is, you did not tell us in your presentation where were the site of disruptions. The commonest is at the neck. Why is the injury commonest at the neck, especially in a blunt abdominal trauma?
Sir, the anatomical location of the neck exactly against the fixed vertebral column, sir. So mostly the crushing force, the crushing force which happens in the blunt abdominal trauma tears apart the neck of the pancreas, sir. In most of the situation, So the injury will be more in and around the neck of the pancreas, sir.
Is it the crushing force or the deceleration force that actually ruptures the pancreas?
Sir, if it is it's the mode of injury like falling of heavy weight or like that, it will be a crushing force, sir. If it is a moving vehicle, the patient is in a moving vehicle, it's a deceleration force, sir.
Okay, my last question to you is, why do you need to do a pancreaticojejunostomy after a distal pancreatectomy, especially when the other duct is absolutely clear and papilla is going to drain into the duodenum?
Sir, actually, in guidelines also, there is a resectional management is advised for any patients with the pancreatic injury with the ductal disruption. We advise for a distal pancreatic jejunostomy, especially in patients who had injury close to the neck of the pancreas, sir. We attempted preserving the pancreatic substance in 3 patients who are very young and who are very much of longevity left behind. So we have to wait for the results, sir.
See, it is a crushed tissue, right? Blunt abdominal trauma, the pancreas is usually crushed. So anastomosis that you are doing, you do not know whether it is normal pancreatic tissue or a crushed pancreatic tissue. And logically and theoretically, the chances of disruption of your anastomosis is going to be quite high. Similar to even if you suture it and do not do pancreaticojejunostomy and put in a drain, the chances of fistula are very high. So why do a more morbid procedure in such patients when you are unsure? So locally, what made you decide that yes, this is a patient for pancreaticojejunostomy and this is a patient for leave him alone with suturing of the distal end?
Sir, after the intraoperative observation, if the ends are less macerated, young age group of patients, pancreatic injury is the only isolated intra-abdominal injury and patient is very much hemodynamically stable, we will go for a pancreaticojejunostomy, sir.
Okay, my last question is, do you know of any Indian study on isolated pancreatic injuries?
No, sir, actually one retrospective analysis has been published from PJ Immersion. But I don't know about isolated pancreatic injury. I have no idea.
You have to read, since your topic is that 2007 tropical gastroenterology. Go ahead and read it. I leave it to the other jury, please. Thank you.
Thank you.
Hi, Shankar. So what was your basis for non-operative versus operative management? And then how many in the non-operative management have to be operated later on?
So actually, the conversion of non-operative management failure in our group is 3 patients, sir. Who have developed one patient developed distal pancreas going for operator on the patient. We have done a necrosectomy, and 2 patients developed a pseudocyst, and we have done a cystogastroscopy, sir.
So when do you go for non-operative management?
Sir, a patient presenting in a delayed manner, and the patients have associated organ injuries, and patient has a hemodynamic unstable patient, sir. Hemodynamic unstable. If the patient is on resuscitation, we will wait and watch, sir.
But if it's unstable, means that's some other organ injury and that has to be operated, no?
Yes, sir. For patient is having multi injuries, sir. Patient, 2 of our patients have bilateral thorax, and we have put them on conservative management. And one of our patients have long bone injuries, sir, going for immediate orthopedic procedure. So in that scenario, we have maintained conservative management, sir. Otherwise, lower grade injuries, we have maintained on conservative management, sir.
What about pancreatic duct stenting? How many have you done?
We have done 1 patient, sir. We have done successfully in 1 patient.
Okay. So what is the cause of mortality in the 1 patient who died?
Sir, a patient presented on the 29th day of post-injury, sir, with full-blown sepsis and succumbed to sepsis, sir.
Okay. And these pancreatic injuries, were they referred with the diagnosis of pancreatic injuries, or they just came and you diagnosed them?
Sir, actually, out of the 20 patients referred, 8 patients have been referred with the diagnosis of pancreatic injury, sir. The rest of the 12 patients have been referred with some sort of other diagnosis, sir, for further management from local government hospitals.
Yeah, because in your conclusion, you say the pancreatic injury should be managed by experts. What do you mean by experts?
Sir, experts at least they got elective as well as emergency hands and pancreatic surgery, sir.
Okay, thank you.
Thank you, sir.
Other jury members, please.
So Shankar, of your delayed injuries,
yes, sir.
So can you state that which one can go for conservative, or when they come to you, then you can say this one can go for surgical management and non-operative management? It's only or is it only on clinical deterioration that you decide?
Sir, one is depends upon the clinical scenario, and another one is depend upon the grade of pancreatic injury as per the imaging, sir. With that, we will decide, sir. And if you have any doubt about ductal integrity, we will go for MRCP, and then we will decide, sir.
Okay.
Can I come in? Yeah. Shankar?
Sir?
Am I audible? Yeah. I mean, one question would be, again, you could have excluded, you could have restricted it to either pancreatic trauma alone or pancreatoduodenal injuries, because I think with some of the other things that you have mixed up with hollow viscous injury, etc., are the ones which would be. And I believe in the early group, for less than 48 hours, one patient which was managed conservative needed to be readmitted and operated. Is that right?
Sir, one patient in conservative management, sir. That patient underwent successful ERCP and stenting, sir. So we have managed him successfully in conservative management.
And you have talked about early ERCP. Have you resorted to early ERCP in some of these patients? And what all criteria you should fulfill before you consider an early ERCP?
Sir, in immediate imaging, once we receive the patient, if it shows there is not much of disruption of the distance between the both disrupted ends of the duct is very well be managed with the endoscopic therapy, we will go for ERCP, sir. We have done.
How many patients you managed in that manner?
Sir, actually only one case we have managed with ERCP and stenting, sir.
Okay, and I find it a bit interesting when you say since most of the patients are economically active, the management of pancreatic trauma must be done by experts for better outcome. I thought expertise is required for all patients, whether they are economically active or not. No?
I want to stress that issue, sir. That's all.
Yeah.
Nothing else.
You have to provide the best result, irrespective of how much is the patient, economically active or not. And so, what would you think that based on your nice, this 5-year study, what are the learning points for the magistrin clients?
Sir, the first thing, the early suspicion, sir. Early suspicion for pancreatic trauma in a certain group of patients with blend trauma abdomen. And second thing, suspicion with followed by appropriate imaging, sir. And to identify the cases earlier. And third thing is appropriate management, sir. Either conservative or it is surgical management, appropriate management by expertise, sir. And the fourth thing is better to preserve the pancreatic substance, sir. That's what our department considers, sir.
Okay, over to the other experts.
Hello, sir. Hello.
Yeah, how are differentiating which imaging do you think that very valuable in identifying the pancreatic trauma? MRI and CT, both you have done.
Sir, in presentation of acuity, it's better for more of our patients. We have done CT in all the patients, sir. Yeah. But for ductal disruption, it's MRI or MRI with MRCP or it's CT, sir.
So when you are deciding that in CT there is some suspicion of disruption that you are confirming?
In CT,
MRI?
Sir, in CT, if there is features which is suggestive of majority of the pancreatic parenchymal transaction, that is almost more than 50% of the parenchyma has been transected, or if there is any appropriate transaction, complete transaction, then we will go for MRCP, sir, to identify whether it is a ductal injury is persistent, and whether we can go for a ERCP or we can go for operative management.
Next and the last question is, you have decided less than 48 hours and more than 48 hours.
Yes,
more than 48 hours, you are more in pancreatic trauma. And what is the hypothesis that you are conservative management, even after 48 hours?
Sir, more than
and
48
you
hours.
Lost 1%, and among that, you lost 1% also.
So in more than 48 hours group, most of the patients presented with extensive inflammation, sir. Extensive inflammation, and most of the patients presented with traumatic pancreatitis, sir. So we didn't want to enter and do any surgery in those patients, sir.
That condition you don't put also drain.
Sir?
That is, you are not interfering anyway. That's you are not putting drain also in that abdomen.
No, sir. We didn't put any drain in those cases, sir.
That way, you lost one case that after 48 hours. This is because of sepsis.
Yes, sir.
The
Patient
after you thinking that you had modified it, it was conservative.
Sir, actually, the patient has been referred after almost 3 weeks, sir. 3 weeks later, the patient has been referred, sir.
Okay. Okay, thank you.
I have one last question for him. Shankar, can you tell me what is a pancreatic protocol CT, which may not be directly related to pancreatic trauma? It's okay, let it go.
Okay. I think the question and answer round to Dr. Shankar is over now. So thank you, Dr. Shankar. Thank you, our jury members, for that discussion.
Thank you. Thank you. Thank you. Thank you, the jury members. Thank you. Thank you, sir.
Thank you, Shankar. Well done. Thank you.
Thank you.
So we'll move on from here, and we'll have now Dr. Niharika for the Q&A round with the jury members. Dr. Niharika, if you can kindly switch on your camera.
Niharika, can you hear? Can you hear? Niharika, can you hear me?
Yes, sir. Yes, sir. I'm
Good. Okay. Maybe louder, please.
Okay.
So basically, in your study, you have said the sample size is 300. Is that correct?
Yes, sir. Yes, sir.
But there is no other numbers. I don't know if I missed or not. You don't know how many had benign breast disease, how many had this thing. Nothing was there on the.
Sir, all 300 patients were of benign breast disease, sir. Out of whom, atypical hyperplasia was present in 36 people. Rest
How many had?
36. 36, sir. Rest all
36.
had non-proliferative breast disease.
That's given in your slides?
Yes, sir. That was missed, sir. That slide actually.
Of that, then you looked at the family history, all those things in that.
Yes, sir. Of that, every variable that is considered as a breast cancer risk factor was looked into, sir.
So how will they change your management between the ones who had this thing and the other group? Because all of them present with the breast disease, right?
Yes, sir.
All of them require a biopsy anyway.
Non-proliferative disease, the risk of future breast cancer is lower, no, sir. It's only 1.5 to 2. But with atypical 0 and without atypia is 1.5 to 2. With atypical hyperplasia, it is 4. So we are taking that people at least who have a higher risk have to be offered something additionally, and hence we are trying to identify the people who are at a higher risk, sir.
So they need closer follow-up, is that right?
Yes, sir. They need closer follow-up and probably additional screening methods like a breast MRI, sir.
All right, thank you.
Niharika,
Yes, sir.
what is the role of controls in your study?
So the role of controls was that these people were also at risk of benign breast disease, but we are comparing that this high group, like history of benign breast disease itself confers a higher risk for breast cancer. But within this also, we are able to identify people who are at a higher risk. And in a country like India, where everyone is not able to access all modalities like screening and chemoprophylaxis, maybe identifying a higher risk group will be better.
Okay, can you tell me what are the proven benign breast diseases with increased risk of cancer development?
So the proven breast diseases, sir?
Yes, benign breast diseases.
Okay, sir. Sir, a typical ductal of atypical lobular hyperplasia, lobular carcinoma in situ, and columnar cell change with atypia, any all proliferative changes with the atypia.
So all these patients in your study had biopsy, all 300?
Yes, sir. All 300 have undergone true cut biopsies. This study is actually a part of my thesis, sir.
Okay.
So I have only followed.
Okay, you said the BIRADS 3.
Yes, sir. BIRADS 3.
BIRADS 3, what are the benign breast diseases that they can present as BIRADS 3?
Probably benign diseases will be presenting as benign breast BIRADS 3, sir. Mostly it will be proliferative diseases. Most commonly, proliferative diseases with or without atypia can present as a BIRADS 3, sir.
Yeah, but they cannot, you see, they don't have typical radiological pictures. Most of the time, these proliferative disorders are incidental findings on biopsy.
Yes, sir. Yes.
Okay. The BIRADS is mostly for diagnosing cancer.
Cancer, sir. Yes,
not
sir.
For
what we had, sir, BIRADS 3 was more reported, sir. Maybe that was a radiological problem, but most of our biopsy reports consisted of fibrocystic disease, sir.
That's what I'm telling. So most of the time in a mammography, what it shows is the BIRADS is mostly related to the typical well-defined circumscribed benign breast diseases like fibroadenomas.
Yes, sir.
Okay, those proliferative diseases are difficult to diagnose on mammography.
Yes,
They are incidental findings when you do a biopsy.
Yes, sir. But generally, when we have a BIRADS 3 on mammogram, we send the patient asking for a follow-up. The purpose of my study is that identifying people who are at a higher risk by these risk factors, maybe it will help us in detecting the cancer better.
So you mean to say that we should go for biopsy in all BIRADS 3?
At least people who have the higher risk factors like age, family history, and a dense breast, sir. That is what my study's purpose was, sir.
Okay. How do you grade the density of breast?
BIRADS, American College of Radiology has given BIRADS scoring, sir. 1, 2, 3, 4. 4 is dense breast, sir. 3 is heterogeneously dense. 2 is scattered fibroglandular tissue. 1 is fatty tissue, sir.
And you also have shown some family history correlation.
Yes, sir. Family history. But family history was only present in 2 cases in my study, sir. Those 2 cases had atypical hyperplasia, not any other histological picture.
Okay, thank you.
Thank you, sir.
Other juniors.
Okay, Dr. Niharika.
Yes, sir.
You have done all 300 cases biopsy. That is a guided biopsy or like blind biopsy?
Sir, on mammogram, people who had, we only considered people who had a lumpiness, sir. So among people who had BIRADS 3 and the lumpiness, the area of lump was targeted, sir, in our biopsy.
This one's guided, mammogram or blind?
No, sir, not mammogram. Clinically, where the lumpiness was there, that was taken, sir. Because BIRADS 3, they haven't given any suspicious area, sir. They couldn't mark.
This is a diffuse, that's why you are taking the blind biopsy. How it will be representative and how often you missed the characteristics?
The false negative rate will be higher, sir.
No, this is not mentioned here. You study all the 300 cases, how your statistical, all this analysis is not there.
Sir, yes, sir. I should have kept them. Sir, for everything, we have done a chi-square test and also an odds ratio, sir.
Okay.
Yeah.
What's the next?
Yeah, Niharika, what is the average time that you need to follow up these patients? Because you said that the benign breast disease is a risk factor for malignancy. So, as per literature, what's the average time that you need to follow?
Sir, the lifetime risk of this, at a 25-year period, they will have a 30% risk of breast cancer, sir. People who have atypical proliferative breast disease.
Right. And I have a little difficulty in understanding some of your conclusions because based on your data, like the first conclusion that you draw that as per our study, early age menarche is associated with a raised odds ratio of 1.5 times.
Yes, sir. I should have kept the entire
but not statistically significant.
Now, how do you derive that? This is not your population study, or I don't think control group also. I didn't, if I missed it, I don't know. But I think based on your data, a patient in that perimenopausal age group presenting with this by RAD3, how can you conclude? And similar is the thing with some of your other conclusions as well.
So what I have done was, we have first performed an odds ratio, sir. So, and after that, what we have done was, we have went for a chi-square Fisher's test. My comparative data, my control group was those patients who had non-proliferative breast disease and also proliferative breast disease without atypia, sir. My test group were those who had atypical proliferative breast disease, sir.
And what about the, you said that early childhood has also been a
yes,
risk
sir.
factor?
We have taken like early menarche is less than 13 years and early age of childbirth was less than 21 years, sir. What happened is that because in various forms of literature, late age at first childbirth is considered a risk factor, sir. But our entire 300
Is
people.
childbirth a risk factor?
Yes, sir, for breast cancer.
Yeah.
Nulliparity.
Nulliparity and late age of childbirth more than 30 is given as a relative risk.
Right. So and you are saying early childbirth is also a risk factor. So which one of them is
No,
true?
sir, late childbirth. But for our patients, all 300 of them had a childbirth less than 19 years, sir.
Right. Okay. Over to the next jury. And we are running out of time, I think.
So what is the other conclusion, Niharika? Most of the girls in Andhra get married early?
Yes, sir, and they're also hysterectomized very early, sir. That was what we found in our study, but most of our patients come from low socioeconomic status, sir, as a government hospital. So that might be a factor.
Any other questions from other jury?
I think we just reached text here.
Yeah.
So if we don't have any further questions, can I move on to the next one?
Yeah.
Thank you, Dr. Niharika, for the discussion. We are moving on to now have Dr. Shavik Paul for the Q&A round. Dr. Shavik Paul, I request you to kindly switch on your camera and get ready for the Q&A from the jury panel.
Thank you. Good afternoon, respected jury members.
Hi, Shavik. Hi.
Hi, sir. Good afternoon.
Very nice study. High profile study, I think.
Thank you,
so
sir.
First of all, I wanted to ask you, how did you actually choose these inflammatory markers? Because there are quite a few
Yes, sir.
that you mentioned. So you've chosen
Yes,
only 3 out of all those. How did you choose that?
Sir, actually, in literature, there are numerous markers are defined, but most commonly studied ones are the TNF-alpha, IL-6, and the adiponectin. And choosing these 3 markers because of the basis is that TNF-alpha and IL-6 in of the cases is the triggering factor. Because if we get a pro-inflammatory response or anti-inflammatory response, like for pro-inflammatory Th helper T cell 1 response or anti-inflammatory helper cell T2 response, the triggering one is the TNF-alpha or IL-6, which is being stimulating other factors, and then the stimulation goes in a vicious cycle. So that could be the basis or the basic first step, first hit. So that's why we choose the things, and the other reason is that these are the most studied markers in the literature.
So one question regarding your control group.
Yes, sir.
So you've taken a control group which is just a normal population with no surgery at all.
No surgery.
Do you think it could have been better chosen?
Yes, sir. It could be better chosen if we could have a obese patients with NFLD who doesn't have any surgery. But this is population is difficult.
Or even better, a non-obese group who's undergoing surgery. Because you're looking at patients who had surgery, right?
Yes,
effective surgery on the inflammatory markers is partly what you're looking at.
Yes,
sir. You need another group who's non-obese and is undergoing surgery. Would that be better?
Definitely, sir. But we choose because we have to establish the baseline inflammatory burden in the NFLD patients and the obese patients. So that's why to compare that we took the control group. But obviously, as you said, that could be a better choice, and we'll keep this thing in mind in the future studies.
And what
Last
about
question?
What about obese patient undergoing other surgeries? Because I think you are having some inflammatory markers. And I think probably the timing would have been important, because in your study, initially there was a rise in the inflammatory markers. So
Yes,
I
sir.
think to take away the trauma of the initial surgery, I think that also might be, another group that you could have as
Yes, sir. Obviously, that is in our mind. But I want to say that regarding the timing, that 3 months initially when the rises, in literature we have studied such that at what time TNF alpha after any surgery rises and then decreases. We found that there is usually within the 7 days maximum rise and then gradually tapers down. So that was the basis that we selected 3 months as the first point in the follow-up.
Won't this be the same for any surgery that you do? I mean, in a non-obese patient, for any other surgery, or obese patient for non-bariatric surgery?
So that data I could not derive from the literature. I could derive from cardiac bypass surgery and other surgeries in normal patients, irrespective of the BMI. They showed that TNF alpha IL-6 levels are increased at the fourth or peaked at the fourth or the fifth. This is in around 2002 studies in the Western literature.
So finally, what is your clinical implication? I mean, you have said that these are avenues for new treatment. How does that work? I don't understand.
Sir, if we could have definitely say significantly in numerous studies with even a good control trials that TNF alpha is raised and it is being decreased after the surgery or IL-6. So there could be some antibodies or monoclonal antibodies to these things which could have impact on the treatment of the NFLD without any surgery. And even in initial days, nowadays, 2020 March, there is a published paper from the USA that shows the anti-TNF alpha in mouse models. They showed helps in decrease in the hepatic steatosis and also to extent non-alcoholic steatohepatitis. And also some studies are being undergoing taking tocilizumab anti-IL-6, which is quite known in this COVID era.
All right, thank you.
Yeah, very good, Souvik. That's what actually I was about to ask. What are the clinical implications, and whether your mind is working on future sort of interventions? You have rightly said, yes, you can look at the pharmacological interventions against inflammatory markers. That's a really good answer from you.
And
Dr.
Yes, sir.
And how would you kind of interpret the type of surgery that you have said? Are you suggesting that probably RYGB is better than sleeve gastrectomy for this purpose?
Sir, from this, our study is not powered to answer this question, obviously. But if we take our results, we can say that RYGB will be the preferred one, which has a better specifically, which has adiponectin. Adiponectin is has anti-atherogenesis factors. So for patient with cardiovascular disease, RYGB would be a better choice. But to answer
that would be carrying the results too far, because I don't think this data is enough to really suggest, because I agree. You'll have to correlate with that also the rate of weight loss which happened and other things. And I think also I think your yardstick has been the fibroscan, isn't that right?
Yes,
so
sir.
Things to look at that, and whether 3 months, 6 months, how's the accuracy of a scan to really determine that. So I think there'll be a few other things that you'll have to throw in before you can make that conclusion that actually RYGB would be kind of better.
Yes, sir. One thing I want to just mention, regarding the fibroscan accuracy, a part of this study initially, which are ready as a manuscript and will be going for in other journals. So in that case, we have shown that fibroscan is quite accurate with Kapra statistics showing a 0.75, which is good Kappa statistics showing agreement with the fibroscan with the liver biopsy. So that could help in initial, but obviously this is the initial days, as you rightly said.
Okay, Souvik, based on this study outcomes, if you are given a big grant and asked to carry out a good study, how will you design it?
Sir, in that case, first of all, I would include another factor in this, that is the gut microbiome, which is the most evolving thing in the literature, because gut microbiome, cytokines, bile acid pool, these are things that all correlated and pathophysiological are the things which the major pathological basis of the NFLD and obesity. So in that case, I have to take the NFLD populations with obese patients, bariatric surgery, and as the control group, we must have a 3 control groups, as you said, that obese patients going surgery, obese patients not going surgery, or normal patients without NFLD without going any surgery.
Because that is very important, because you see, even normal surgery causes a stress response.
Yes, sir, definitely.
And inflammatory markers will be raised. Unless you have
Yes.
that baseline value, you cannot conclude that obesity.
Yes.
Sorry if I missed, did you have liver biopsy in any of these patients at the time of bariatric surgery?
Yes, sir. And the baseline, they have liver biopsy, and at that time, we have correlated the liver biopsy grading of the steatosis fibrosis with the fibroscan grading and staging. But that is not included in this because that is the initial part of the analysis and not appropriately related to this topic. That's why.
Okay, Dr. Souvik.
Yes, sir.
Can I ask
yes, sir.
Only one question, that is on basis of fibroscan. Like suppose they are giving the index 9, you can decide your bariatric surgery, or you can suggest any other intervention.
No, sir, not necessarily, because on fibroscan I have to see whether this value is valid or not, and otherwise along with that whether the patient's architecture of the liver in the ultrasound, which is it looking cirrhotic or that. So if the patients have a severe fibrosis like 13 or above and nodular liver, so we do not undergo this patient RYGB in this patient. But as you said, 9 fibroscan value is not sufficient to decide as a deciding factor.
Okay.
So a good study. How was the sample size of 23 patients calculated? You've given the power errors,
yes,
but
sir.
expected reduction in cytokines you not provided.
Sir,
also, could you explain why the control group had high level of pro-inflammatory cytokines, and why you measured cytokines level at 6 months rather than 6 to 12 months after surgery?
So, sir, first of all, that TNF, the pro-inflammatory cytokines are higher in the control population, specifically TNF alpha. That was a bit striking feature in our study. But when we goes into the details of this study, we found a specific thing that patients who were diabetic in the control group has a higher TNF alpha level. This strikes our mind. But we could not get an answer. But we analyzed and searched in the literature that patients who have, we got a study that patients who are using metformin usually have a lower TNF alpha level. But as we do not have insulin resistance HOMA-IR level in this group of patients, we could not come to a conclusion. So these things we should consider in the future studies. And the second thing, sir, you asked that 6 months, because 6 to 12 months we can take, but 12 months is quite long duration, and in the Western literature, most of the 70 to 80% studies says that after 12 months these levels are decreased. So the early thing is we need to hit this, because as we give time, progress time, suppose we give a medicine, medical treatment which is being acting after 1 year, so that will not be so much helpful in future.
And sample size?
Yes, sir. Sorry, sir, forgot that. Regarding sample size, in the previous study, 2012 Spanish study by Ilan Gomez et al., they showed a statistically significant reduction in the TNF alpha, IL-6, and the adiponectin. From that, we calculated the sample size for each of these markers, and the total of this minimum sample size come to be 23. It was exactly, I think, for adiponectin 9 and other exact values I cannot remember at this moment. Total was 23. So we considered that we have to be a sample size minimum of 23. And fortunately, we get up 50 eligible fit patients for this analysis, which approximately powered the study around 90%.
Okay, thank you.
I have 2 questions.
Yes, sir.
The first question is, you have got 3 departments helping you in this study.
Yes, sir.
Of the 3 departments, which do you think is the most important?
Sir, all of these 3 are important according to this merit.
I want 1, 2, and 3.
So for this study or the disease, understanding of the disease, for this study, obviously the patients are coming to us and we are enrolling the patients. Obviously, we are the primary, and then radiologists, which are giving us the basis for the estimating steatosis and fibrosis, and then the pathologists.
So you want your department to be number 1, lab services to be number 2, and department of immunology as number 3. Is it right?
Yeah, yes, sir. For this.
Fair enough. Fair enough. I don't want reasoning. My second question to you is: suppose you are given this award, how will you use it for benefit of Indian population?
Sir, my area of interest is hepatobiliary surgery. So in this regard, as my topic is related to the liver, so in this regard, I will get idea from the other areas, other international countries, that what they are doing and how their research is going on. So we could have a better idea and concept to develop an area of research in our country. So we could get so maybe in next sometime we could be the one that we are developing some medicines for this disease. And also in the present days, the liver transplantation indication, if we say per se, that NFLD is presently the 3rd most common cause. So that will help to reduce the burden of the liver transplantation in this group of patients if we could develop a medicine which can decrease the progression of the NFLD.
Do you think staying in full-time service and going in private practice, concentrating on liver transplantation, which is better in respect of research?
Sir, in respect of research, full-time research is the most important, but it can be continued along with providing service to the patients also.
Thank you.
Thank you, sir. Thank you. Thank you to jury member and the organizing team. Thank you.
Thank you so much, Dr. Shouvik Paul. So moving on, we have Dr. Yash Sinha for the Q&A round. Dr. Yash Sinha, if you can please switch on your camera and get ready for the Q&A round.
Hello, good afternoon, anyone.
Hi. Hi, Dr. Yash. Fantastic data collection you had. So where was the funding for that from?
It was from the Swedish Council. There was a Swedish data registry system that had provided funding for the data collection per se. So the data collection was funded by them, and we did the annual.
So who actually collects the data from each center? Who does that?
So before the start of the study, we had trained project officers. So we had project officers who were previously trained, given a week's training, and advised in the methods of data collection of what we wanted, and they collected the data for us.
So it's a prospective collection.
The collection was prospective.
Yeah, a couple of issues with your conclusions. You have concluded that there are logistic issues with treatment of these patients, like financial and lack of blood products, etc. How did you conclude that from your data?
Sir, the difference in a study, like normally the Western the Western guidelines normally recommend that the grade 4 injury should be straight away taken to the OT. But I worked in a government hospital, so we had lack of OT tables. So suppose a trauma patient comes rolling in and the OTs are occupied, so we cannot be pushed into at the very same time. And so there are a lot of blood products are not readily available, and sometimes angiography is needed or imaging is needed.
But how can you conclude that from your study? You don't have any of those data with you.
No, I'm not concluding.
That's what your conclusion was.
No, I just mentioned that the probable reasons for the discrepancy might be one of these. I didn't conclude that, but I said that could be one of the possible reasons for the discrepancy between our findings and the Western literature findings.
You also mentioned that there's a lack of protocols in hospital. How do you conclude all that?
Actually, sir, lack of protocols mean the WSC guidelines that we normally talk about, like in the current scenario, were initially published in 2015 and then were revised in 2020.
And before that, there was no as such protocol directed management or how the patient should be. And before the start of the study, the hospitals that were managing liver trauma had their own consensus or the line along which they were managing patient. But there was not a common set of protocols along which all the patients were managed.
So I think on the same, you go from here. What are you going to do after this? Sorry, last question.
No, I was just adding on to your question, so that's right.
Yes, I just finished my post-graduation general surgery, and I've joined as a surgical gastroenterologist, and I hope to be a liver transplant surgeon in the future.
Yeah, I mean, from your study, what are you going to do from your study? How will you what gain has India made from your study, and how will you progress that study further?
Based upon the studies, we have had a lot of progress. Like the National Injury Surveillance Centers have been established in the RML Hospital and the Jayaprakash Trauma Center. So we are going in that line, and I believe that we Indians are like very good. So we have a good set of surgeons, but we don't have data. Our results don't get published. We don't get the acknowledgement that we should get. So yeah, and for authentical data, we should have a basic have a good data collection system and a trauma registry system. A trauma registry system in the.
Thank you.
If I may add on from what Sudhi talked about, because certainly very good data, and you got the data from various centers, which is fine. But again, sweeping kind of conclusions from which are not based on really the study, because like even when you said low and mid-income, because countries, you can't say that is your conclusion based on, because you took some centers from India where you got this data, isn't that right? So I think, and I think on the same lines, I find that in some of the other things also, you have kind of more of your opinion. It was more of a talk on how you should, go about establishing trauma services rather than, because when you are talking or presenting as a study, then you have to have defined aims, and then you analyze the data and come out with what are the shortcomings or what are the, some of the things, and discuss in the light of the, like probably it was fine to say that if you had a set protocol which you agreed upon, because considering that this was a prospective study, so probably for all the participating centers, I think usually the way to go about it is that you set up a protocol, and then you may say that in some of the X percentage of patients, you were not able to follow that protocol because either the theater was not available or some XYZ. So you could come out with, say that those are the limitations of carrying out the trauma services in these patients. So I think, and I think again, some of the things you just mentioned, Jayaprakash Trauma Center was not as a fallout of this study. I thought this has been going on for a long time. And there is no doubt that RML and other places, trauma services are required in all centers. But those are the opinions. And I think what we would want you to focus is that probably you have a fantastic data, fantastic, from various centers across the country. But I think when you present a study as a postgraduate, you have to stick to what your aims are, what your data you have collected, and how you've interpreted in the light of the available literature, and what are the shortcomings.
Yes, sir. I do agree that, sir. This was basically a subgroup analysis, and we didn't have like predefined goals at the start of the study. So we had a
Hello.
Hello. Yes.
Hello. Yes. Can you hear me?
Yes, I can hear you, sir.
Yeah. Yes. I just wanted to ask, since you're dwelling into the data and registries, can you tell me what the difference between a registry data and a clinical database of a department? Which is better?
So I don't know the exact difference, but I can give you registries have a common set of variables that are to be followed across all the participating study centers. Yes. But the clinical data set might vary from center to center.
Absolutely. You see, while I'm asking this in the operative outcomes data in your registry, if you see 74 out of 106 surgical details are not available.
Yes, sir. Yes, sir.
The surgical management group.
Yes, sir.
Okay, so that is a big lacuna. So unless the registry is properly designed,
yes,
you will not get a good quality data, because almost 2/3 you are not aware what kind of surgical management was done
yes, sir.
in the surgical field.
Yes, I do
So
agree.
that is the lacuna of the registries. So individual departments, high quality databases are extremely important.
Yes, sir. There has to be a coordinated effort amongst all the centers and hospitals in our country to make it an authentic and a reproducible system.
Yeah. Yes.
Okay. So yes.
Yes, sir.
Yeah, just there are so much comments and all these things. With that, still I am asking one question: like government is setting up all AIMS new trauma centers. Do you think that any specialized like GI surgeon should be recruited for trauma center to take care of like liver injuries? Like it will be handled by everyone.
No.
Like
I
general
don't
surgeons.
believe that. Designated GI surgeons. Anyone who has expertise or who has been handling this over a period of time and is confident enough of doing that, they should be given the handover for these.
So how will develop that trauma center?
Sir,
like for especially liver trauma, you are telling. Most you are going for the conservative type. You are supporting.
Yes, we deducted those because we had a lot of operative mortality. From my results, amongst the mortality was very high in the operative group. So the reasons could have been varied reasons. Depending upon the physiological variables of the operative who underwent surgery was very bad. So that could have been one of the reasons. And then, sir, basically,
and most of the time you see the polytrauma, not like isolated liver trauma.
Yes, sir. Liver is normally very protected. So normally, if you have a liver injury, you're bound to have other injuries, which is a common. It's very hard to just isolate on liver injuries and focus on them per se, and not look at other injuries. Because the main reasons for operative management liver injuries are associated injuries rather than the liver injury per se.
Just I'm telling you what total analyze and what is your study, how it will be implicated in the practical. Any outcome from your study?
So basically, we can try to find out what were the causes of the death. What were the causes of death in the patients, and whether there was we should have. We don't have data per se. What happened? What were the intraop events? What happened? What happened to the patients in the post-operative period? We just know they died. So we need to have like a better data collection, better to document all these, and then maybe we could find out reasons how to improve our healthcare.
Okay, that's okay. Yeah, myself.
Yash, so much must have changed between 2015 and 2019.
Yes, sir.
Your data is between 2013 and 2015.
Yes, sir.
Why have you not improved on this data?
Sir, because the data group that we analyzed was from TITCO. So, it did not have further data sets that were given to us for analysis. So, I could not have included, the data from 2000 and beyond 2015 and 2019 because we were not provided with the data set per se.
But you could have tried and evaluated. You were working in one of these institutes. And
we did not have a registry system here. So the document, we do not have so the data was not there.
You could have included, because what is happening right now is you are presenting a published data. Now, once you submit data for publication, it becomes copyright of the publisher.
Yes, sir.
So how do you wriggle out of this situation?
Sir, we had taken the consent, from the authorities that the Swedish and the Lauder Foundation was only involved in data collection, and the statistical analysis and everything. What we do with the data was given to us. So already the legal clarification had already been done before we were given this data.
What about the journal? World Journal of Emergency Surgery. Where is the permission for you to present this data?
So we had taken consent and we had submitted to the journal itself.
It should have been part of your slide.
Yes, sir.
You have already talked about funding in your slide. You should have written one more line. permission taken from publisher?
Yes, sir. I mean, we have taken permission from the Swedish and the Larder Foundation.
No, I'm asking about the World Journal.
Yes, sir.
Where you have published this article in 2020.
Yes, sir. After we took permission, but yeah, I did not include it as a part of my slide.
Are you going on record that you have got a permission?
Yes, sir.
Okay, fine. Thank you. One more last question.
Yes,
what is this slide statistical analysis Wilkinson rank sum test?
So Wilkinson rank test is like, I mean, it used to compare categorical, I mean, if you have two categorical variables, it is a test of significance that is used to compare two categorical variables, sir.
Is your spelling correct?
I'm not sure, sir, but if you made a point, it must have been wrong, but
go and cross check.
Yes, sir.
Anyway, for the other juries, this boy has worked in my department. I have asked him questions. They may be nulled and void if at all you feel correct, and I will not be part of any marking as far as this boy is concerned. Thank you.
Okay, so I think that concludes our Q&A round with Dr. Yash Sinha. Now let's moving on. We can invite Dr. Usha for the Q&A round. Dr. Usha, if you can please switch on your camera.
Hello.
Yes, Dr. Usha.
Good afternoon.
Hello, Usha, hi, can you hear? Oh, hi.
Yes, sir.
Hello.
Good evening. Good afternoon, sir.
Good afternoon. Hi. Thank you very much for your presentation. Just one question. You said in your conclusion that your NLC ratio is going to alter the management. How does it do that?
So,
How does it alter the management? And when do you actually do the NLC ratio? At what time point of admission or pre-admission, or what? When do you actually do it? Does it actually change during your course of treatment?
Yes, sir. So, sir, the first question regarding the neutrophil to lymphocyte ratio, basically, we need to identify the T1 tumors in the early tongue squamous cell carcinomas, wherein such patients may not require an elective neck dissection. So if you're able to identify these set of patients where they need not be undergoing a neck dissection, you can actually stratify them and keep them on watchful policy. When we do this NLR is right before the patient is posted for surgery. That is the pre-anesthetic checkup when they go. The CBC that is being done before their pre-anesthetic checkup was considered for this NLR ratio, sir. Because post-operatively and during the adjuvant therapy, these NLR ratios can be altered. So we have excluded all the patients who had a previous history of cancer or had a previous history of any infection or inflammatory disorders. And hence NLR was calculated only for patients who did not have any of these conditions.
I mean, if NLR is high, what do you do? If it's low, what do you do? What change does it matter?
So what we have done is, so there is no cutoff which has been given in any of the literature regarding this has to be a particular cutoff. So based on our study population, we have taken the cutoff as 2.66. So what we...
How did you get that cutoff from your retrospective data? I didn't understand.
So we did a receiver operative characteristic
On what?
curve. It is a graphic. Based on the NLRs of all the patients, all the 134 patients in our study. And then we plotted it on as a graph. And in that, under the area of curve, we have taken 0.8 as a cutoff. For that, we calculated the sensitivity and
specificity. It's a self-fulfilling prophecy, isn't it? I mean, you have done your own data, you have analyzed, and then you're saying this is... So what is Jordan's index?
The Jordan's index is basically equation which is used for calculating the cutoff value, wherein you add your true positives with your false positive ratios.
That's ROC curve, no?
Yes, sir. ROC curve. On that, you
Jordan's index. What is Jordan's index? How much? Where does it go from where to where? What value normally you get?
So it is the maximum distance of the square between the where the specificity and the sensitivity is maximum, sir. That is where you take the Jordan's index, and that is taken as a cutoff value for the NLR.
No, Jordan tells you what the accuracy of a test. You see, so specificity plus sensitivity minus 1.
Yes, sir.
So if it's 0, that means if it's 100% sensitivity, 100%, this thing your value will be 1.
Yes, sir.
If it's 0, it's no good. So it's between 0 and 1.
Yes, sir.
Thank you.
Okay, Dr. Usha.
Yes, sir. Good afternoon, sir.
This is a good study.
Thank you, sir.
Two questions I will ask.
Yes, sir.
One is the depth is already widely taken as the 4 millimeter. Why you are putting it to the 4.6?
Sir, the thing is, the depth of invasion was being introduced into the AGCC in 2017, where T1 was differentiated from T2 at 5 mm, sir. So basically, this validation of depth of invasion has not happened in any of the randomized controlled trials. This was basically based on the largest retrospective data where they included 3,000 patients. So in our study, all the patients we had analyzed from 2017 to 18, and at that time, AGCC 8th edition was not taken into consideration. So 7th edition was being followed up. My patients, I have considered the post-operative depth of invasion, and based on this, I have calculated a cutoff value, and this correlates well that T2 tumors had higher node positivities in our analysis.
See, that is the depth of invasion. Before that, that was deciding like in terms specially, that is deciding the adjuvant radiotherapy. That time it was taking like 4 millimeter.
Yes, sir. Yes, sir.
Yeah, then like AGCC stage, 8th stage, the depth involved, that is different. Before that, they are taking. But you know, which basis you are deciding this is for your study, it is 4.6 is a cutoff line.
Yes, sir. Again,
Anything,
based on ROC curve, only we have calculated this cutoff, sir.
Okay, second thing is like depth and PNI, these are the already established prognostic factors.
Yes, sir.
What new things you are finding in your study? Which
So
is
one
respect to
is-
the NLR.
Sir, there were all three independent parameters that we have analyzed. There was no relationship between the NLR and the depth of invasion or PNI. So what we have seen is depth of invasion. The validation of 8th edition was very much confirmed with our study. PNI, what we are trying to see is the node positive patients had higher rates of perineural invasion, and that is again an adverse feature for considering your adjuvant treatments.
Yeah, that is already established.
Yes, sir.
This is your new finding is like NLR.
NLR is the new findings.
That is,
Yes,
I
sir.
just going with the study on how it will change your practice, because already randomized study like that is a selective neck dissection is better than the therapeutic neck dissection.
Yes, sir.
This is already
So,
established.
yes, sir. But in T1 tumors, watchful waiting can still be considered, sir, rather than subjecting every. So, because the overall survival has not changed in a few meta-analysis where T1 was compared versus
No, this is a
T2.
randomized study. In our study from TMS also they established this is the selective neck dissection.
Yes, sir.
Is better than therapy.
Yes, sir. Sir,
How
and
only
then
one study that usually prevent disease.
no, sir. There was a meta-analysis again which showed that disease-specific and disease-specific mortality is reduced when you do an elective neck dissection. But overall survival, there is a trend, although there is no difference, statistical significant difference between the overall survival, sir, in watchful waiting versus neck dissection.
Okay. Dr. Usha.
Yes, sir. Good evening, sir.
Yeah, it's a good study. You are looking at some simple non-invasive markers.
Yes.
Okay, to optimize neck dissection or neck management. So NLR is being done in most of the solid tumors nowadays. Okay?
Yes, sir. Yes, sir.
And it is not specific for oral cancer or lymph nodes of oral cancer. So how will you overcome this problem? Can you just decide based only on NLR?
No, sir.
Yeah.
So NLR can never become an independent prognostic marker. It can just be an additional marker to the existing ones so that we can formulate probably like a nomogram to risk stratify these patients, that these patients definitely need a neck dissection and certain patients who can be omitted a neck dissection and kept on watchful follow-up, sir.
Okay, good. Are you aware of any other genetic or molecular biomarkers which can predict lymph node metastasis in oral cancer?
E-cadherin expression, sir. Then we have the tumor budding, the tumor differentiation, grades of differentiation, pattern of invasion, worst pattern of invasion. All these things have also been studied.
No. I'm talking specifically molecular and genetic markers.
Molecular markers.
Yeah, you said one E-cadherin is one. Any
Yes,
other?
sir.
Which can predict lymph node metastasis. Okay. So what is the role of sentinel node biopsy? If you want to avoid neck dissection, unnecessary neck dissection,
yes,
we have a time-tested tool, that is sentinel node biopsy. How do you rate it in this situation?
So sentinel node biopsies have been tried in head and neck malignancies, but the data is very varied across all the studies. They say that the proximity of the primary is very close to your lymph nodal drainage. So there can be an interference with the identification of the sentinel lymph nodes, and also that floor of mouth, and there are a lot of other anatomical constraints which have been considered, and it has not been, the dye and the method of identifying SLNB has not been validated in randomized control trials yet. So it is a very controversial thing for malignancies.
Okay, last question. What are the drawbacks of wait and watch policy?
So one is when the patient comes back, very good compliance is required from patients. And in our Indian scenario with patients presenting to tertiary care centers, the compliance of patients on being on strict follow-up as per protocol is not very good. So hence all patients are being subjected for neck dissection. So if patient is very much compliant, we can still put the patients on watchful waiting. The other thing is, sir, in head and neck malignancy, it's regional and the local recurrences which are of concern and not the distant metastasis. So once the patient has a regional recurrence, the survival drops by 50%. If at all they come back with a nodal recurrence. So timely management is very important in head and neck malignancies.
So you mean to say an element of over-treatment is not harmful, especially in oral cancers?
If their morbidity is acceptable, it is
acceptable. Yes. Unlike axillary lymph node dissection with lymphedema, in head and neck it is not that kind of issue.
Yes, sir.
So, thank you.
Thank you, sir.
Yeah. Dr. Usha?
Good afternoon, sir.
Yeah, good afternoon. In your limitation, you have talked about DOI and PNI cannot be assessed preoperatively, correctly so. But PNI, yes, you cannot get it. But did you try to correlate the DOI with the CT scan imaging and try to get a correlation that if you can have one more variable before surgical option?
So, yes, sir. So the correlation was seen with the radiological MRI images with the depth of invasion postoperatively. But especially in T1 tumors, sir, the imaging was overestimated in the sense that what was seen as a 3 mm invasion postoperatively was identified as a 5 to 6 mm lesion on an MRI, which was an overestimation of the tumor. That was the T1 lesions were upstaged. So if based on this, if you're going to do a neck dissection, you're unnecessarily treating every patient is being subjected for neck dissections.
But still, that information would be useful because more importantly is the higher stage tumors. In fact,
yes, sir. Correct, sir.
And I think probably you are trying to see, based on whatever your findings are, that how far do you go in terms of, either preoperative assessment and in terms of surgical. So I think that would be important to get that information also.
Yes,
and also, you have talked about disease-specific survival and 5-year survival data. That is very good. How do you think that the study in question, how would that impact the 5-year survival?
So, sir, neutrophil to lymphocyte ratio is established as a prognostic marker in terms of bad prognosis. It means that the tumor is very aggressive. So if you're able to derive this data of disease-free survival and overall survival, it will have a better impact on how useful a tool NLR is for our clinical practice.
And do you use that as a guide for adjuvant treatment, and how far do you go?
No, sir, right now there are no established guidelines to use NLR as a tool for...
That is another area that can be looked at or studied?
It can be, sir. We need further prospective trials to look into how useful a tool it can be as an additional marker. Not an independent marker, but as an additional marker.
Thank you.
Thank you, sir.
Can I come in here? Yeah, Usha, I am not a head face neck person at all, and I am 0. Okay, so whatever you answer will be correct for me. Tell me the full form of ROC curve.
The receiver operating characteristic curves.
Yes. Define sensitivity and specificity and tell me what is more important as far as you are concerned.
The sensitivity is identifying the true positives, sir, and specificity is identifying the positive of all those who have been positive.
Correct. Now you have 30% specificity in the depth of invasion, and I can correlate it to your MRI findings against the operative or histopathology findings.
Yes, sir.
So when you compare your data, which one will you give more importance, sensitivity or specificity?
So the issue with sensitivity is it will identify more positive stuff. So the higher you increase the threshold, it will try to identify more number of patients. So it is important that you balance it out, and recommended is you should consider sensitivity and sensitivity more than presence.
Yeah. Now in GI tract, we have come down to, doing endoscopic ultrasounds to know what is the stage of esophageal malignancy disease and other applications.
Correct.
In case you get this Sushruta,
yes, sir,
will you do research and try and find out any investigation which will tell you the exact depth of invasion?
You mean
what
to
comes
say
to your mind?
Preoperatively, you mean, sir?
Yes, of course.
Sir, I think endoscope, like your ultrasound probe, it can be a useful tool again preoperatively to assess the depth of invasion, because tongue is a very accessible subsite in oral cavity. So I think it should be a good tool to identify the depth of invasion.
So in future, whether you get this prize or not, I want you to come out with some sort of invention or a probe which will tell you depth of invasion, because that is one of the things that I realize is of extreme importance. My last interview, can you logically prove to me why perineural invasion and how does it happen that perineural area leads to the lymph node?
Sir, so basically the tracking of tumor along the nerve sheath, sir. So when these nerves are in close proximity to the tumor, the nerve sheath act as a pathway for its drainage towards the lymph nodes, sir, along the track of the nerves that traverses the primary to your nodal drainage, because most of the nerves to these organs are through the neck, sir.
Is this anatomically proved?
Yes, sir. It has been anatomically proved.
Very nice. My last question to you is one quote said by somebody, since your last slide shows Albert Einstein.
Yes, sir.
Imagination is the highest form of research.
Yes, sir.
Imagination is more important than knowledge. Knowledge is limited. Imagination encircles the world. Who said this?
All of this are being said by Albert Einstein, sir.
Very good. Thank you very much. God bless you.
Thank you, sir.
Someone else can take over or we can finish.
We move on to the next candidate. Thank you, Dr. Usha.
Thank you, Dr. Usha. That was a very good discussion that we had with you. Now I will call again Dr. Naveen Kumar. Let's check if he's back in network. Dr. Naveen Kumar, can we have you now for the Q&A round?
Yes, sir. Good afternoon, everyone. Sorry for the network issues.
No worries.
Yes, I am now ready.
Very nice. Sorry, one simple question. How will your this questionnaire, how will it change your management, and how is it important in the community?
Yes. So the concept is conceived by my guide, Dr. S.V.S. Dev, who have noted each and every questions, and it is relevant to the etiology of breast cancer, genetic aspects, and willingness of the patient as well as family members for the genetic testing as well as prophylactic interventions. So the concept is not mine. It is my thesis topic, and it is given by my guide, Dr. Dev sir.
So how will you do? How will you expand on it further? If you think it's important,
yes.
How do you think you should spread to the community? What are your methods to do that?
Yes, sir. So I have explained in all these questionnaires to 5 to 10 breast cancer patients individually by myself who came to the breast cancer clinic, and first I try to know the basic level of awareness about the breast cancer in the questionnaire. So first the basic knowledge, and then I gave the educational intervention like in verbal as well as written form. So in verbal form, most of the patients understand in the written form. So first I speak to patients as well as attendants to all these questionnaires and try to increase their knowledge. And after 7 to 10 days, again I on the further visit ask the same question and record their responses in the written form. So and after that I compare with the first one.
Last point. I mean, your duration of a video, I think it was explained, if it's supposed to be 20 minutes.
After the next follow-up, yes.
The video presentation, it was supposed to be 20 minutes. Surprise presentation.
Yes.
It was still taken 23 minutes. Why is that? Something which you had time to cut, you had a lot of time to do and cut it down to 20 minutes. Why didn't you do that?
I think it's 19 minutes, 50 seconds, and though I have no idea. I said it's okay. So
maybe the one they gave it was different. Okay.
No, yes, 19 minutes, 15 seconds or 20 seconds like this.
All right. Okay.
I don't think.
Hi, Naveen. Good afternoon. Good to see you. Good study, actually. The best one. The best way to improve survival is to do prophylactic surgery, and that's the point in the right step. So you said, are there any reference studies to see about knowledge about breast cancer genetics in India which has come out?
Yes.
So there may be data from the Western world.
Yes.
And the other thing is you have used the same questionnaire for both literate as well as people who are not that literate.
Yes.
The other thing is you have assessed the effect of this questionnaire after a week after you've done it.
Yes.
Wouldn't it be better if you do it after 6 months and then you would have seen whether they've come for this or not? And also none of these people, in the familial thing, opted for any prophylactic surgery. So do you think the effect of information may not make any difference in survival if people haven't taken any options? A lot of questions, but it's really a good study. I really liked it.
Yes. Thank you, sir. Important issue is in our patient profile, most of the patients, as we in our study demographic profile, only 6% patients were below 10th standard. So they don't know actually the meaning of breast cancer. They come with something like gaant ho gayi, or they come to our study. So pertaining to the genetic aspects, it's very, very important first to know the awareness and level of level of awareness. So it's not a screening which decrease the incidence or to reflect the cancer burden in our society. It's awareness level, particularly in the low middle income country like India. So it's a study. One study I can quote Somdatta et al. In from India, but they don't talk about the genetic aspects. They don't. They published a paper regarding normal awareness about the breast cancer. What is the etiological factor? What are the treatment modalities? Like this, they don't talk about the genetic aspects. So probably I searched in the literature from Italy and European countries. There are some studies pertaining the genetic aspects, but from India I didn't get anyone.
Okay, so why not do this questionnaire after 6 months or 1 year?
Yes,
you
sir.
see, the
So,
impact is only on a 1 week. Don't you think it would be better if you did it at 1 year to see they have got anything, blood sample or genetics done or something? Or
yes, sir. You are absolutely right. It's the constant time constant because the thesis have to complete it within 1.5 years. So it's it's better to follow these patients after 6 months.
Okay, thank you.
Yes, sir. Thank you, sir.
Okay. Dr. Naveen?
Yes, sir. Thank you.
Yeah, continue the same question. Yes. If you are intervening with the breast cancer, after you are expecting that people will come back to you again. That
yes,
limitations. Regarding what limitations, like you are intervening with the breast cancer patients.
Yes, sir.
Regarding breast cancer patients.
Yes, sir. Yes, sir.
If you do the same study after 6 months, they will come to you. What is your perception during your study?
Yes, sir. So basically, the knowledge level will definitely change after 6 months follow-up.
because they know about the knowledge about the prophylactic interventions during the encountering to the breast experts.
Yeah, Naveen, two things. One is continuing with Dr. Saklani's question. Another is regarding the impact of your questionnaire for the treatment. Yeah, what you are telling, there's a, like you assess after 1 week.
Yes.
Yeah, because the patient one diagnosed to see a breast cancer or coming to us with breast cancer, you are counseling them.
Yes, sir. Yes.
Suppose you are giving and they are updating their knowledge, and within 1 or 2 weeks they have to decide for their treatment. If you make it after 6 months,
It
then
may be
they have
wise.
to wait for your treatment.
No, sir.
That's why I'm asking. This is the process of your study.
No, it's not possible to wait for so many months, sir.
Yes. Second thing, this is a very good study to know our own yes. So what is your output that it will change the treatment modality for these patients? But we
yes,
have
sir.
not, because we have ourselves, we are not convinced that Angelina Jolie effect you are telling one of your concluding presentation. Then
Yes, sir.
how will it impact the management, breast cancer management?
So, as we all know that we are not supposed to prevent the breast cancer. It's which can take the patient to the clinician in early stages. Like more than 50% patient coming to our clinic in stage 3 or stage 4. If they are aware with all these facts, they can come in early stage, so we can give more.
No, this is regarding the familial and hereditary breast cancer.
Yes, yes.
Yeah.
Yes. So familial breast cancers in our cohort, like 175 patients, 3 patients have they called their family members, and in these 3 patients, we found that BRCA mutations were present.
Okay.
These are the main advantages. So if we can continue these small things in our OPD clinic to at least to the health worker or MSW, so that they can at least acknowledge these points, that breast cancer may be genetic, may be hereditary, so we can prevent or we can do intervention before coming to the later stages or before knowing in the bilateral side.
Okay, that way changing your management.
Yes,
that's
sir.
Like payments.
Yes.
Okay.
From your comment, can I come in? Yeah.
Yes, sir. Yes.
Yeah. From your comment, it appears that the larger aim is that as people are made more aware about the breast diseases and early detection can be there, and they kind of take an informed decision and to improve the overall results. Am I correct in thinking that that's?
Yes, sir.
So in that light, because there are a couple of things. One, that your study is not really a population-based study or not trying to, the masses. Here, what you are trying to look at is, as they say, a pre-test and a post-test.
Yes, sir.
That you have made people aware, those patients who have come, I think it was only patients or the family also?
Patients, sir. Patients, sir.
Patients, right. So I think probably you could have also included the family members or something. And basically what you're trying to get at is that if they are made aware, then can they make a better informed decision as of now, this captive patient that you're talking about? Because that is not leading to that aim of early detection and all those things, right? Am I right in that? So
Yes,
in that light, I'm just thinking that when I look at your chart at, your slide number 13, I mean, it intrigues me because if you are doing this study after a week, and I think if more trainees fail, then it is a trainer's, fault. So in this, if you are the one, as you said, that you did the explaining to the patient relative, I am unable to understand that even after you have explained, it has only dropped from 87% to 77% as regards their information about breast cancer. And similarly, because I would expect that they would be more aware, they may or may not decide for genetic testing as another thing. But as far as awareness is concerned, and then again, what are the sources of information? Now, because you have a major element which has gone in terms of your doing the explaining,
So that is missing in that, because the source of information still remains the same in all those, and that has also not changed much. So I think probably, I mean, that is what, would you like to answer this before I move on to another point?
Yes, sir. So explanation to our patients is first done by me as well as consultant if they need to do them. So it's not in a single session. Yeah, if some patients want to meet consultant, or if they have some more queries, they can we directly contacted to our chief guide or other consultants. So it's not only training. I am solving their problems or their questions.
No,
if they have some more questions,
blame on you or the consultant.
I'm not.
I'm just trying to drive at is that despite your explaining in detail, it only dropped the low information from 87 to 77%. And the awareness, if you considered moderate and high as awareness, that increased from 13% to only 23%. So that is what I was, trying to look at, because this is the captive audience, the patients, and I think it's not the families. In them, if this is the awareness, then the population based, probably we need to do something more than this. Because, and recall at 1 week, if it is not as good, then as some of the people were talking about 6 months, because basically you are wanting to dissipate. Your idea is that learning from this study, can you make the general masses more aware about self-examination and other things, that queries that they are talking about, and to also look at familial incidents, right? And the second thing, one more thing, just last question, is that you have divided it into, for this purpose also, familial and this
sporadic group.
Sporadic. So in that, does it make a difference in terms of awareness and the points that you are studying? Because just the
so a sporadic group.
Yeah, go on.
Oh, the awareness level in a sporadic group low as baseline as compared to the familiar, because most of the patients come from different from the referral system. Like some they shown to first PSC or CSC or other district hospital, or then come to AIMS referral center. So they don't they are more about explaining about all these things. If one or more than two family members are affected, then they know about the basic idea. But yes, in BRCA gene mutation, they don't. In both groups, awareness level is very low. So this is the main factor. In a sporadic group of patients, like 150 patients, the awareness level for genetic mutation is quite low as compared to the familial. And after intervention, it increases in both groups. So a small 5 to 10 minutes education intervention, it increases the awareness level. This is the conclusion point. And also I want to tell about the limitations. Yes, it is not a population-based study. It is a hospital-based study. Also, this is it is a very small number of patients. And third thing, this is single institutional study in which there is a biasing factor for selection bias, because we are selecting these patients after coming to our breast cancer clinic. So these 3-4 things are the limitation. Thank you, sir.
Hello, Naveen, can you hear me?
Yes, sir.
Since your presentation is on breast cancer and the discussion has gone on to awareness, can you name some breast cancer awareness foundations who have taken lead in India?
No idea, sir. Can assist?
I don't know. I'm just asking you, since you are presenting something which is leading to breast awareness, I think you should have knowledge of various societies who are coming out to fight breast cancer.
Yes, sir. I have searched for the review article. But societies-wise, I don't know exactly the names and.
Because you can, you're doing a good job, so you can involve these societies so that
Yes.
females to female, because most of these are run by females. So females are always close to females. They will, help you to see that the follow-up, etc., is quite good as well, and awareness is also quite good. I'm sure you know this answer. Name an American actress who underwent a prophylactic mastectomy.
Angelina Jolie. Sir.
Very good. Now you know Western literature, but you don't know what is happening in India. That is unfortunate.
Sorry.
Okay, doesn't matter. Good paper.
Yes.
Good paper. Do well. Okay. Yeah.
Thank you, sir. Thank you.
So I think with that, we can conclude our Q&A round with all the 10 finalists of India's Next Sushruta. That was an amazing brainstorming session, I must say. Now we will have a break of around an hour, and we will resume our most awaited section of the event, that is the award ceremony. So see you all again at 4 p.m. sharp.
India's Next Sushruta.
Physicians and surgeons in India are among the best in the world, but we do need larger numbers of qualified physicians and surgeons in India for achieving healthcare outcomes and to take healthcare further together. India's Next Sushruta is an initiative by Medtronic to nurture and develop young surgeons.
As Medtronic, the largest medical device company in the world, I guess there is a serious commitment that we have towards improving quality of education.
India's Next Sushruta is a unique program wherein best of medical minds have been competing over the last 1 year.
Congratulations to all of you, the top 10 winners of India's Next Sushruta. What an amazing journey this has been.
This is fantastic.
Most eminent and celebrated jury.
India is having immense disease burden, and India looks forward to have you in its force to relieve this burden. Thank you for all the hard work you have done till now, and congratulations for making it till this stage. Thank you and all the best.
All the best.
Learn from all the experts and actually be juried by the top surgeons of India.
I am sure it would have been a tough, intense competition between best of the minds. Top 3 winners will have the chance to win 2-week international clinical immersion.
Congratulations to all the finalists. You're on the lookout
for India's Next Sushruta.
Are you the one? All the very best to the finalists.
India's Next Sushruta.
Physicians and surgeons in India are among the best in the world, but we do need larger numbers of qualified physicians and surgeons in India for achieving healthier outcomes and to take healthcare further together. India's Next Sushruta is an initiative by Medtronic to nurture and develop young surgeons.
As Medtronic, the largest medical device company in the world, I guess there is a serious commitment that we have towards improving quality of education.
India's Next Sushruta is a unique program wherein best of medical minds have been competing over last 1 year.
Congratulations to all of you, the top 10 winners of India's Next Sushruta. What an amazing journey this has been.
This is fantastic.
Most eminent and celebrated jury.
India is having immense disease burden, and India looks forward to have you in its force to relieve this burden. Thank you for all the hard work you have done till now, and congratulations for making it till this stage. Thank you and all the best.
All the best. Learn from all the experts and actually be juried by the top surgeons of India.
I am sure it would have been a tough, intense competition between best of the minds.
Top 3 winners will have the chance to win 2-week international clinical immersion.
Congratulations to all the finalists. You're on the lookout
for India's Next Sushruta.
Are you the one? All the very best to the finalists.
India's Next Sushruta.
Physicians and surgeons in India are among the best in the world, but we do need larger numbers of qualified physicians and surgeons in India for achieving healthier outcomes and to take healthcare further together. India's Next Sushruta is an initiative by Medtronic to nurture and develop young surgeons.
As Medtronic, the largest medical device company in the world, I guess there is a serious commitment that we have towards improving quality of education.
India's Next Sushruta is a unique program wherein best of medical minds have been competing over last 1 year.
Congratulations to all of you, the top 10 winners of India's Next Sushruta. What an amazing journey this has been.
This is fantastic.
Most eminent and celebrated jury.
India is having immense disease burden, and India looks forward to have you in its force to relieve this burden. Thank you for all the hard work you have done till now, and congratulations for making it till this stage. Thank you and all the best.
All the best.
Learn from all the experts and actually be juried by the top surgeons of India.
I am sure it would have been a tough, intense competition between best of the minds.
Top 3 winners will have the chance to win 2-week international clinical immersion.
Congratulations to all the finalists. You're on the lookout
For India's Next Sushruta.
Are you the one? All the very best to the finalists.
India's Next Sushruta.
Physicians and surgeons in India are among the best in the world, but we do need larger numbers of qualified physicians and surgeons in India for achieving healthier outcomes and to take healthcare further together. India's Next Sushruta is an initiative by Medtronic to nurture and develop young surgeons.
As Medtronic, the largest medical device company in the world, I guess there is a serious commitment that we have towards improving quality of education.
India's Next Sushruta is a unique program wherein best of medical minds have been competing over last 1 year.
Congratulations to all of you, the top 10 winners of India's Next Sushruta. What an amazing journey this has been.
This is fantastic.
Most eminent and celebrated jury.
India is having immense disease burden, and India looks forward to have you in its force to relieve this burden. Thank you for all the hard work you have done till now, and congratulations for making it till this stage. Thank you and all the best.
All the best.
Learn from all the experts and actually be juried by the top surgeons of India.
I am sure it would have been a tough, intense competition between best of the minds.
Top 3 winners will have the chance to win 2-week international clinical immersion.
Congratulations to all the finalists. You're on the lookout
For India's Next Sushruta. Are you the one?
All the very best to the finalists.
India's Next Sushruta.
Physicians and surgeons in India are among the best in the world, but we do need larger numbers of qualified physicians and surgeons in India for achieving healthier outcomes and to take healthcare further together. India's Next Sushruta is an initiative by Medtronic to nurture and develop young surgeons.
As Medtronic, the largest medical device company in the world, I guess there is a serious commitment that we have towards improving quality of education.
India's Next Sushruta is a unique program wherein best of medical minds have been competing over last 1 year.
Congratulations to all of you, the top 10 winners of India's Next Sushruta. What an amazing journey this has been.
This is fantastic.
Most eminent and celebrated jury.
India is having immense disease burden, and India looks forward to have you in its force to relieve this burden. Thank you for all the hard work you have done till now, and congratulations for making it till this stage. Thank you and all the best.
All the best.
Learn from all the experts and actually be juried by the top surgeons of India.
I am sure it would have been a tough, intense competition between best of the minds.
Top 3 winners will have the chance to win 2-week international clinical immersion.
Congratulations to all the finalists. You're on the lookout
For India's Next Sushruta.
Are you the one? All the very best to the finalists.
India's next Sushruta.
Physicians and surgeons in India are among the best in the world, but we do need larger numbers of qualified physicians and surgeons in India for achieving healthier outcomes and to take healthcare further together. India's Next Sushruta is an initiative by Medtronic to nurture and develop young surgeons.
As Medtronic, the largest medical device company in the world, I guess there is a serious commitment that we have towards improving quality of education.
India's Next Sushruta is a unique program wherein best of medical minds have been competing over last 1 year.
Congratulations to all of you, the top 10 winners of India's Next Sushruta. What an amazing journey this has been.
This is fantastic.
Most eminent and celebrated jury.
India is having immense disease burden, and India looks forward to have you in its force to relieve this burden. Thank you for all the hard work you have done till now, and congratulations for making it till this stage. Thank you and all the best.
All the best.
Learn from all the experts and actually be juried by the top surgeons of India.
I am sure it would have been a tough, intense competition between best of the minds.
Top 3 winners will have the chance to win 2-week international clinical immersion.
Congratulations to all the finalists. You're on the lookout
For India's Next Sushruta.
Are you the one? All the very best to the finalists.
India's Next Sushruta.
Physicians and surgeons in India are among the best in the world, but we do need larger numbers of qualified physicians and surgeons in India for achieving healthcare outcomes and to take healthcare further together. India's Next Sushruta is an initiative by Medtronic to nurture and develop young surgeons.
As Medtronic, the largest medical device company in the world, I guess there is a serious commitment that we have towards improving quality of education.
India's Next Sushruta is a unique program wherein best of medical minds have been competing over last 1 year.
Congratulations to all of you, the top 10 winners of India's Next Sushruta. What an amazing journey this has been.
This is fantastic.
Most eminent and celebrated jury.
India is having immense disease burden, and India looks forward to have you in its force to relieve this burden. Thank you for all the hard work you have done till now, and congratulations for making it till this stage. Thank you and all the best.
All the best.
Learn from all the experts and actually be juried by the top surgeons of India.
I am sure it would have been a tough, intense competition between best of the minds.
Top 3 winners will have the chance to win 2-week international clinical immersion.
Congratulations to all the finalists. You're on the lookout
For India's Next Sushruta.
Are you the one? All the very best to the finalists.
India's next Sushruta.
Physicians and surgeons in India are among the best in the world, but we do need larger numbers of qualified physicians and surgeons in India for achieving healthier outcomes and to take healthcare further together. India's Next Sushruta is an initiative by Medtronic to nurture and develop young surgeons.
As Medtronic, the largest medical device company in the world, I guess there is a serious commitment that we have towards improving quality of education.
India's Next Sushruta is a unique program wherein best of medical minds have been competing over last 1 year.
Congratulations to all of you, the top 10 winners of India's Next Sushruta. What an amazing journey this has been.
This is fantastic.
Most eminent and celebrated jury.
India is having immense disease burden, and India looks forward to have you in its force to relieve this burden. Thank you for all the hard work you have done till now, and congratulations for making it till this stage. Thank you and all the best.
All the best.
Learn from all the experts and actually be juried by the top surgeons of India.
I am sure it would have been a tough, intense competition between best of the minds.
Top 3 winners will have the chance to win 2-week international clinical immersion.
Congratulations to all the finalists. You're on the lookout
For India's Next Sushruta.
Are you the one? All the very best to the finalists.
India's Next Sushruta.
Physicians and surgeons in India are among the best in the world, but we do need larger numbers of qualified physicians and surgeons in India for achieving healthier outcomes and to take healthcare further together. India's Next Sushruta is an initiative by Medtronic to nurture and develop young surgeons.
As Medtronic, the largest medical device company in the world, I guess there is a serious commitment that we have towards improving quality of education.
India's Next Sushruta is a unique program wherein best of medical minds have been competing over last 1 year.
Congratulations to all of you, the top 10 winners of India's Next Sushruta. What an amazing journey this has been.
This is fantastic.
Most eminent and celebrated jury.
India is having immense disease burden, and India looks forward to have you in its force to relieve this burden. Thank you for all the hard work you have done till now, and congratulations for making it till this stage. Thank you and all the best.
All the best.
Learn from all the experts and actually be juried by the top surgeons of India.
I am sure it would have been a tough, intense competition between best of the minds.
Top 3 winners will have the chance to win 2-week international clinical immersion.
Congratulations to all the finalists. You're on the lookout
For India's Next Sushruta.
Are you the one? All the very best to the finalists.
India's next Sushruta.
Physicians and surgeons in India are among the best in the world, but we do need larger numbers of qualified physicians and surgeons in India for achieving healthier outcomes and to take healthcare further together. India's Next Sushruta is an initiative by Medtronic to nurture and develop young surgeons.
As Medtronic, the largest medical device company in the world, I guess there is a serious commitment that we have towards improving quality of education.
India's Next Sushruta is a unique program wherein best of medical minds have been competing over last 1 year.
Congratulations to all of you, the top 10 winners of India's Next Sushruta. What an amazing journey this has been.
This is fantastic.
Most eminent and celebrated jury.
India is having immense disease burden, and India looks forward to have you in its force to relieve this burden. Thank you for all the hard work you have done till now, and congratulations for making it till this stage. Thank you and all the best.
All the best.
Learn from all the experts and actually be juried by the top surgeons of India.
I am sure it would have been a tough, intense competition between best of the minds.
Top 3 winners will have the chance to win 2-week international clinical immersion.
Congratulations to all the finalists. You're on the lookout
For India's Next Sushruta.
Are you the one? All the very best to the finalists.
India's Next Sushruta.
Physicians and surgeons in India are among the best in the world, but we do need larger numbers of qualified physicians and surgeons in India for achieving healthier outcomes and to take healthcare further together. India's Next Sushruta is an initiative by Medtronic to nurture and develop young surgeons.
As Medtronic, the largest medical device company in the world, I guess there is a serious commitment that we have towards improving quality of education.
India's Next Sushruta is a unique program wherein best of medical minds have been competing over last 1 year.
Congratulations to all of you, the top 10 winners of India's Next Sushruta. What an amazing journey this has been.
This is fantastic.
Most eminent and celebrated jury.
India is having immense disease burden, and India looks forward to have you in its force to relieve this burden. Thank you for all the hard work you have done till now, and congratulations for making it till this stage. Thank you and all the best.
All the best.
Learn from all the experts and actually be juried by the top surgeons of India.
I am sure it would have been a tough, intense competition between best of the minds.
Top 3 winners will have the chance to win 2-week international clinical immersion.
Congratulations to all the finalists. You're on the lookout
For India's Next Sushruta.
Are you the one? All the very best to the finalists.
Our event, we would like to have you on the stage.
Virtual, you mean?
Yes, sir. Virtual.
Well, maybe eating food.
Welcome back. Today we witnessed some of the best case presentations in the domain of surgery. I would like to call upon our esteemed jury members to share with us their feedback on this event, India's Next Sushruta. So I would like to welcome Professor Dr. Abhay Talvi sir, Professor Dr. Anil Agrawal sir, Professor Dr. S.V.S. Dio sir, Professor Dr. Abanish Saklani sir, Professor Dr. Madhav Nandakar sir, and Professor Dr. S. Sudhindran sir to be on the stage to kindly share with us their valuable feedback. If we can start with maybe Professor Dr. Abhay Talvi, sir, or yes, sir, please, if you can go ahead. Can I request Dr. Madhav Nandakar, sir, to start with his feedback, with his kind feedback, sir, if you can. I think are you on mute, sir? If I'm having some issue in hello. Okay, so maybe we can go to Professor Dr. Anil Agrawal, sir. Sir, if you're there, if you can kindly share your feedback, sir. Am I audible enough, sir? Okay. Let's move on to Professor Dr. S.V.S. Dio, sir. So, can I have your valuable feedback, please? Kindly share your feedback on the entire event and on how our presenters and finalists did today. Okay. I will return again to Professor Dr. Abhay Talvi, sir, if you are there. So if you can.
Okay, I'll take the lead. Not an issue.
Yes, please.
But you have to give me lunch.
I will, sir.
I'm halfway through. Okay. You are Medtronic, whoever it is. Let me tell you, I go back to, I think, 2018 or 19 when Medtronics came to me with this idea. And I had discussions with their representative who had some suggestions, etc., etc. And unfortunately, after that, while they were still going on, I lost contact. But it has been a wonderful journey. And as a jury of the finalists, it has been a wonderful thing. Luckily for me, my apprehensions were all solved when all papers have been really good, ranging from people who are doing MS general surgery, then doing subspecialty postgraduation, super PG, and then who are already done their subspecialty are in private practice. So when all the juries were together trying to find out, I think we have given all weightage to the junior most person, to the senior most person who were the finalists, 10 finalists, and taken a very cognitive view of also the seniority as well as the type of papers that have been presented, which should be commensurate with their level, and the prizes have been announced. I believe the jury has been absolutely unanimous in the decision. It did not take us more than 10 minutes to come to a conclusion, and we have declared the results, which will be declared soon. I think, Priyanka, are the candidates also in the audience?
Yes, sir. They are very much there.
So all the candidates, let me tell you, whenever you appear for any competition, there are some things which you have to guard. What are the do's and don'ts? The do's were limit yourself in 20 minutes and that is what was done almost by everybody with good editing from Abhishek, etc., etc. And then the presentations were very nice. All the glitches were solved by the Abhishek's people, and obviously then the things came to us. We have gone through meticulously each and every presentation well before this competition, and at the same time I have to congratulate each and every of the jury members who have sat through 9:30 till now. And obviously the candidates must have had their lunch, but I'm sure jury are not responding because they are having their lunch. So whatever it is, so be it. All the best to all the candidates, the prize winners, and the Medtronic team who have done a wonderful job. There need to be some sort of improvements in future which have been communicated to them. And next year, I foresee a very good and intense competition in this regard. My blessings to everybody who are there. And now I was introduced as Professor of Surgery, GS Medical College. Now my other avatar is that I'm the President of the Association of Surgeons of India. So this year, please involve yourself in all academic activities, visit the website, and there is another competition which is coming up known as Regional Refresher Course, where there are equivalent prizes that are going to go through. I know it is an advertisement, but I'm taking liberty to do it on behalf of the Association of Surgeons of India. Because when the prizes are announced, you will realize that everybody gets his due. Thank you so much, Priyanka, and thank you, Medtronics, and thank you, everybody, for choosing me as a jury.
Thank you so much for your kind words, sir. Thank you so much, and apologies that I had to sort of, call you in the middle of your lunch. Really sorry for that. Moving on, can we have Dr. Madhav Nandakar, sir, to share his kind feedback on the entire flow of event and how our finalists did? I think it's facing some technical glitch. Can we have maybe Dr. Anil, Professor Dr. Anil Agrawal, sir?
Yeah, I think now it's evening or afternoon.
Good evening, sir.
It will be an honor and a pleasure to be a jury for this very nice event that you have organized. And I think at least congratulations to, actually, I would say all those who reached this stage of finals, irrespective of who are the number 1, 2, 3. But I think all have been winners, and it has been very heartening to see that the presentations which were there, and I think also the confidence with which the candidates faced the questions, and sometimes many of us, jury, have put them in a tight spot, but I think they were able to defend that well. So because I think that is part of your learning process, because life throws all the challenges as you go along, managing the patients in future, because all of you are graduate or postgraduate students. And I think just one or two things that I would say to the younger colleagues who are in this process is that as an exam, we always, you must have heard all your teachers say that the examiner is not so much bothered about whether you are correct, right or wrong, because it's not an exact science. So I think what finally the diagnosis turns out to be, rather than that, people are looking at approach, because with approach you will diagnose most cases well. So I think similar to this, in this also we know that a lot of the paper that you have been involved with, or a lot of the presentations that you have been involved with, have been the brainchild of your supervisors or your teachers. But what we are trying to look at is that how much has been your involvement, and I think at different stages, and how have you learned the scientific approach to a thing in terms of study design, in terms of powering the study, and also in terms of how much depth of knowledge you have in that concerned subject, so that you can not just restricting to that one thing that you are studying, that all around it, and that how you analyze the study. Because I think the framework might have been dictated by your seniors, but I think how do you analyze when the available data, available literature on the subject, and and you have to be an honest approach that you don't brush anything under the carpet. Whatever is the strength, whatever is the deficiency in the study, you need to know. And also the last thing that I would say in that regard is, for learning points, is that presentation. I mean, you might have seen all kind of presentation, but in medicine, in our field, it is not to be very flashy, not too many caricatures and all those things. I think you have to have a relevant kind of thing, but you still may score enough if your strength of study is there. So people will not take that against you, but I think that is a piece of advice. And so I think I must thank all my co-jury, because it was such a pleasure, and I was really very happy that in that breakout session also that we had, that we were all on the same page. And I think all the assessments were almost uniform. And so I think and also though it was a Sunday that we all were involved with, but it was it was a pleasure to be part of it. And thank you all the co-jury, and thank you Medtronic and the organizer Docplexus to have organized this event, and it was a pleasure to be part of it. And all the best for the younger this thing. And you must realize that even though it may be the next Sushruta, but that is a little far away. I think we are there. They are just by this competition putting you on the track that maybe a few years down the line, you are a force to reckon with, and probably a name that will be looked up to by the surgical community. And that is what this competition is actually providing you, is that they will give you an opportunity to get yourself trained in institution, get the exposure and wherever you want, so that nothing comes in the way of your learning things to become on the path of being a great surgeon. So all the very best to all the candidates. Thank you. Thank you, Priyanka.
Thank you, Dr. Anil Agluwar, for that valuable feedback and your motivating words. It is indeed a pleasure for all of us to listen to you and take on your path. I will now invite Professor Dr. Madhav Nandakar, sir, to kindly share.
Now I'm audible? Now I'm audible?
Yes, sir, you're very much audible. Please go ahead.
Thank you, Priyanka. That's initially some technical slang. But thank you, Medtronic, and thank you, Docplexus, to organize this type of events and give a platform to the young surgeons to commensurate their knowledge up to their expectations and assessing their self among all. And all the jury members, I am thankful. They are all senior people and very experienced. And most important, to make it happen is very, very challenging. And I congratulate them, and together on a Sunday, all these senior people to assess. And the next important things, I will congratulate all the finalists, 10 finalists coming out of 1,000 competitors like that. And I have watched all the people, like 10 people, they're so positive, and I have gone through before also their presentations. This is a very good thing. And most important, they are involved in the research. This is what the presentation is all about, and the kind they are presenting, involving themselves in analyzing, that gives a big boost to them. And most important, this is the encouraging platform to look for the future. And before all the giants they are presenting, and they are exposed to the whole world, they presenting, that is the important thing. And that way, Medtronic and Docplexus, that's praiseworthy. And one thing I tell that all the finalists, this all have done well, but it's a competition. We have to choose first, second, third. That doesn't mean that deteriorate to the others. And most important, what Dr. Dalvi and Dr. Anil they told that everyone is the same, or all the juries, they are having the same thing, and let the 10 minutes we have decided. That is so unanimous and doing things. But that is giving a responsibility to all the finalists, like 10 people. This is, don't think that someone is tougher than someone is not getting into, definitely. And this is a responsibility. And you are in the track. And for future, you have to prepare yourself. That one, Dr. Usha, like as Einstein's motto there pointed out, imagination. But all big surgeries, they need the imagination. Then accordingly, you have to prepare yourself for future. That's all the best to all. And thank you, Medtronic. Thank you, Docplexus, to involve me here and making such a platform for the youngsters. And I also hope that it will continue like every year. And this will definitely encourage more institutes to involve their own people, students, and in this platform. Thank you all, and all the best for all the 10 finalists for their future. And congratulations, someone is joining us.
Thank you so much, sir, for your guidance and your motivation to everybody present here. So thanks for all the inputs and the feedback, our esteemed jury panelists. Now, I would request Mr. Madan Krishnan, Vice President and Managing Director, Medtronic India, to share his views about today's event.
Thank you.
Maybe there.
Is there any comment? Any other from the jury? There was one more.
Dr. Dev is there.
Yeah, Dr. Dev.
Oh, we have Dr.
Hi, Mother. At the outset, I would like to thank Medtronic for this great initiative during these difficult times. I'm sure this kind of initiatives will give all the young surgeons in India a good platform to showcase their talent at the national level. So the overall experience has been good. We have given some suggestions. I think my previous co-jury members have already, conveyed it. We need to refine the format because we have to, segment the sections, in the next session, because we are judging from junior resident to post-MCH senior residents also. I think it can be refined, but overall it's a very great initiative, and I would like to congratulate Medtronic and all the team and the Docplexus team for bringing together this great event. Thank you.
Thank you, Dr. S.V.S. Deo, sir. Sorry, I missed your name earlier. Thank you for sharing that valuable feedback. Now I would like to call upon again Mr. Madan Krishnan, Sir, Vice President and Managing Director, Medtronic India, to share his views about today's event. So, if you can please proceed.
Thank you. Thank you, Priyanka. Thank you to all the participants. I really want to congratulate Dr. Naveen Kumar, Dr. Sauvik Paul, Dr. Usha H., Dr. Satya Niharika, Dr. Said Mustafa Hashmi, Dr. Shankar Subramanian, Dr. Rishin Datta, Dr. Nitesh Kumar, Dr. Yash Singha, and Dr. Prateek Kumar Jha. I think you displayed your best. You displayed, made it into a very competitive grand finale. The doyens of a surgery world in India and in, I would say, in the world. We have some of the topmost names here. We've been mentoring and giving you also some feedback. So I'm really happy that you participated, and also a great word of thanks and respect to our learned jury members, to Professor Dr. Abhay Dalvi, Professor Dr. Anil Agarwal, Professor Dr. S.V.S. Dev, Professor Dr. Avinash Aklani, Professor Dr. Madhavananda Kar, Professor Dr. S. Sudhindran. And I think as Dr. Dalvi said, the approach is an essence in terms of how you approach it, how structured are in your approach. And as also the elect of the president of the Surgeons Association of Surgeons exhorted you, continue to play an engagement role with the Institute of Surgeons and other forums, because you are the leaders, correct? And these doyens of the industry are there as the gurus to really guide you. Also, I was also quite inspired to see how the comments from Professor Agarwal and Professor Professor Kar to talk about how in the approach and the exposure, continue to gain exposure as much as exposure possible, because we are all learning, and as budding surgeons, you are also going to learn and continue to learn from people like those in the jury and otherwise. And to Dr. Dr. S.V.S. Dev, I also remember fondly our meeting in Hyderabad a couple of years ago. We will also work on segmentation and the right approach, taking your feedback into mind, because this Medtronic's commitment to innovation and Medtronic's commitment to improving skill set is the essence of our existence. And we'll do everything possible to reach more surgeons and surgeon candidates all over around India, to ensure that this event is also becoming a nurturing platform for exchange of latest knowledge, research, clinical trials, and experience sharing among surgeon community in India. And they would actively work with the community to ensure that Indian surgeon physicians are among the best in the world, I said, but we continue to nurture the newer generation who also will make us proud. And we need all your support and all your committed efforts to make India healthier. That's the only way that India can become healthier, and we need your leadership and all your passion and the attitude to do better for the people of India. So thank you once again for all the participation, great participation by the participants, and also the 1,300 odd participants who joined the contest. And once again, my respects and thanks to the jury. Jai Hind, all the best.
Thank you so much, sir, for your kind words. So we are coming to the last leg of the competition. The much awaited results are here. It has been an incredible journey so far. I'm equally excited to know who has made it to the top 3. With much bated breath and without further ado, let me take this opportunity to announce the winners. Cross your fingers, everybody. Our second runner-up is Dr. Nitesh Kumar from Osmania Medical College, Hyderabad. Our first runner-up is Dr. Shavik Paul from BLK Multi-Speciality Hospital, New Delhi. Wow, congratulations.
Thank you.
And the title, India's Next Sushruta, goes to Dr. Usha from Kidwai Memorial Institute of Oncology, Bengaluru. Wow, great. Congratulations, Dr. Usha. You are our India's next Sushruta.
Thank you so much. Thank you.
So congratulations, Dr. Nitesh Kumar, for securing that third position today. I would I would like you to please switch on your camera and share your thoughts on being placed third today. Dr. Nitesh Kumar. I think Dr. Nitesh Kumar is facing some challenge in his network. So I will move on to our first runner-up of the day, Dr. Shouvik Paul. Can I have Dr. Shouvik Paul sharing his thoughts on winning the first runner-up position?
Yeah, thank you very much, the respected jury members. And also, I would like to thank to the organizing team, Medtronic and Docplexus. And also, I would like to thank my guide, Professor Dr. B.P. Bhalla, and other Dr. Deep Goel, Dr. Ravinder Bhatt of our hospital. Last but not the least, also the patients who have participated in the study. I would like to thank all them and all the staffs involved in this study. And also, I would like to thank my mentors all out to my life in the surgical field, from whom I have taught the numerous things, and also to my mother and my father. Thank you very much, and I am very much happy with this.
I'm sure you'd be on top of the world, Dr. Shouvik Paul.
Yeah,
congratulations again. So here we have India's next Sushruta, Dr. Usha. Hearty congratulations to you, Dr. Usha. Please share a few words on this immense victory.
Thank you so much to respected jury members who considered my research paper worthwhile for this title. It's my heartful esteemed gratitude towards them. I thank all the members on the team who have helped me make this research paper. Special thanks to the head of the of my institute, Dr. Professor Ravi Arjunan, and also the director of the institute, Dr. Ramachandra. And thank you all my fellow colleagues who've helped me come here, and thank you to the team Medtronic. I'm really honored. Thank you so much.
Congratulations again, Dr. Usha. I can hear all the excitement in your voice. Great going, I must say. So once again, I congratulate Dr. Usha, Dr. Shouvik Paul, and Dr. Nitesh Kumar for this wonderful achievement. We have come to the end of today's event. Now I request Prashant Krishnan, Senior Director, Surgical, PMA and ENT Therapy Business, Medtronic India, to propose a vote of thanks.
Priyanka, can I say a word?
Yes, Dr. Deo, please go ahead.
Sure.
Yeah, Prashant. I think we must congratulate all the remaining participants also. They have really done very well. The fight was very tight. There was almost a tie for 3, 4, 5 positions. So we all would like to compliment all the other participants also who have actually could make it to the final. And we wish you all for your future. And I think you will also get a complimentary sort of a traveling fellowship as promised by Medtronic. A big hand for all the participants, please. Thank you.
Thank you, Dr. Deo. I would request jury members if any of you would like to share something or to the winner.
I just congratulate all the winners and simultaneously congratulate all the finalists to be here. And we decided, and Dr. Dev, what they decided, that was all finalists were almost the same. Few are like, this is the top. But all have tried, and to reach that things is not easy. And to persistently keep the positive mindset and to be here, that's why I congratulate all. And all the best to all. Yes, sir.
Thank you, Dr. Kar. We have Dr. Abhay and Dr. Anil also with us. If you can please share your comments on or your message to the winners, please, sir.
Anil, you want to go first or I go first?
You go ahead.
Okay. To all the finalists and the competitors who may be on the YouTube watching this prize distribution ceremony, whenever you get into a competition, stay focused, and all of you all did it very well. Some of us asked you point blank questions, some of us put some leg spin, off spin, etc., etc. You all batted them quite well, and the best of the person who talked to the point, least of the points. Remember, there was a time slot of 10 minutes and you had to answer maximum number of questions. And that is possibly the third, fourth and fifth positions went away from the fourth and the fifth position holders. So congratulations to all of you all. As Dr. Dev has announced, and I also plead with Medtronic that coming to a finals is something which is really achievement in itself, and these 4th to 10th also should be rewarded in an appropriate manner. And I thank you, Dr. Medtronic's people, for agreeing to this. So all of you all are winners. Congratulations and all the best in your future career. Someday, I hope at least 50% of you all will sit in our positions as jury with Medtronics continuing the same thing, and you will apply the same thing to the future Sushrutas. Thank you so much.
Thank you, sir. Thank you so much.
Yeah.
Anil Agrawal, sir. Yes, if you could please.
Just a brief message to all the young postgraduate and postdoc students. I think this is the beginning of the journey. In fact, as you complete your PG or the postdoctoral, because often what happens is in this competitive world, once you crack through the exam and then when you pass out, you think that you have achieved something, but you have to realize that, yes, that was part of your, preparation for the actual journey, which begins when you complete your course. And I think in that, the attitude is very, very important. And I think Usha is the next Sushruta. You have to realize that you are put on that path. And I think you have to put a lot of efforts to reach where you want to reach, because this is just the beginning of the journey. And I think it is very, very important, and the learning goes on in the surgery. In fact, because all are surgeons, I took up surgery. I thought I won't have to read, but now you realize that, at surgery also, it's not just cutting. And I think you have to keep abreast with the latest. So it's a beginning of the journey, and all the best. And I think it was very heartening to see all the 10 contestants and that they are on the track. And we hope, as Dr. Dalvi said, that probably all these people would be occupying good positions in terms of giving back to the society in terms of the surgical care. And I think hopefully they will also be the jury in times to come. So thank you and all the best.
Thank you so much, Dr. Anil Agrawal, sir. So now I will request Mr. Prashant to give the vote of thanks. Or we have Mr. Madan Krishnan also on the stream. So would you like to say a few words?
No. From my side, I think if any of the other jury members want to add anything, please, because their voices of wisdom is what we need as an encouragement to the team. I can only say that Medtronic will continue our efforts working with esteemed minds in the surgical world in India to nurture further young minds, and everyone is a winner. Every one of the 10 finalists will also be fully supported by Medtronic, and I, as Dr. Dalvi also suggested, that even others also will continue to nurture. So, but if Dr. Madhavanandakar or Dr. Dev or anyone wants to say any few words, because their words matter to us.
Yes, definitely. So I think, yes, we have.
Dr. Anil has already conveyed it. I think this is a big legacy you need to carry forward. It's just the beginning, it's a big responsibility. Now there's a lot of burden on your heads. There will be a lot of expectations, anticipations. You need to fulfill that. So what we need to see, maybe I would suggest Medtronic, we should have a sort of event after 10 years. Would like to see where these 10 participants are after 10 years.
Lovely.
Yeah, I think that would be a real sort of achievement. Whether this is inspiring youngsters or not.
Absolutely, Dr. Dev. I guess with this, a beautiful day comes to an end. I've spent nearly 2 decades in healthcare, and I can tell you today, I feel fulfilled. It was beautiful to try and have an opportunity for the faculty, for the jury members to try and interact with the budding talent, as well as identifying and looking for what exactly is the hallmark or what is required for being the next Sushruta. So I wanted to thank each one of the jury members firstly. But before I go to the jury members, I wanted to thank the doctor community and the surgeon community. India and the world has gone through a very, very serious crisis in the last 1 year. And it's because of the efforts of surgeons and doctors and healthcare professionals such as yourselves, working very, very hard. So it's not just the head of departments, but also the young residents and the students and all of you who've actually played a part in keeping India healthy and creating a path for us to come beyond the pandemic to a situation where we are in the vaccine situation right now. So firstly, thank you very much for your support and the hard work that you've done. It was not easy. It was extremely tiring. It was challenging, extremely challenging, but it's something that is that is really needs to be appreciated. Secondly, I'd like to thank the 1,500 participants who were there for this particular contest. And like all of you jury members said, it is now the onus is on us as Medtronic to make sure that we take this platform to the next possible level. Today it was 1,500. What stops us from the next year for it to be 5,000 and even more? And the right talent to try and get nurtured. Like Madan said, we are committed towards healthcare improvement and education in India. And it can only be shown by us continuing on this entire process and this entire journey that we've started. 2,500 people attended this event across different social platforms today, which is phenomenal. It's a Sunday, and it is the entire day that actually we spent talking some of the presentations that we did. To the jury members, Dr. Dalvi, Dr. Agarwal, Dr. Deo, Dr. Saklani, Dr. Khan, Dr. Sudhindran, I know we made you miss your lunch, and I assure you at some stage, I will be there and have a lunch and a dinner with you to really thank you from the bottom of my heart for the kind of passion that you showed and the commitment that you showed. It was tough all day. And then to the participants, we were doing an offline chat. That some of the presentations that were going on and the question you were doing, this reminded me of my Viva days in school and college where it was the tough questions being thrown at you. But for the participants, for you to be able to present and then to take those bouncers which are coming in, some of the leg spins, some of the off spin that was coming in, and really present their studies very well and defend it very well, that's something that is phenomenal. The winners, Dr. Usha, Dr. Sovi Paul, and Dr. Nitesh Kumar, my congratulations. And for the balance, 7 who also made it to the finalists, between me and Madan, we commit to the fact that we will support your growth and development as the process goes on. But for the 3 winners, it will be an opportunity for an international observership over 2 weeks. And having seen healthcare very closely, I know how important some of these exposure is going to be as the journey to become the big surgeon in the future kind of comes around. And this is where our commitment has to be there to really support that, not just for this particular educational initiative, but as your journey continues in the entire process. So wishing you all the very, very best there. Finally, for the organizing team, for Aman, for Nidhi, for the Docplexus team, for a lot of the people who are on the call right now, some of my sales team that have actually gone ahead and made the awareness of this campaign across medical colleges, across institutions, ensuring that we get the right minds to come together to a situation like this and create an event of this nature. It has required that kind of effort and passion. So thank you very much again from my side and from the behalf of Medtronic for the efforts that you've actually put in. Finally, I'd like to say that as Medtronic, our commitment towards education is rock steady. We are planning to scale up significantly in India. Under Madan's leadership, the plan is for Medtronic to actually have a significantly bigger footprint in India. And as we kind of embark in this journey to make Medtronic stronger, the whole platform can be based purely on working very closely with the healthcare community. And that's something that we would look forward to in the future as well. Wishing you all the very, very, very best for the future.
Wishing all the very best for the all the best. Thank you very much for the thank you very much for
for that address.
Here every day. Thank you.
Priyanka,
Yes.
you give a chance to talk to Usa.
Sorry.
You give a chance to Dr. Usa to speak some.
Yes, sure. Dr. Usha, I'd like to hear from you.
Yes, sir. Good evening, sir.
Go on. No, I thought she will share something.
He wants you to share your thoughts at this moment, Dr. Usha.
Yes, so I'm overwhelmed actually. I have no words. I'm feeling really happy and I thank the jury members. I'm very grateful to you all for my people. Thank you so much for giving me this opportunity. Thank you so much.
Thank you so much, Dr. Usha.
Thank you, ma'am.
So I think we can conclude the event here. If we don't have any further feedback.
Thank you all. Now, thank you.
Thank you so much.
Yeah. Yes.